one minute and we go, because Dr. Peacock already told the chairman that we have to be in time, okay? Okay.
Then you better give us the microphone on time.
Okay.
No problem.
We will do our best.
It can't be an hour later.
Ok, aspettiamo 30 secondi. E quindi mi ricordo all'epoca c'era sempre, poi quando il concetto poteva essere, visto i risultati della TLISE e la troponina I è più sensibile solo del mioscita, e se la T invece prende qualche altra parte, quello poteva essere, però è difficile collegare il danno morfologico col danno diciamo di morte. Comunque è molto bella quella cosa.
Volevo fare l'immunofluorescenza, vedere i livelli anche con la proteomics o con la proteomica o con altre tecniche per consolidare i dati che ho.
Ma voi siete ancora in confocale? Sì.
Sì,
Tutte
certo,
quelle belle immagini,
certo,
tutta la confocale.
con la colorizzazione dei marker, dell'etidio, della caspasi, con i cardiolacidi si fa.
Ok, cominciamo.
Sì, okay.
So, thank you for being here in time for starting the second day of the meeting. I have the privilege to chair this session with Anna Marsano from Basel. And we have this session, Young Expert on Stage. Majority of the young experts on stage will be from Czech Republic, but also we have people from France, and also we have a master lecture leader from South Africa, from Karen Sliva Hanle. So, without wasting time, I will ask Dr. Susanna Komorova from Czech Republic to come on the podium and give the talk on risk factor analysis of patients with cardiogenic shock in STEMI. Please, Susanna.
Good morning, ladies and gentlemen. Today, I would like to present you my presentation titled Risk Factor Analysis of Patients with Cardiogenic Shock in Acute ST Segment Elevation Myocardial Infarction Treated with Primary Angioplasty. Our department treats 250 and between 250 and 300 patients with ST segment elevation myocardial infarction STEMI every year. We analyzed a group of 270 patients with STEMI treated with primary coronary angioplasty between April 1st, 2018 and March 31st, 2019 in our cardio center. The aim of this work was to analyze a subgroup of cardiogenic shock patients, survivors and deceased, with acute STEMI treated at our department with PCI, and evaluate the difference between shock and non-shock patients with STEMI, and the influence of factors on mortality in a subgroup of cardiogenic shock patients. We have 270 patients with acute STEMI. We divided them into two big groups. First group, cardiogenic shock patients, 49 patients, and patients who were free of shock at admission, 221. In each of group, there were survivors and deceased. Here we have table with patient characteristic. In first column, we have a value of all groups. It means together cardiogenic shock and no-shock patients. And in second one, we have characteristic only of shock patients. Now I am going to talk only about cardiogenic shock patients. We can see that mean age was around 68 years. There were 31 men and 18 women. Culprit lesion, left main was culprit lesion in 4 cases, ramus interventricularis anterior in 19 cases, ramus circumflex 4 patients, arteria coronaria dextra 22. No one has no one has bypass or left intermediate as culprit lesion. 88% of them achieved post-PCI TIMI3, which means complete perfusion. Median of ischemic time was 163 minutes. 78% of them achieved complete revascularization. 1/3 was indicated to recoronarography. Every one of them was in cardiogenic shock at admission. 16 of them had ventricular fibrillation at admission, and then we can see echocardiographic parameters. Mean ejection fraction of left ventricle was around 40%, and other echocardiographic parameters. In personal history, 74% had hypertension, 1/3 had diabetes mellitus, 9 of them had known ischemic heart disease, 4 of them had stroke, 40%, 18 were current smokers, and more than half of them had a family history with cardiovascular event. Median of creatine kinase was 15. Median of troponin T was more than 3,000. Median of NT-proBNP was more than 1,800. Median of C-reactive protein was more than 100. Glomerular filtration rate mean was around 65. LDL cholesterol mean was around 3 millimole per liter, and more than half of them had hyperuricemia. Comparison of shock and non-shock patient with STEMI. Here we have again table with same parameters, and we compared cardiogenic shock patients with patients who were free of shock at admission. And we can see that statistically significant at the level 0.05 came out the following parameters. NT-proBNP, then glomerular filtration rate, C-reactive protein, hyperuricemia. It continues. Post-PCI TIMI-3, post-PCI TIMI flow defect versus 3, ischemic time, ventricular fibrillation at admission, and left ventricle ejection fraction. In the last part of my presentation, I'm going to talk about selective parameters and influence on survival in shock patients. We used univariate Cox regression models, and again table with same parameters, and we can see that statistically significant at the level 0.05, which means these parameters are associated with survival, came out age per each 10 years. Then stroke in personal history, glomerular filtration rate per 1 milliliter per minute, post-PCI TIMI flow defect versus 3, recoronarography, and left ventricular ejection fraction. We can see that LDL cholesterol came out with borderline significance, but not significant at the level 0.05. And we can also see that ischemic time is not associated with survival, because it's not that independent risk factor, but depends on a patient's condition. At the end, we can say that statistically significant differences between shock and non-shock patients were in the following parameters: left ventricle ejection fraction, natriuretic peptides, glomerular filtration rate, hyperuricemia, CRP, post-PCI TIMI-3, post-PCI TIMI flow defect versus 3, ischemic time, and ventricular fibrillation at admission. Influence on survival in cardiogenic shock patients. All these parameters are associated with survival. And as I said, LDL cholesterol came out with borderline significance, but not significant at the level 0.05, and ischemic time is not associated with survival because it's not an independent factor, but depends on patient's condition. The shock patients were at admission in more serious clinical condition. That's why they had shorter ischemic time.
Thank you so much, Susanna, also to be in time. So that's allow us to have 3 minutes discussion. I just would like to start asking You mentioned troponin. Is that high-sensitive troponin?
Yes,
Okay.
high sensitive troponin.
Because I was surprised was not really so much elevated. Please.
Hello, I want to ask you what exactly was the ischemic time in your presentation or in this sample of patients?
Ischemic time in minutes was time since symptom starts, chest pain, until a balloon insufflation in cath lab.
Any other question? Dr. Mazip?
Thank you for the presentation. You have a quite high proportion of patients with cardiogenic shock, nearly 20%. Did you analyze how many of them were in shock on admission or developed shock during the stay?
Every one of them was in shock admission, and we defined shock. They need catecholamine support, and because they had a systolic blood pressure lower than 90.
Probably you have a reference center that you receive more severe patients than
Yes,
standard,
yes,
probably.
yes.
Okay. Just another comment is that it seems that kidney makes a difference in your patients, right? That means that these patients had already some kidney involvement before STEMI, or was some ongoing damage of the kidney. What do you think?
Some of them already had chronic renal insufficiency, but some of them
Developed during the procedure,
exactly it get worse
Okay.
because of all condition.
Right? Okay. Thank you so much.
Thank you. Thank you, Susanna. So we are going with the next speaker, Maria Bokosova, please. And the title of her presentation is STFR as a marker of iron deficiency in heart failure.
Okay, thank you.
Thank you.
Yes. Okay. Good morning, dear chairman, dear colleagues. I would like to tell you something about the STFR as one of the markers of iron deficiency in patients with heart failure. Iron deficiency is a very common comorbidity in patients with heart failure, and it not have to be always expressed by anemia. In patients, even in non-anemic patients, it is the prevalence is up to 59%, and in the acute heart failure, it can be up to 80%. In the conditions of iron deficiency, the bioenergetic reserve is reduced in organs with very high need to energy supply, like heart muscle is. And it is connected with decreased capacity of more exercise capacity and low quality of life, and also connected with very high level of decompensations and for heart failure. In AST guidelines for diagnostic and treatment of heart failure, it is highly recommended to screen for iron deficiency in patients with heart failure. Not only to take a blood count, because anemia don't have to be the marker. In patients with heart failure, the iron deficiency is defined like ferritin under 100 or 100 up to 299 if the transferrin saturation is under 20%. But there can be the problem with diagnosis based on ferritin, because ferritin is also an acute phase protein, and heart failure is an inflammatory condition. But the thresholds for a diagnostic of iron deficiency is quite higher than in normal population. But the question is if the diagnosis based on ferritin is correct. In recent study, iron deficiency defined by the guideline definition was found to have a low specificity for the patients with reduced ejection fraction. In other recent study, mortality was lowest when the ferritin was under 100, and the saturation of transferrin was above 20%. So this can provide that ferritin-based diagnosis is burdened by inflammation, while low saturation of transferrin reflects iron deficiency in heart failure. So it can seem that saturation of transferrin can be a more accurate parameter to diagnose iron deficiency, and newly, the STFR molecule appears to be promising to this. It is a soluble transferrin receptor, which is a very sensitive marker of iron deficiency, and it means that it is expressed or increased in serum when the cells are hungry for iron, which can reflect the depletion of iron in body. And because STFR molecule, it is not so sensitive to inflammation, it can detect iron deficiency also in the inflammatory conditions. What we wanted to do is to find out the role of soluble transferrin receptor in the patients with heart failure, advanced heart failure. And we included 60 patients and with severe heart failure, and we divided into two groups, the patients with left ventricular assistance device and the patients without LVAD. And we measured iron metabolism like normally, but also measured saturation of soluble transferrin receptor. And we compared ID parameters established normally by guidelines with the STFR. Why we included LVAD patients? We just wanted to see if there's a difference between patients with LVAD and non-LVAD, because there are data that LVAD patients are more likely to have iron deficiency or anemia, but on the other hand, they also have higher conditions of inflammation. So let's take a look to the results. In the whole group, iron deficiency was prevalent in 55%. In patients without LVAD, it was 45%, and with LVAD, it was 68%. If we compare iron deficiency and non-iron deficiency patients, we can see that STFR was statistically significantly different in patients with and without iron deficiency compared with normal guideline parameters. And we can also see that iron deficiency don't have to be expressed by anemia. Just to note, there was no significant difference between LVAD and non-LVAD patients. According to our results, we can suggest that STFR can be a better parameter to diagnose iron deficiency in severe heart failure because, as you can see, only STFR didn't correlate with CRP and NT-proBNP. All other parameters of iron deficiency was correlating. So to illustrate, I have analysis of variances of CRP and NT-proBNP and New York Heart Association score status. And you can see that as higher CRP was, as higher the New York Heart Association status was, so higher the CRP was. And if we make a correlation between CRP and NT-proBNP, it was statistically significant. So let me conclude that there is a high prevalence of iron deficiency patients with advanced heart failure, and I want to emphasize that we have to actively search for these patients. Ferritin and saturation of transferrin can correlate with NT-proBNP and CRP, what could mean that this established diagnosis can be falsely negative in severe heart failure. Soluble transferrin receptor didn't correlate with NT-proBNP and CRP, so it seems to be a more accurate parameter to diagnose ID in patients with advanced heart failure, especially in the period of decompensation. And we can say that iron deficiency definition with low specificity can exclude patients from the administration of iron supplementation and the benefits of it. And thank you very much for your attention.
Thank you, Maria. The floor is open for discussion. Well, okay, perfect.
Hello, thank you. You've showed us that there was no difference between outcomes in LVAD patients and non-LVAD patients. What is your explanation of it?
This can be, thank you for the question, this can be a limitation of the study because I took iron metabolism to patients with LVAD who was ambulant, so they were stable, and the other parameters from the non-LVAD patients I had from hospitalizations, so they were decompensated. So this is my explanation.
I have also a question. Maybe, I don't know, can you go back to your slides where you make the conclusion that ferritin is not...
Could you please upload the slides again?
Or maybe you can just answer your question, you know, by heart. Because I think your population is quite small to make such a huge conclusion. So maybe, you have, with the ferritin, you have a p-value of 0.048, and with the transferrin, soluble transferrin, it's 0.05. So it's the question whether you're, can you comment on it? Are your findings, did you compare it to other research? Can you be sure that these conclusions are really valid? I was a bit, I should be a bit more careful maybe, because I know transferrin is also a negative acute phase protein, while ferritin is a positive acute phase protein. So I was a bit surprised about your conclusions. Can you maybe comment on it? Or do you have any idea from other researchers what they found?
Yes, thank you for the comment. Yes, I really did the research, and the soluble transferrin receptor is something what I looked for in my research, because the recent studies think it the same as me. So, and other parameter seems to be more precise is saturation of transferrin, like better than ferritin. And the soluble transferrin receptor is something new, so I want to do that. But it is a limitation of study that I have a small amount of patients.
Okay.
It's true.
Thank you so much, Maria. Sorry, we have to go ahead. And now, next speaker is Thomas Skokna from Czech Republic again, talking about the challenges in CPR in patients with left ventricular assistance device. Please, Thomas.
Good morning, ladies and gentlemen. I would like to present to you my case report of challenges in CPR in patients with left ventricle assist devices. So let me start right away with the case presentation. 72-year-old man with implanted LVAD for severe heart failure was admitted to our hospital because of urinary tract infection and acute kidney injury. On the physical examinations, there was nothing significant, maybe only that the patient has peripheral pulsation, which is not very common in patients with LVAD. On the ECG, there was alternating sinus and pace rhythm. In the labs, there was hyperkalemia, renal impairment, signs of infection, and anemia. And the urine was positive for bacteria. we did some imaging studies. There was nothing significant. We treated the patient with standard therapy, and on the therapy, the patient got better. He was stable on the ward, and now I want you to imagine that you are a young doctor, and you are called in the middle of the night because of the alarming LVAD. So as you walk to the ward, you try to remember or recall what the LVAD actually is, and you know that it's a pump that is connected to left ventricle. It has some cables, drive-like cable, controller, and batteries. And you remember that there is a special circulation in this patient. There is usually no peripheral pulse. The oxygen saturation is usually unobtainable, and the blood pressure is measured with Doppler probe. And there are some usual adverse events, the major infection, bleeding, device malfunction, and stroke. So as you arrive to the patient, you see that one nurse is performing chest compressions, the other one is connecting external defibrillator, and the LVAD is still alarming, and the nurse reports to you that they found an unresponsive patient with no palpable pulse, no breathing, so they started the CPR. And I want you to tell you in your head what is your immediate response to this. Would you stop compressions because you can dislocate the device and harm the patient, or you order to stop connecting external defibrillator because it's contraindicated in LVAD patients, or you continue with compressions, you secure airways and breathing and examine the LVAD, or you do something completely different. So while you are pondering upon the answers, I want to tell you what the experts say and what are the guidelines for resuscitation in LVAD patients. So you call the resuscitation team as the first thing, and then it's recommended to do not start chest compressions immediately. Remember, LVAD is a very capable device. It can maintain circulation even in very unstable situations like ventricular fibrillation. So the next step, if there is someone else, try to secure patient airways, try to treat problems with breathing, and attach ACG or defibrillator. And then next thing is to look at the LVAD. So with any electrical device, try to look at the batteries, try to look at the drive line, the cables, if they are connected. If there is low flow alarm, remember there can be a problem with hypervolemia or major bleeding. If there are high watt alarm, suspect the pump thrombosis. And if ECG shows ventricular arrhythmia, don't be afraid to use defibrillation since it's not contraindicated. The next step is to assess circulation. And remember that in LVAD patients, there are usually no pulsations, so you need to assess the circulation in different ways. So you need to use, for example, capillary refill, the cyanosis, or the look of the patient. You can try to measure blood pressure with the Doppler probe. You aim at the mean arterial pressure of 60 millimeters per mercury. If it's above, you likely have a normal perfusion. You listen to LVAD sounds. The LVAD sounds like a hum, so that's another thing you can look at. And if you think that the circulation is okay, you continue with ABCDE assessment, and you try to exclude stroke as the main priority. And if you think that the circulation is not adequate, you continue with standard CPR. And remember, echo is always a good option. So let's get back to the patient. We continued with chest compressions. We called the resuscitation team. We secured the airway. We ventilated the patient with a bag mask. The device was checked. There was low flow alarm. The cables and otherwise the controller seems to be fine. There was paced rhythm, so non-shockable. The patient was cyanotic. We tried to measure the blood pressure, but we failed. So we continued with CPR. We administered epinephrine, And after the resuscitation team arrival, the patient was intubated, and we had peripheral pulsations after another administration of epinephrine. And we examined the patient with bedside echocardiography. There was nothing significant, but on the physical examination, there was anisocoria, so we ordered head CT, and it showed a large intracranial hemorrhage of occipital lobe. The neurosurgery was not indicated, and we started palliative care. So I would like to conclude that the number of patients with LVAD is increasing, and we need to be prepared for these emergency situations. Remember that the care of these patients is very specific, so don't be afraid to call LVAD coordinator. We should be always on the phone. Remember special circulation, and remember if the resuscitation is happening, do not start compressions, chest compressions immediately. Try to secure ventilation and airways, check for the device malfunction, and if you think the circulation is impaired, don't be afraid to use standard CPR. And I thank you for your attention.
Thank you, Thomas. We have just a couple of minutes for discussion. Any question from the audience? I just would like to start. So your patient died because of brain hemorrhage or because of septic shock?
Because of brain hemorrhage, we think.
That's challenging because...
Yeah, it is, but I want to like to comment on it. It's just based off the low flow alarm, I think, because...
No, I understand.
And another thing is that the patient was like stable, his CRP markers and everything. He did not have fever, but yeah, it could be that the patient had septic shock. Yeah, sure.
That's my opinion. I mean, at the end, hemorrhage in these patients you can really have as a consequence, but you cannot die for hemorrhage. I think he's died because it was a very severe septic shock.
Okay,
that's
it could
my
be.
opinion.
It could be.
Any other question?
If there are not, we can move on.
Okay, let's move on. Thank you very much,
Thank
Thomas.
So I would like to invite the next speaker, Karolina Motilova, on the stage. And the title of her talk is Interplay of Biventricular Arrhythmogenic Cardiomyopathy and Myocarditis. Thank you.
So, good morning, ladies and gentlemen. It's my great pleasure to present you about a recent case from our department. This case report is about a 15-year-old patient with no significant past medical history. He's an active athlete, a hockey player actually, and last year in winter he had an EBV infection. After that he was fully recovered, and then the same year in summer he had 2 viral infections. A month later,
You suffer too much.
Thank you. A month later, 2 days after hockey training, occurred dyspnea and weakness, but with no fever or cough. And he was administered in a local emergency room where the echocardiogram was performed with severe left ventricular dysfunction with ejection fraction of 15%. Then he was transferred to our department where on admission there were signs of acute heart failure, NYHA class 3 to 4, ventricular tachyarrhythmias, hypotension, and lung crickles, peripheral edema, and mild ascites. So the initial therapy for this was inotropes, furosemide, and amiodarone. In labs there was CRP 17, so there was like mild elevation of inflammatory markers, mild elevation of TNT, and in serology there was positivity for IgM and IgG antibodies for borreliosis and EBV. So then, after stabilization, the therapy, we started with the therapy of heart failure and also with antibiotics for the borreliosis. So now let's take a look on the findings on admission. So first there's an ECG where we can see that there's normal sinus rhythm with heart rate 80 beats per minute. Then we did the echocardiography where we can see that there's severe dilatation of left ventricle and of right ventricle with severe dysfunction. Also, there's mitral and tricuspid insufficiency, second grade of mitral insufficiency. And then we did the cardiac magnetic resonance, where I would like you to notice this ring-like structure, which is the subepicardial late gadolinium enhancement. So after this finding, we take a look at the ECG again, and then we notice that there's this epsilon wave in right precordial leads, and also that there are inverted T waves in left precordial leads. So our first conclusion was that this is fulminant phase of myocarditis. So according to guidelines, we did endomyocardial biopsy, where we could see these white regions of fatty tissue, also this fibrous tissue replacement, and also there was a presence of significant inflammatory infiltration. On a side note, I would like to note that PCR from myocardium was negative for all cardiotropic viruses and borreliosis. So this is just the summary of our findings. And then we did also the genetic testing. So there was found a presence of two mutations for genes encoding desmosome proteins. And the first one he inherited from his father, and the second one, the likely pathogenic desmoplakin, he inherited from his mother. So our final conclusion, based on those findings and based on PEDUA criteria and the presence of significant inflammatory infiltration, is that this is a hot phase of biventricular arrhythmogenic cardiomyopathy, which basically means that there is a myocarditis-like episodes in patients with ACM. And for the treatment, we continued with the guideline-directed medical therapy for heart failure. We did the ICD implantation, and because it was virus-negative lymphocytic myocarditis, we started with immunosuppressive therapy. Then there is a follow-up from March 2023, where the patient is clinically stable. There are no crackles, no peripheral edema. The NT-proBNP is lower. Then on ICD checkup, there were 0 shocks, and what's important that the left ventricle ejection fraction improved to 40%. Also, in case of worsening condition, there was examination for heart transplantation performed, and patient was put on a waiting list for heart transplantation. So, as a conclusion, I would like to say that this is a clinical case that shows a 15-year-old patient carrying DSP mutation, which led to biventricular type of ACM. Also, it documents myocarditis-like episodes, which are called hot phases, and it's myocardial injury accompanied by ECG changes and cardiac biomarkers. So these hot phases can be also the initial presentation of ACM. And what's most important, that the combination of heart failure therapy and immunosuppressive therapy led to improved heart function in our patient. But evidence supporting tailored risk factors, clinical decision-making, and target therapy in patients with hot phase episodes in ACM is currently lacking. Thank you for your attention.
Thank you, Carolina. So the floor is open for discussion. There are any questions from the audience? Yeah, thank you.
You have had, thank you for a great presentation, Carolina. You had in bracelets the VOS after plakophilin. What does it really mean?
That means that it's a variant of unknown significance. There is a mutation, but we don't know its significance to the organism.
Thank you.
Thank you. If there are no any urgent question, I would move on with the next speaker. Thank you.
Thank you so much.
Thank you.
Next speaker is Karel Lab from Czech Republic again. Prognosis in stable heart failure in relationship to NGAL and NT-proBNP. Please, Karel.
So, dear Chairman, ladies and gentlemen, first of all, I want to excuse Professor Špinarová and Professor Špinar. They were very sad that they aren't able to come in here to this meeting, to this great meeting. And my topic is the prognosis in heart failure and in relations to NGAL and NT-proBNP. We focus on our registry, which is called PHAR-NHL, Pharmacology and Neurohumoral Activation, and from the registry of chronic heart failure with patients with lower ejection fraction than 50%. They should be at least 1 month stable. And there were included patients in 3 cardiological centers in Czech Republic, in Brno and Prague. This is our flag of Czech Republic. And as well, other institutes from Masaryk University, like biostatistics or lab samples, were processed in these departments. From 1,100 patients that were included into the whole registry, we excluded patients without available follow-up data, and then without available samples of creatinine, NGAL, or NT-proBNP, and we've got 547 patients. And then we look for the follow-up. The primary endpoint of this study was all-cause death combined with left ventricle assisted device implantation or autotopic heart transplant. And this primary endpoint was present in 13.5% of patients. When we focus only on all-cause death, it was present in 11% of patients, and new heart or the new pump get 2.6% of patients. What is NGAL? NGAL is neutrophil gelatinase associated lipocalin. It's protein. And its expression is upregulated. That means it's higher when is present acute kidney injury, inflammation, ischemia, or infection. And it's not only renal parameter, it doesn't predict only mortality, but as well it is the overall marker for the level of severity of, in general, cardiovascular disease. Let's focus on baseline characteristics. In our registry, there were 80% of men, age approximately 62 years old. Half of patients were with ischemic etiology, 40% dilated cardiomyopathy. Almost 2/3 of patients were NIHA class 2, and the average ejection fraction of left ventricle was 35. And here's the table with association of NGAL. And as we've said, the level of NGAL is higher when the patient is more severe. And so it was statistically significantly higher when the patient was older than when the patient has atrial fibrillation or stimulated rhythm, was higher when the etiology was ischemic of heart failure, definitely was associated with NIHA state. And in heart failure, we know there is a blood pressure paradox that higher is better because we can titrate medication, and so this association was shown in here as well. So when lower blood pressure was present, the NGAL was as well higher. Here we have laboratory parameters associated with NGAL. NGAL was primarily like renal parameter, so it's obvious that it's higher when urea or creatinine is higher, and as well it's associated with creatinine clearance, but it's as well higher when the albumin or hemoglobin is lower, and as well it's associated higher NT-proBNP and higher NGAL levels. Here we have distribution of NGAL and NT-proBNP. NT-proBNP is in here, and there was statistically significant difference between patients with no endpoint and with present endpoints, and of course patients who were more severe were with higher NT-proBNP, and there was statistical significance of NGAL in both these groups. As we can see, the area under the curve of NGAL is very low. It's only 0.6. But from this receiver operating characteristic curve, we took the cutoff value, and then we've divided the patients into two groups, and you can see, according to the cutoff value of 90 nanograms per milliliter, there is significant difference between survival of patients without primary endpoints, and it is almost 20% of difference. This is graph as well, survival without primary endpoints, but to the NGAL we've added NT-proBNP. And here we have the best survival, 90%, when NGAL and NT-proBNP obviously were lower than cutoff value. Then the worst survival was the opposite. That means NGAL and NT-proBNP was higher than cutoff value, and in the middle there are two curves that one of them is higher and one lower, and you can see that between those middle curves there was no statistical difference. So maybe it is the same that one of them is higher and one lower. We can, from this graph, from chronic heart failure, we can compare with another registry which gives us very similar graph, and I can see here the author, the Alan Meisel, who was here a few years ago, and his registry, Gallant, of acute heart failure, and the colors you can see is almost the same, only in acute heart failure, so very similar graph. Let me conclude. NGAL has an independently very poor ability to predict our outcome, like death, hospitalization, LVAD, or orthotopic heart transplant. In conjunction with NT-proBNP, identifies patients at risk for heart failure, but in heart failure, definitely NT-proBNP is very and most important for prognosis setting. NGAL is not only a renal parameter, but its values are elevated in other comorbidities. And as we've shown, the paradox of high blood pressure was confirmed. Thank you.
Thank you so much, Karel. Now we can open the discussion. In the meantime, people are thinking for a question. I have a simple question for you. Which is the additional value from your data of NGAL to creatinine? Because at the end of the day, you say that there is a linear relationship between creatinine and NGAL, and then you say that NGAL was an independent predictor of mortality compared to creatinine. But I am thinking that if you are inserting NGAL and compared to creatinine, did you make this difference? How NGAL is performing better than creatinine?
When you take creatinine, its level is in blood with 1 or 2 day latence. That means their values are higher after 1 or 2 days after injury of kidneys. But the NGAL is very, very acute marker, so you can maybe monitor by NGAL the acute injury of kidneys. So
okay, I was just wondering about the prognostic value. I understand the AKI role of NGAL. Any other question from the floor? Okay, because another issue is that, Frank, you were making any question? So just another issue is, we're finished. You are perfect in time. The only question is that you should probably look about the false positive value of NGAL in the patients having chronic disease. Like we recently published the big meta-analysis. So there is a challenging on the NGAL that still should be addressed. But this is out of your presentation. Thank you very much.
thank you.
Thank you. The next speaker is coming from France, and Manon Duran, and his presentation is titled presentation is Reorganization of Resident Macrophages and Recruited Monocytes in the Heart During Sepsis.
Hello. Today I will talk about the reorganization of resident macrophages and recruited monocytes in heart and kidney during sepsis. So first, a simple definition of sepsis. Sepsis is an inappropriate host response to infection leading to organ dysfunction, and in some cases to death. A recent study estimates that 1 person dies of sepsis every 3.5 seconds worldwide. And the survivor of sepsis have another risk of cancer, infectious disease, chronic kidney disease, and cardiovascular disease. But these long-term consequences are poorly studied. Our hypothesis is that the changes in intra-organ immune homeostasis could be in part responsible of the long-term consequences of sepsis. So the objective of our study is to characterize the changes in number and phenotype of resident macrophages and recruited monocytes in a mouse model of sepsis, to evaluate the cardiac function after a second hit post-sepsis, and to analyze the phenotypic changes and the spatial localization of the different macrophages subtypes after a sepsis. So we use the most common model of sepsis, which is a sickle ligation and puncture model, inducing a polymicrobial sepsis. And it's characterized by a weight loss of about 50% and a mortality about 20%. In terms of cardiac function, we saw at day 1 after sepsis a decrease of the fractional shortening, which increased after without returning to the basal state. And for the kidney function, we can see an increase in the plasma creatinine at day 1. And if we look at the fibrosis 14 days after the CLP, we see an increase in fibrosis in septic mice. In their mice, we use the flow cytometry to describe 3 subtypes of macrophages. We use the nomenclature of Dick et al., who describes 3 different subtypes, the TLF macrophages, the MHC2 macrophages, which are resident macrophages, and the recruiting monocytes, which are CCR2 cells. If we look at in the heart, you can see an increase of recruiting monocytes, of the percentage of recruiting monocytes, and a decrease in TLF resident macrophages. But if we look at the number of cells in the heart, you can see an increase in recruiting monocytes, but also an increase of the number of resident macrophages. For the kidney having heart, you can see an increase of recruiting monocytes after sepsis. And in terms of number of cells, we saw an increase in MHC2 subtypes and CCR2 subtypes. So this figure shows us 2 things. The first one is that sepsis induces an increase in number of resident macrophages in the organs, and that in 41 days after sepsis, the homeostasis is not restored. In a second time, we want to look at the resistance of septic mice to a second hit. So we designed a model of 2-hit model of sepsis. And 14 days after the CLP, we infuse angiotensin II for 28 days to mimic the most common cardiovascular risk factor, which is hypertension. And if we look at the survival of these animals, we can see that having a sepsis before angiotensin infusion induces an increase of the mortality in these mice. Concerning the heart function, we can see that angiotensin II infusion induces an increase of cardiac hypertrophy and a decrease of the fractional shortening without difference between the sham group and the septic group. But if we look at the cardiac fibrosis 28 days after the angiotensin II infusion, you can see an increase in the fibrosis for the mice having a sepsis before angiotensin. So it shows the long-term consequences of sepsis in the heart. So to conclude, we describe the evolution of tissue macrophages and variations in the 3 described subsets of macrophages in the heart and kidney after sepsis, and we demonstrated that animals who survive sepsis are more sensitive to a second injury. And to continue this project, we are doing a single-cell RNA-seq of myeloid cells from heart and kidney of septic mice, and in parallel we are doing spatial transcriptomic in order to visualize where are the macrophages in the kidney and the heart. So maybe I will present you this result next year. Thank you.
Thank you so much. So there are any questions from the audience? If not, well, I was curious if you checked other inflammatory cells presence in the heart during the damage?
At the moment,
Like-
no.
No, okay. And are you planning to do it?
We have, with the flow cytometry, no, but we have the tissue for all these animals, and we want to test something with the PCR.
And another question about the sequencing of the cells that you are planning to do. You will do a bulk analysis or a single cell analysis?
Single cell analysis.
Single
yes.
cell. And are you planning to normalize this data in some way to better understand the two conditions? You know,
Can you repeat?
just how you would compare then the single cell RNA analysis from the two experimental groups by, you might have different results if you have more cells in one condition than in the other.
We did it with CLP mice and sham mice, and we will compare the two groups.
Okay. Thank you.
Thank you.
Thank you.
Okay, now I have the privilege to introduce a lecture by remote from Professor Karen Sliva Hanle from South Africa. She's connected. Oh, hi, Karen. How are you?
Hello, hi.
Are you in South Africa now?
Yes. Unfortunately, I can't be with you in Berlin. I was in Berlin 2 weeks ago, but I just can't fly down 9,000 kilometers again to be part of the great meeting. But so that's why I'm here now. Yes.
Thank you to be with us today. Professor Karen Sliva Hanle is going to talk about risk stratification in women at risk for peripartum heart failure. Please, Karen.
Thank you. So just imagine you're all in Berlin, I know, and you are a doctor at the Charité, which is not far from you. I'm actually from Berlin, I know. And you're seeing a pregnant woman who is 20 weeks pregnant, and she's from South Africa, and she is visiting her sister in Berlin, and she presents with shortness of breath. So she's still allowed to fly because she's still not only 20 weeks pregnant. So where do you start? So you have never seen the patient. So what can be your approach? So the patient can have a known pre-existing heart disease, such as congenital heart disease, Marfan's cardiomyopathy, rheumatic heart disease, which we have a lot in South Africa, valve prosthesis when she was operated. She can be presenting with a newly diagnosed heart disease unmasked by the pregnancy. So for instance, she could have familial cardiomyopathy, which was not diagnosed, previously undiagnosed rheumatic heart disease, undiagnosed congenital heart disease. But she could also, technically, but she's not far ahead with her pregnancy, have a newly developed heart disease such as peripartum cardiomyopathy, which presents more like a last week of pregnancy or postpartum. She can have acute coronary syndrome or pre-existing ischemic heart disease, which we see more and more common, gestational hypertension, preeclampsia, or severe hypertension. Does it matter where the patient comes from? Yes, it does. So in higher income countries, you have now an increased maternal age for the first pregnancy, and that is linked to pre-existing hypertension, obesity, as I mentioned already, pre-existing coronary heart disease. If you come from lower income countries, which for instance is South Africa, you can have, as I mentioned, rheumatic heart disease. When you're from South America, there are clearly women who have Chagas cardiomyopathy. You have also commonly unoperated congenital heart disease, which only presents with symptoms and signs in pregnancy. And in all other regions, you need to be aware that there's an increase in the diagnosis of cancer-induced cardiomyopathy. So the pregnancy with this increased load is unmasking pre-existing heart disease. So if someone had a cancer and was treated childhood, let's say for leukemia, they can have left ventricular dysfunction and present then in pregnancy with heart failure. They can have rarer condition as left ventricular non-compaction cardiomyopathy and others. So I want to show you how to risk stratify those women and why is it important. So there are several classifications, but there is a modified World Health Organization classification, which is most commonly used, and also has a best value of risk prediction. So I'm just showing you this one. So you can see here, so if you have a WHO1 classifications. This is, for instance, I didn't put it on a slide. If you have operated atrial septal defects, you're fine, small defect in your heart is closed, you're not on symptoms. This is, for instance, someone who has WHO group 1. WHO group 2, so you can see the maternal cardiac event rate, which includes hospitalization, severe arrhythmias, possibly death, is 5 to 10%. So in that group, you have unoperated ASD, ventricular septum defect, repaired congenital heart disease like a repaired tetralogy of Fallot, most arrhythmias, when you have mild left ventricular impairment, a genetic condition like hypertrophic cardiomyopathy, native, that means non-operated or tissue valvular heart disease, and Marfan syndrome without dilatation of your aorta, which is less than 45 millimeter, and repaired another congenital heart disease coarctation. So WHO group 3, you can see the maternal cardiac event rate is already around 20 to 27%. So it's relatively common, 1/3 of the patient. Everyone with a mechanical valve. Then you have this genetic disorder like systemic right ventricular Fontan circulation, cyanotic heart disease, other complex congenital heart disease, or when you have Marfan with a more dilated aorta. 4 is important to remember because the maternal cardiac event rate is 40 to 100%. This is where pregnancy is actually contraindicated. It's any pulmonary artery hypertension, severe left ventricular dysfunction, so ejection fraction less than 30%. Anyone with a previous peripartum cardiomyopathy, residual left ventricular function, severe rheumatic heart disease, so that's severe mitral stenosis, severe symptomatic aortic stenosis, and other conditions. So the most important thing is the preconception evaluation. So as I've told you, our patients, the one who arrives at the Charité, didn't have that. So, but ideally, in most scenarios, the patient do know that they have a heart problem. And it's important that even when young couples, young women visit their cardiologists, their physicians, that the aspect of pregnancy is discussed. And why is it so important? First is you need to risk stratify. I told you about this classification. So you need to, the patient, I mean, it's not a patient at that stage. The woman and the partner need to understand what it means to have a pregnancy. So the risk stratification, you need to do an ECG, an echocardiogram, an exercise test. And then you need to really spend time with careful counseling, which includes the maternal risk for complications that showed you already. And then, but also choices of treatment, which do have effect on the risk of miscarriage, the risk for early delivery, the risk for small for gestation. So there are long-term implications for the babies of women born with congenital heart disease. And it's also important to understand for the partner of that woman. So if that woman, for instance, had a stroke or dies, it means that you're left alone with the baby. And that is something which really carefully people need to understand before they plan, for instance, the number of pregnancy or go ahead for contraindicated pregnancies. So what's a practical approach? So first we need to know, does the patient is known to have a heart disease? So is no, then you need to follow a diagnostic algorithm. I showed that just now. Yes, you managed underlying according to the condition the patient has. Very important to understand if there are comorbidities, aggravating factors. Then if the patient isn't heart failure, like our patient, you need to understand the weeks of gestation. If it's more than, if it's less than 60 weeks, it's a question you need to discuss if it's If the pregnancy is desired, if there is severe heart failure, one should really in early pregnancy think about termination. It's a very high risk to continue. And if it's more than 60 weeks, let's say someone is 26 weeks, you usually try to stabilize the patient, think about early delivery and other specific aspects. There are actually dedicated papers from the ROPAC registry on pregnant women with uncorrected congenital heart disease who really go into much detail about all those different scenarios of complex congenital heart disease, the risk for the women, the stroke risk. There's also a paper on pulmonary hypertension and pregnancy outcome. I can just tell you, if you have pulmonary arterial hypertension, the risk to die is 50%. So it's a high risk condition, and other options to have children like adoption should be really considered for those families. Then if your patient has rheumatic heart disease like our patient, you think about medical therapy. So it depends. I don't have time in 10 minutes to go into all the different options, but there is ways how you stabilize the patient with medical therapy. If for instance, atrial fibrillation, fast heart rate, if there is mitral balloon valvotomy, if the mitral valve is tight, if there is, if you have then other conditions like congenital heart disease, it's often too important to do more imaging to understand the complexity of the congenital heart disease better, and if it's to decide how to stabilize the patient. This sounds all very overwhelming, and it's really a complex area, but there is very detailed reference work. There is a paper which I don't show you now. It's from the ESC from 2018, the guidelines on heart disease and pregnancy altogether. It's 80 pages. It's free to download online, and you find really information on the specific conditions. There's also a more recent paper on risk stratification and management of women with cardiomyopathy, heart failure, who have heart failure like our patient, planning a pregnancy or presenting during or after pregnancy. And that's a position statement of the Heart Failure Association of the European Society of Cardiology study group on PPCM, which also goes through not only the diagnostic pathway, but also the management. This is my last slide. So what is also important, so you have the WHO criteria, the risk stratification, but don't forget the more general factors. So there is, for instance, the maternal health factor, late presentation, more than 20 weeks, detrimental when they only come for the first assessment, 20 weeks. If they have pre-existing heart failure, atrial fibrillation, it's reported that they have clearly a worse prognosis. Anemia, important, contributes to heart failure. Important to understand if you have the health system factor, if you have unskilled healthcare workers, lack of tools to make an early diagnosis, inappropriate referral algorithm, so the patient comes very late to you. Long distance to appropriate care is clearly a predictor of poor outcome, or it's a factor to consider if you plan a pregnancy. Then you have the maternal socioeconomic factors, if the woman is very young or older, poor maternal education, low household income, and poor access to appropriate care. So just to end my presentation, so this woman who came to the Charité, that she had rheumatic heart disease, she had mild mitral stenosis and atrial fibrillation, so with some digoxin and a beta blocker, you can slow the heart rate, and then the patient is stable enough to return to South Africa and give birth here in my hospital. So in conclusion, each woman with substantial heart disease and pregnancy is unique. The effect on the mother and the fetus need to be balanced and discussed with the entire broader range of family and support care system like parents or friends. A multidisciplinary approach, including the cardiologist, obstetrician, anesthetist, the cardiothoracic surgeons, and others, should be put together for a tertiary center and be consulted. and understanding the precursors of preventing heart failure pregnancy will have the highest impact. With that, I thank you.
Thank you. Thank you to you, Karen. There's been really a very clear, comprehensive, let's say, vision of what we really need to do for these women. Alex Mebaz, of course, cannot take, don't want to miss the opportunity to talk with you. Alex.
Thank you, Karen, for this great presentation. I mean, you're indeed one of the world experts. In the great network, we love biomarkers. And you didn't mention so much biomarkers. Can you give few clues for the people in the room who may have those patients coming? If you can give maybe 2 or 3 tweaks. For instance, there are many people saying, oh, during pregnancy, the biomarkers can go very high, etc. And you showed many times it's not true. Yeah, can you give us 1 or 2 tricks, please? And again, thank you for being with us.
Yes, it's a pleasure, Alex. So there is actually very good data of the usefulness of anti-proBNP or BNP. And there is a study which was presented by Dr. Charles Viljoen. He is part of our team here at the ESC Heart Failure meeting in Prague. So the paper is unfortunately not yet published. But he evaluated anti-proBNP as a screening tool exactly for the patient which I've described. And there are some older information which thought that anti-proBNP is not useful in pregnancy, but this is wrong. There is a slight increase of, let's say, 5% while you are pregnant. But I mean, if you have proper evaluated values, it's a clear indication that the patient has heart failure or left ventricular dysfunction. So it's a very useful screening tool if you, to find out if the patient has heart failure, needs to be referred to a center where they can do cardiac ultrasound and other tools to work up the patient. Then obviously, I mean, the classical biomarkers which you use for other conditions like the troponins, are working exactly the same in patients who have ischemic heart disease. And as I mentioned here, I'm not sure how it's in other parts of the world, but in Cape Town, unfortunately, due to the strong smoking history of many women, obesity, poor access to good nutritional options, we see really many women in the early mid-30s who have already diagnosed ischemic heart disease and are coming pregnant. So if they present with chest pain, you really have to respond quickly, use the same markers as you would do in a non-pregnant patient. The markers are working equally well.
If there are no other questions from the floor, thank you so much again, Karen. We hope that next year you will be with us in presence, okay? Have a good rest of the day.
I try to time my travel better next year. Thank you very much.
Ciao, Karen. Thank you. Now, I have to remark that we are giving the podium to the next chairman in perfect time. I hope you are able to do the same, right? Because I'm controlling you.
I think, Anna, if you can offer a watch to Salvatore, because he needs a Swiss watch. You gave us the floor with 2 minutes delay. As soon as the Professor Salvatore Di Somma stops speaking with and he's making our life miserable. Thank you very much. I mean, the first session was just great, and we need to do better. Josep, and it's my pleasure to chair this session with Josep Massip. And Josep, you're going to introduce the people. I know no one of them. Apparently, they are French. I don't know.
Yes.
Let's manage them.
Of course. The first speaker will be Adela Fudahili from France. She will present early mobilization of subarachnoid hemorrhage patients admitted to ICU, impact on functional outcome.
So, hello everyone. I will talk today about the mobilization of patients with subarachnoid hemorrhage. And just to precise, I'm a French physiotherapist and PhD student. So, to begin with, subarachnoid hemorrhage is a subtype of hemorrhagic stroke, and its management requires a close monitoring in ICU units or neurological ward, to prevent and treat neurological complications such as hydrocephalus, intracranial hypertension, and cerebral arterial vasospasm. Patients with subarachnoid hemorrhage are left with multiple sequelae, and at 1 year, as you can see, patients still report an altered quality of life, and 1 out of 5 patients is still dependent. In the general ICU population, early mobilization has shown multiple benefits on, among other things, quality of life and independence. However, for our subarachnoid hemorrhage patients, there are no recommendations to date regarding early mobilization because there is only 1 randomized controlled study of poor quality. There are also still some safety concerns, and there are some fears that mobilization could induce hemodynamic changes that would be deleterious for the brain perfusion. So consequently, bed rest is often prescribed for several weeks, but its necessity has not been proven, while there are multiple complications of prolonged bed rest. In the light of all these elements, we wondered about the impact of early out-of-bed mobilization on the functional independence of our patients. To answer this question, we performed a retrospective study in our neurosurgical ICU, and we included adult patients with subarachnoid hemorrhage of aneurysmal origin during a 2-year period. We split our population into 2 groups, patients who were mobilized early, before day 5, and patients who were not mobilized early. They constituted the EOM and DOM group. The first out-of-bed mobilization was considered as the first time patients was taken out of bed by standing or by means of a lift. And we assessed the impact of early out-of-bed mobilization on 3 months functional independence and cerebral vasospasm occurrence. Regarding the procedure of the unit, on the medical plan, patients are managed according to international guidelines and local procedure, while for the mobilization practices, we don't have a protocol at the moment, and patients are mobilized under medical prescription by physiotherapists and nurses every weekday, following a close monitoring. So out of the 236 eligible patients with SAH, we were able to include 179. And as you can see, the characteristics of our populations were representative of the population described in the literature in terms of age, sex ratio, and severity of SAH. Of importance, in our early mobilization group, you can see that patients were less severe, and they were more precociously extubated, and they had less external ventricular derivation. Now for our results. So regarding 3 months functional independence, patients who were mobilized early were more likely to be dependent than patients who were not. And as you saw earlier, there were differences between our 2 groups, so we performed a multivariate analysis taking into account the severity of SAH, as it's the most important predictor of independence. And you can see here that early mobilization was still associated with functional independence, independently of the severity of SAH. Now, regarding cerebral vasospasm, you can see that patients who were mobilized early did not experience more vasospasm than patients who were not, and there were even a tendency for less vasospasm, but it was not statistically significant. We also looked at the impact of the delay between subarachnoid hemorrhage onset and the first mobilization, out-of-bed mobilization. And you can see here that the earlier the first out-of-band mobilization, the higher the odds of 3 months functional independence. Inversely, the later the first out-of-band mobilization, the higher the probability of vasospasm. So this result suggests that early mobilization could be beneficial, but we have to keep in mind that it was a retrospective study. I showed you some bias, and it was a small sample size. However, our results are still in line with the previous observational studies that suggested safety and benefits of early mobilization, and we are now working on a randomized controlled trial to confirm these results. Thank you very much.
Thank you for your presentation. There is time for questions. If not, were comparable the two groups, with, early mobilization and late mobilization in terms of general conditions? Did you perform a matched analysis or
So yes, when we tried to submit our article, reviewers asked for a propensity match analysis, but there was only a few patients that could be matched because, as you can see in the early mobilization group, there were only 31 patients. So the results were not very interpretable.
And can you elaborate? Yes, question from Brazil. Are you getting those kind of patients in your emergency room?
Okay. I better not to make my question.
No, you do.
No, I don't have in our emergency room, but there are several patients who are in the central ED. And I think your results were very interesting. Although there was no difference in the statistical, from 48 to 36 is very important for an individual patient. And maybe this should be analyzed in a different way, because any small improvement in this kind of patients is very important.
Yes, this is why we are going to do further studies, because with this basis of results, we can't do another analysis to show that there are less vasospasm, but there are a few studies that show that the earlier the mobilization, the risk of vasospasm is reduced. But today there is just only one randomized control trial, so we need to work harder.
No, the reason why I ask you the question is because those patients, we published many years ago, measuring biomarkers in those patients, catecholamine level is very, very high. And in fact, you end up, even before they start for a neurological problem, they have a lot of cardiovascular issue, mostly cardiac, related to this catecholamine release. Then you may see this kind of patient coming and then going back home, and in fact, they have a neurological problem. Then it's, I think maybe it's one of the topic of the next years is the brain cardiac interactions with the biomarkers. Okay, thank you very much. You are going to see that in France there is an invasion of Japanese promising fellows, and Ayu is going to come. Ayu Azakage. The associations between PaO2 level and mortality in severely ill patients. Thank you, Ayu. And Ayu should tell us whether it's a German beer or not.
Okay, hello everyone. Guten Morgen. I'm Ayu Asakage, currently a researcher of INSERM in France and an emergency doctor in Japan. So, ich komme aus Japan. So, I'd like to thank you for giving me the chance to speak here today at the end of my research journey in Europe. And thank you to Professor Mevatsa and Dr. Dunio for mentoring me. So now my presentation is the association between PaO2 levels and mortality in severely ill patients. While the oxygen is essential for the maintenance of biological functions, it has also been noted to be toxic. FiO2 and PaO2 have been shown to exert the toxicity through different mechanisms, and especially in the patient who admitted to the ICU often receive supplemental oxygen with high FiO2, leading to high PaO2. However, clinical practice guidelines give no recommendation for oxidation targets in adult patients in the ICU due to lack of evidence. So recently, extremely high PaO2 was reported that's more harmful with the U-shaped curve. And it was also reported that the too high PaO2 levels did not improve patient outcome. And in a research comparing high and low FiO2, there is no significant difference in 6 months mortality nor biomarker concentrations. So our current studies was designed to examine the toxicity of PaO2 and FiO2 in the entire ICU patient population. And it's based on the FROG ICU cohort, multi-center prospective observational studies, and we set the primary outcome as 28-day all-cause mortality and secondary outcome as 90-day all-cause mortality. And we analyzed these 3 inflammatory biomarkers, IL-6, adrenomyosin, and DPP3, to determine the relationship between oxygen and inflammation leading to the tissue damage. So these are the survival curves for 28-day and 90-day all-cause mortality. And we divided the patient in 2 groups using the mean values of PaO2 or FiO2 during first 3 days. And the hyperoxemia group had a lower hazard ratio than normal oxemia for both 28-day and 90-day all-cause mortality. On the other hand, high FiO2 had high hazard ratio than low FiO2 for just 90-day all-cause mortality. To add information on the tissue damage by PaO2 or FiO2 through inflammation, we verified that the correlation of PaO2 and FiO2 with these 3 inflammatory biomarkers, IL-6, adrenomyosin, and DPP3. Overall, they negatively correlated with PaO2, while positively correlated FiO2. However, all of these correlations were significant but very weak. So our current analysis has demonstrated that hyperoxemia had lower mortality than normal oxemia, and high FiO2 had higher 90-day mortality than low FiO2. Concerning first point, it is possible that normal oxemia had more severe condition than hyperoxemia, therefore PaO2 remained lower, Because in FROG ICU, the patient were not initially assigned to normal oxemia or hyperoxemia. I mean that it's not strategy, it's just only the result of treatment or their status. So the mortality risk might be lower in hyperoxemia than in normal oxemia. Secondly, with these 2 findings, we might estimate that high PaO2 leads to worse outcome by being more likely to cause inflammation than high PaO2. Additionally, it is also supportive that inflammatory biomarkers were negatively correlated with PaO2, whereas positively correlated with FiO2. In conclusion, our study shows that hyperoxemia had a lower mortality than normoxemia in the entire ICU population, and high FiO2 levels were shown to be potentially more harmful than high PaO2 levels. But anyway, further RCT studies are required to determine the relationship between oxygen and patient's outcome. So thank you for your attention. Dankeschön.
Thank you, Ayu, for your presentation. Before some questions come from I would like to ask you, how many patients did you include in the series?
About 942 patients.
Yes. And then perhaps an explanation may be just so simple. Patients who need higher FiO2 are more sicker, are sicker than other patients, reflecting that they have worse respiratory function. And the opposite, patients that are more sensitive for oxygen to have hyperoxemia, perhaps are reflecting they are in a better pulmonary function. It would be an explanation.
Yes, it is biggest our limitation. So to compare them, as I mentioned in the presentation, it is just only result of treatment, the possibility of result of treatments. It's not strategy. So yes, it is very good or big limitation. Yes, sir.
Thank you, Ayu. I mean, the question is a bit along the same. The same question is: have you tried to look at patients with high FiO2, high normoxia, high FiO2, hyperoxia, low FiO2? I mean, normal FiO2. I mean, to split the patient into 4 groups based on FiO2 and PaO2 at the same time.
I'm sorry.
Do you want it in French?
Yeah, I think it gives ideas for you to analyze PaO2 and FiO2 in circles. I see. Yeah, another question there.
A moment, wait for.
It's a provocative result, but Ayu needs your help, guys, to understand. Yeah.
Thank you very much.
Thank you.
Oxygen is one of the most used medicines in the hospital, and we still don't know what to do with it. So your results are very interesting, but it confuses me. What should we do outside the ICU? Do you think oxygen is safe? Because you didn't measure oxidative stress parameters, right? You only measure infectious parameters. We know that even in myocardial infarction, when you give oxygen, there seems to be a higher mortality in some patients. So what do you advise us? Should we give oxygen uncontrollably, or?
And maybe you can help. What kind of stress parameters would you measure in the plasma?
Peroxynitrite, and there are some markers of oxidative stress, also DNA markers of oxidative stress you can measure, but their half-life is very low, so it's very difficult to measure them.
Very
short.
short.
We all talk about it, but we measure the infectious parameters. So I wonder whether that's the correct measurement.
About the biomarkers, of course, we tried to analyze the how can I say, other biomarkers in frog ICU. However, firstly, in previous studies, IR6 is mainly mentioned as inflammatory biomarkers to explain the correlation. Relationship between the damage and the PaO2 oxygen. So we tried to focus on the IR6, and other reasons is technical one, because due to lacking of the number of patients in our database, we focused on these 3 inflammatory biomarkers. So further study, we have to try to for example, database or other biomarkers to explain the relationship.
Thank you very much.
Thank you.
Okay, thank you, Ayu. We have more questions, but no time for them. I hope we will do this at the coffee break, and then let's go for the next presentation. It will be Pierre-Louis Blot. He will present a clustering analysis of ARDS patients.
Hello everybody, thank you for letting me the opportunity to present you my work today. I'm presenting you a clustering analysis of acute respiratory distress syndrome, ARDS, patient under high-flow nasal oxygen therapy, which we'll call further HFNO. So first of all, I have no conflict of interest related to this presentation. How clustering analysis can be a step toward precision medicine in ICU. During the last few years, despite profound prognosis improvements, there is little to few innovation in ICU treatment. And we keep accumulating negative results from randomized control trial because we keep recruiting heterogeneous patients with heterogeneous disease and heterogeneous prognosis. And you would never treat all cancers with the same chemotherapy, so why are we still treating ARDS and sepsis with the same treatment? Cluster analysis is an opportunity to identify subphenotypes, which leads eventually to subphenotypes, endotypes, and finally to suitable traits. A lot of effort has been done in the recent years to identify subphenotypes across mechanically ventilated patients, mostly by reanalysis of former randomized control trial. Here an example with 5 reanalyses of RCTs, which have shown very consistent subphenotypes of hyperinflammatory versus hypoinflammatory subphenotypes. It gives us a prognosis enrichment as the hyperinflammatory subphenotypes suffer from higher mortality than the hypoinflammatory subphenotypes. It also gives us a lot of information on the likelihood to treatment response, as all those RCTs were negative in the first analysis. But when you reanalyze them in the light of subphenotypes, you can show, for instance, in the alveoli trial, a 9% mortality reduction with IPIP in the hyperinflammatory subphenotype. In the FACT trial, a 10% mortality reduction with a fluid restrictive strategy in the hyperinflammatory subphenotype, or a 13% mortality reduction with simvastatin versus placebo in the hyperinflammatory subphenotype. So what about ARDS under HFNO? First of all, the latest recommendation published earlier in June, I finally recognize that hypoxemic patients under HFNO are truly ARDS. Secondly, despite more than 3,000 studies during the last 20 years, HFNO has only proved that it reduces intubation rate, but no study yet has shown any mortality reduction. And this is a call for me to better select our patients to identify those who will benefit from HFNO and those who won't benefit from HFNO. And no study yet has tried to enlighten subphenotypes across HFNO patients. So we built this proof of concept study to explore whether subphenotype can be found across HFNO patients. We ran a post-hoc analysis of a prospective observational study. And here I have to apologize. I'm not a cardiologist, so I don't have thousands of patients. I only have 41 patients under HFNO. This is the original publication. We ran unsupervised machine learning algorithm, which is named K-means, on 8 biological numerical variables, which are the coupled ligand receptor IL-33 ST2, S-RAGE, IL-6, IL-8, which are pro-inflammatory cytokine, surfactant protein D, which is a reflect of lung injury, angiopoietin 2, which is a reflect of endothelial injury, and bicarbonate, which is a reflect, of course, of the acidobasis equilibrium. All those variables were sampled during the first 24 hours of HFNO initiation. So the first result is we had to determine how many clusters we had to identify. We used combined method, statistical method, and we find that 2 was the optimal number of clusters. Here on the cluster plot, a representation of the distribution of our patient, and we can see that we have a very beautiful separation with no overlay of our two clusters. Here is a heat map representing the strength of each variable to drag a patient in one or another cluster. And we can already see that there is two variables that are very potent to drag a patient in the cluster 2, and they are ST2 and IL-8. Here, another way to see the same data is the level of biomarkers according to the cluster appartenance. And we can see that cluster 1 has a tendency to have lower levels of biomarkers, so we can call him the hypo-inflammatory subphenotype, where the cluster 2 can be called the hyper-inflammatory subphenotype. So what happened when we compare those two subphenotypes? First of all, we can see that all patients were ARDS according to the latest recommendation. Secondly, we can see that the patient had no difference at all in the initial characteristics, especially in terms of severity score and PaO2 over FeO2 ratio. And despite the no difference in initial characteristics, they had radically different outcomes, with a huge difference in intubation rate, even if with our low-powered study there were no statistical significance, but there were a 5-fold increase in mortality rate, and it was statistically significant. Finally, we ran dimension reduction work to use less variables to predict the same clusters, and we built a simple score based on IL-8 and ST2 value to predict the cluster appartenance. We had a good area under the RAC curve of 96%. The score is the following, and if the patient is over a certain threshold, you can predict cluster appartenance with a sensitivity of 88% and a specificity of 94%. In conclusion, ARDS patient under HFNO can be enriched using inflammation-related biomarkers. Those results, of course, need to be confirmed on a larger, biggest prospective cohorts. But this is the first study to predict mortality across HFNO ARDS. And despite small sample size, we have very consistent results, which are similar to mechanically ventilated ARDS patients. If confirmed, our score could be used to enrich the prognosis of patients and to select the good patient to include in randomized control trial. Thank you all.
If not, why you wanted to study patients treated with high flow oxygenation, but probably this will be the same for the whole cohort of ARDS patients. Those who are more with inflammation have worse prognosis of, which is the key of just to select in this population.
I think hypoxemia is very difficult. It's more difficult, a more complicated disease than it seems, because when you suffer from hypoxemia, you can suffer from heart disease, you can suffer from atelectasia, and you can suffer for like COVID-19. And those diseases are really different at all. And even if you complexify, a patient can have heart failure and COVID-19. And the level of hypoxemia doesn't reflect the prognosis of patient, and that's one of the main difficulties in treating those patients. So you cannot rely on PaO2 over FiO2 or respiratory rate. You have to enrich the way of looking at patients.
Maybe also an answer to echo what you are saying, Joseph. By taking the patient on high flow oxygen, you also avoid patients who are intubated, because when they are intubated, they may have other causes like kidney dysfunction, etc., but they are very severe. Then really you are focusing on the lung, because when the patient is intubated, we are really in a different story with more multiple organ failure.
But usually if you select patients with high flow oxygenation, you are selecting the less severe patients with ARDS because in the initial phases or those who cannot.
But you agree, since COVID, we are taking patients who are more severe than before, patients who would have been intubated before.
Yeah, and HFNO patients are often intubated. We have like a 30% mortality rate, which is not this light. It's a huge mortality rate.
But another option, you could include patients that are treated with CPAP with helmet. They are also tolerate long periods of similar patients.
No, I think it's important for we have a police of the time. No, we are good. You are a friend of Salvatore Di Somma. No, I think it's important for all of us to know what Pierre-Louis said earlier, is that the international societies are putting high flow ventilation as now part of the definition of ARDS, and this was not the case before. It's really recent, since few days. Okay, since we have I have a Swiss watch. Okay, then let's move to the next speaker. Thank you very much. It's Louis Boutin who will present a study that will interest a lot Frank Peacock. There's a reason why Frank is impatient. It's on subclinical acute kidney injury, a serious disease linked to inflammation and endothelial dysfunction. And I can say that what he's going to present is in a favorable position in a top journal.
Hello, everyone. I'm pleased to be here because I will talk about a big subject and a big project that I've been working on since 2 years ago. And we are getting into a conceptual advance in acute kidney injury definition. You all know acute kidney injury is a major problem in public health. It's associated with a high risk of admission in ICU, high cost, big problem. Well, today's definition of acute kidney injury is defined with an increase of plasma serum creatinine, more than 2 in using different definition. Today we use category. But the thing is, when you have less increase in plasma creatinine, you also have a gradually associated risk of mortality. And let's focus on this patient because it's a subphenotype of kidney damage. Let's go back to pathophysiology. Acute kidney injury is not a disease, it's actually a syndrome. A syndrome, which regroup different type of pathophysiology and subphenotype. From normal kidney to death, we will have what we all know, acute kidney injury, which is defined with an increase of plasma serum creatinine or a decrease of urine output. But as an ICU physician, when patients have an acute kidney injury, it's too late. I don't have any treatment to improve their function. I don't have any treatment to help them. What I want to do is to be the earliest possible. That's the reason why the use of kidney biomarker to identify the damage would be essential. There, I have a window to initiate early treatment. There, I have a window to prevent kidney damage and to prevent the evolution to acute kidney injury. I just showed you this result last year using 7 different biomarkers. We assess the definition of subclinical acute kidney injury. I know it's very hard to assess this definition because we have a threshold problem. But whatever biomarker you use, you will find an association and a stratification of the risk of patient. Patients have a higher risk of mortality, even if they don't have a high serum creatinine. That will bring us a big point. As an ICU physician, I want to be able to identify this patient. I want to be able to use a very high-cost biomarker to identify this early damage. In this study, we asked ourselves a question. What if we're talking about 2 different diseases? What if subclinical acute kidney injury is different than acute kidney injury? So to answer this question, we identify patients with subacute kidney injury and acute kidney injury, and we performed a proteomic urinary analysis. We wanted to know what is the pathophysiological pathway behind everything. So the first result of subclinical acute kidney injury, so patients don't have any increase in plasma creatinine, the first result showed 3 different pathways, which is mostly common, mostly known, but it's quite interesting. We have hemolysis here, mostly represented with FGA peptides. We have inflammation in kidney, represented here with beta-2 microglobulin or serpin A1 in urine. And we also have albumin in urine, which represent here an important kidney endothelial dysfunction. I just remind you we're in an acute condition. Glomerular dysfunction are less expressed here. We performed a full enrichment analysis. We wanted to know which pathway were associated with subclinical acute kidney injury. Using Gen Oncology library, we identify that platelet alpha-granule lumen and endoplastic reticulum lumen, or chaperone-binding protein, were the mostly associated with subclinical acute kidney injury. What does it mean? That means that here we have a pathway associated with cells adhesion, endothelial activation, and inflammatory response. Okay, what if I just talked about the pathway in subclinical acute kidney injury, but what's the difference with acute kidney injury? So here we compared all the population with, on the left panel, acute kidney injury, and on the right panel, non-acute kidney injury, so the definition of subclinical acute kidney injury. And what's very interesting here, we have the same pathway. We're talking about the same disease. We just have a difference in the severity and the dysfunction, but we have the same disease. So talking about subclinical acute kidney injury would be the same as talking about acute kidney injury, but without an increase of plasma creatinine. So the conclusion of the study is that we're talking about the same disease, the same pathway, but not the same prognosis, but not the same dysfunction. What if today we just recreate the definition of acute kidney injury to regroup the definition with an increased plasma serum, plasma creatinine, and with an increase of any biomarkers? Just to go further, because we want to go further, we want to understand precisely what's happening. We have the chance to get access to basic science model. And we're working on CD146, which is a marker of endothelial cells in kidney and in other organs. After renal ischemia reperfusion, so it's a renal hit, we have an increase of this protein expression, which led to think that, okay, we have endothelial dysfunction after renal ischemia reperfusion. But what's quite interesting, we're talking about endothelial cells. They are the major doors to crosstalk between organs. And here, in these mice, we found that after renal ischemia reperfusion, we have cardiac dysfunction in mice, and inhibiting CD146, inhibiting the endothelial mechanism, we prevent, at least partially, prevent this cardiac dysfunction. It's only a beginning of the work, but we think that endothelial dysfunction, subclinical acute kidney injury, and acute kidney injury should rely in probably the same definition. I would like to thank all the collaborators for this work. Very, very thankful to Alexandre Mebaza for all the help. Thank you very much for your attention.
Thank you, Louis. Very important concept, the sub-IKI, where everybody thinks the patient has a normal kidney function, but in fact the biomarkers are still high, and this is associated with a high mortality. Questions from the floor? I see a lot of kidney specialists. Maybe the president of the jury? No? Anna? Can you give the microphone to Anna, please?
But I was fascinating about the higher expression of CD146 that you show, and I was thinking, did you check if each cells increased the expression of 146, or you had more cells, endothelial cells expressing this surface marker, and how it could be then a biomarker used as to possibly to predict the
Okay, it's a fascinating question. I would like to discuss with you just later because we're writing a big paper on this. But actually, CD146 is expressed in endothelial cells, but also in smooth muscle inside the arteries or capillaries. The overexpression is more associated with a spread to peritubular capillaries. So when we have kidney damage, we will have a spread and a development of angiogenesis of peritubular capillaries. Because the first hit after ischemia is tubular destruction. And this regeneration will produce more endothelial cells and more peritubular capillaries. We think this expression of an endothelial marker would be due to this point. But it's only an hypothesis. I don't have everything to answer this question. The second point is that it's probably not only due to CD1 alpha 6 because this protein also have a soluble form. And I cannot assure that I'm looking at endothelial form, but I cannot be sure what is the specific role of the soluble form. So we're working on it with Marseille and Tenon, but it's a big work to be coming.
Yeah, a quick question, quick answer.
Yes.
Oh, yeah. So as a clinician, subclinical AKI detection window is very narrow, so time is money. So all the proteomics and all the multiple biomarkers, very good. But we have to quick analysis, have a response and apply to the clinically. So what is the time of analysis and what is your idea about the analysis of practical point of timing?
Okay. If the question is, will I do proteomic to all my patients? I won't. I will use biomarker. This is easy in Saint Louis in my ICU unit. I just have to check a box and then I will have it in 2 hours. So in perioperative medicine, now we're talking about ICU. Patients are very severe, but if you're talking about less severe patient, for example, perioperative surgery, the use of a biomarker with 2 hours is very good, is very important, because I can select my patient that will have a high mortality risk and the one that, okay, I can be with less stress.
Okay, thank you. We have no time for more questions. Let's go to the next presentation. It's going to be Noma Assad from France also. Source of mechanism of DPP3 release in pathological situations.
Hello to you all. My name is Noma Assad and I'm a PhD student in my second year. And I'm going to present to you my ongoing project about dipeptidyl peptidase 3 or DPP3. It is preclinical data. So to start with, what do we know about DPP3? Actually, it is a metallopeptidase, which cleaves dipeptides from the amino terminus from several substrates, such as angiotensin. It is ubiquitous, expressed in all of the tissues and organs. It is intracellular, but it has also been detected in the circulation of healthy individuals and with increased concentrations in critically ill patients. So this increased circulation of circulating DPP3 or cDPP3 were associated with decreased survival in ICU patients with cardiogenic shock, septic shock, or hemorrhagic shock, which shows DPP3 as a biomarker with prognostic interest. So in our project, what we want is to go a step back and try to understand how circulating DPP3 is increased in the plasma of these patients. So we posed several hypotheses. The first one is that the tissues are increasing expression of DPP3 in these pathological situations for some reasons. The second hypothesis are that they are increasing the release of DPP3. And the third one is that there's an accumulation of DPP3 due to decreased clearance. I will concentrate more on the first two hypotheses. Now, in order to study the expression of DPP3, we use two different mouse models of acute cardiac dysfunction, pharmacologically induced by either injection of isoproteinol in the first model on the left, ISO model, or by injecting of doxorubicin, the DOX model. At the end of each model, we collect plasma samples and we harvest the organs. Now, what we have seen that there was a significant increase in the activity of cDPP3 in mice with acute cardiac dysfunction compared to control mice in both models, which go in parallel with the clinical data and with previous preclinical data. Now moving to the expression of DPP3, we wanted to take an exhaustive look of the expression of DPP3, not only in one organ, all of the organs, on mRNA level and on the protein level. So here in this slide, I show you only the organs where there was a significant increase in the expression of DPP3. So in the ISO model, on the mRNA level, we have increase in the heart. On the protein level, we have increase only on the bone marrow cells. However, in the DOX model, we didn't have increase in mRNA level in none of the organs, but we have seen an increase on the protein level in the spleen. So what this result shows us is that, first of all, we see that there is an overexpression in this pathological situation in both models, that the expression varies, so we don't have the same organs that the same increase in both models. So it varies the expression based on the mechanistic or based on the model used to induce the cardiac dysfunction. And we've seen also that there was no correlation between mRNA and the protein expression. However, on the other hand, we have seen some organs that there was a decrease in the expression of DPP3, which leads us to the second hypothesis, which is the release from tissues, meaning that this tisular decrease is because there had been before a release into the circulation. And when we think about release from cells, the first thing comes to mind is the cell death. So in order to study the cell death, we worked in vitro, starting with cancer cells, which is a little far from our pathology, but it was a proof of concept because they highly express DPP3. And then we passed to another cell line, which is human cardiomyocyte, AC16. What we do is that we subject the cells to different stress conditions, and then we evaluate the amount of DPP3 released in the supernatant of cell culture around these cells. So we can see here the mortality of cancer cells. Starvation means that we decrease the nutrient in the medium. DMEM, there's no nutrient, so we starve the cells. And then the doxorubicin in increased doses. We can see here that there's an increase in mortality, logically. And in parallel, we have an increase in the release of DPP3 in the supernatant, which leads us to this very obvious, positive, significant correlation between cell mortality and the levels of DPP3 released in the supernatant. However, so meaning that cell deaths participate in the release of DPP3. However, when we go to the cardiomyocyte, we don't see this clear. It's a weak correlation, barely there's no correlation. And this reflects that, first of all, it depends on the cell type, the way that this protein is released. Second of all, it suggests new release mechanisms next to cell death. Now, speaking of this new or different cell mechanisms, we have the shedding. And before I explain the shedding mechanism, just a few idea about the localization of DPP3. So mainly DPP3 is a cytosolic. If we see here in the table in data about proteins that has 0 transmembrane helix, it has no signal peptide, which is a hydrophobic sequence that allow the protein to be in the membrane. So what we know is that it is cytosolic. However, there is studies that shown otherwise. For example, here is a study about a mouse model of Alzheimer's disease where they analyzed lipid rafts that are in the membrane of brain cells, brain tissue. And when they analyzed this lipid raft, they saw DPP3 in the extract of these membrane structures. And when we did immunofluorescence, we see DPP3 a little bit on the membrane. If you see, there's a cardiac tissue, DPP3 in green. So we wanted to investigate the shedding mechanism. So the idea is we have enzymes that called SHEDAs, a group of enzymes that cut the transmembrane proteins and release the extracellular portion of the enzyme into the circulation as a soluble form. So we hypothesize that DPP3, for some reason, goes to stress, it has modification in the structure, and it's taken into the membrane and then shedded by this enzyme. So what we did, that we used the TAPI2, which is a broad-spectrum inhibitor of these enzymes, and then we wanted to verify what happens on the circulation of DPP3 in the supernatant. And logically, if the hypothesis is correct, they should decrease when we use the inhibitor. But actually, this is not what we saw. There was no significant difference between when we stress the cells alone with doxorubicin or we stress them and before we put this inhibitor. There's no significant. So at least in this context, in this cell line, we don't have the shedding participating in the release of this protein. So to conclude, we have seen that the increasing expression, the cell death, participate in this increase in circulating DPP3, and that the expression varies based on the model. For our next step, it will be to investigate in the extracellular vesicles as a mechanism suggested for the release of DPP3, and to study also the hypothesis of decreased clearance. Thank you very much.
Time for questions.
Thank you very much. That was an excellent talk. Just wondering, have you actually do a little bit of phenotyping of your cell types, looking at the tissue expression of a DPP3, and then actually pinpoint which cell type you should be looking at in the first place, and then later on the cell culture experiment could be more focused on the cell type that could be affected in the first place?
You mean if we studied before if these cells express DPP3?
Exactly.
Yeah, everything we worked on, we studied before the expression in the pellet of cells before we start analyzing the supernatant and the release. We have it in cancer cells, different types. We have it in cardiomyocyte human, and we have it in rat cardiomyocyte. At least these are the cells that we worked on the lab, and the next step would be endothelial cells that we're going to work on.
I guess what I'm interested in is when you look at the heart tissue itself, have you phenotyped every single cell type? For example, cardiomyocytes, endothelial cells, smooth muscle cells, pericytes, for example. Look them all and see which one is actually affected, and then you can then focus on that cell type.
Yeah, it is a good idea. We did like a study on the tissue as a whole, and we did like on just cardiomyocyte for now. But yeah, for the future, we should do all of the cells in the cardiac tissue.
Perfect. Thank you.
Thank you, Noma. Now it's time to introduce Claire Odos from Bordeaux, France. She will speak on DPP3, not on red wine, but in cardiogenic shock.
So thank you for this introduction. It's an honor to be with you today. I will talk about DPP3 in cardiogenic shock. So, as Noma said just before, DPP3 is a zinc-dependent metallopeptidase, mainly cytosolic, but also detectable in the circulation. And the abbreviation for it is CDPP3. CDPP3 cleaves N-terminally active biopeptides such as enkephalin, endomorphin, and angiotensin. It modulates the angiotensin-renin system. If we look in patient cardiogenic shock after myocardial infarction, patients who had higher levels of CDPP3 at admission had higher mortality rates. So DPP3 appears to be a prognostic biomarker in cardiogenic shock. To understand more, we want to evaluate the cardiac expression and plasmatic levels of DPP3 in a cardiogenic shock model in a large animal. In collaboration with Professor Ouattara in Bordeaux, we've developed a model of cardiogenic shock in sheep involving the creation of an infarct by intracoronary injection of alcohol in first intention in the IVA coronary. The sheep are anesthetized, then catheters are placed with a Swan-Ganz catheter and Miller catheter to have PV loop. Then the induction of shock by injection of intracoronary of alcohol, followed by 1 hour of stabilization before 3 hours of follow-up. Then the sacrifice, the heart explantation for tissue analysis. Throughout the procedure, blood samples and echocardiographic are taken repeatedly. Our shock is defined by a 30% drop in cardiac output or mean arterial pressure associated with a lactate levels more than 2.5 millimole per liter. They receive noradrenaline perfusion if the sheep need it. So we want to study DPP3 expression in the heart and activity of DPP3 in the plasma in this model in 4 groups. A sham group, a shock group where animals had only myocardial infarction, a CLS group where animals had myocardial infarction plus ECLS, arteriovenous ECMO, and the last group was ECLS-DOBI for animals who had a myocardial infarction, the ECMO, and infusion of dobutamine. The time points are represented in the figure. We have baseline 1 for just after general anesthesia, baseline 2 the induction of shock, and the 3 or 4 hours follow-up. 3 hours for the sham and the shock group, and 4 hours for the ECLS and dobu group, according to the levels of assistance we adjust from the base flow rates from 25% to 100%, and we increase in each step 25% of the flow. So here we have the mean arterial pressure and the lactates, and we can see that mean arterial pressure and lactates level are stable for the sham group. So it's indeed a control group, a real control group. And for the free over group, we have a decrease in the mean arterial pressure and an elevation of the lactate level. So it's a cardiogenic shock group. If we looked at the activity of CDPP3 in the plasma, we see an increase of the activity in the ECLS dobu group and ECLS at H4. Which is surprising is that the levels of the sham as the same as the shock. We looked at the DPP3 expression in the heart by using Western blot in the left and the right ventricles and in the septums. And total heart corresponds at the 3 previous sections. And we see an increase of the DPP3 expression in the right ventricle and in the septums with significant only in the ECLS group. We looked at the association between CDPP3 and DPP3 in the heart, and we found no correlation between the activity of DPP3 in the plasma and the expression in the heart. But we cannot conclude about a potential release from myocardium to the plasma with our results. So our result demonstrated an increase of DPP3 expression in the heart. So which can be explained by de novo expression because the duration of the model is too short. So this data suggests that cardiac DPP3 does not seem to come from the heart and might come from other cells and maybe inflammatory cells. We know that there is an early inflammation following a heart attack. So what is the contribution of inflammatory cells and DPP3? We studied CD68, a marker of inflammatory cells, the expression in the heart by using Western blot in the same part as we did with DPP3. And we found a significant and positive correlation between the expression of CD68 and DPP3 in the heart. So the increase of DPP3 in the heart seems to originate from immune cells or CD68 positive cells. So the limitation of our study is the model himself, because there is an infarct, but there is no reperfusion. The short time, maybe maybe the elevation of DPP3 for the shock is after the 3 hours. And for the surprising results about the sham, we will add more animals. For the perspective, if DPP3 is brought to the heart by inflammatory cells, what are they? It requires further study to know that. We will evaluate counts of levels in plasma and the transcardiac gradient of the activity of CDPP3. And what are the consequences of the elevated DPP3 in plasma in this model? We want to evaluate cardiac function and plasma of CDPP3. And if we found something, it will be interesting to modulate the activity of CDPP3 in this model. Thank you for your attention.
Questions? If not, I'm not an expert on experimental models, but why did you split the animals in a group with ECMO, another with dobutamine? Why not? Which is the rationale for this?
Because maybe it is a different group between ECMO, maybe more inflammatory with the ACLS than without the ACLS, and the dobutamine may be more inflammatory or make the difference on the DPP3 levels. We don't know about that, and we want to know if there is something different between the group and between our patient, because we have the severity of the patient is different than one without and one with, and, but all the sheep are the same severity, but we want to know if the ECMO in itself make the difference.
All were in cardiogenic shock.
In cardiogenic shock. And the same for the dobutamine, for the catecholamine.
Okay, thank you very much, Claire.
Okay, let's move to the last presentation for this session. Will be Sébastien Rapplinger from France. He will present the development of a risk score to predict pregnancy-related acute kidney injury after postpartum hemorrhage, a French multicenter study.
Thank you very much for this introduction. I will talk about acute kidney injury after postpartum hemorrhage. And let me introduce this presentation with some definition. First, postpartum hemorrhage occurs in 5% of deliveries, and it is still the leading cause of maternal mortality in developed countries. It is defined as a cumulative blood loss greater than 1 liter within 1 day, and is still a major public health issue. Pregnancy-related acute kidney injury is an injury, acute kidney injury that occurs during pregnancy or in postpartum period. The incidence rate of overall patients during pregnancy is about 2%, but the leading cause of pregnancy-related AKI is postpartum hemorrhage. It increases maternal and perinatal mortality and can lead to chronic kidney disease in a young population indeed, for example, 2.4% of patients with acute kidney injury during pregnancy will progress to end-stage renal disease. So our primary outcome was to identify independent risk factor for pregnancy-related AKI after PPH, and to develop a predictive risk score to predict acute kidney injury after PPH. Our study is an ancillary study of HealthMom study. HealthMom study is a prospective, multicenter French study conducted between 2014 and 2018, which included 342 patients with severe PPH. In more detail, to be included, patients must have present a postpartum hemorrhage and had to receive sulprostone, which is an agonist of prostaglandin, with an heterotonic action. And after inclusion, we have to consider two important time points. First, at inclusion, clinical and demographic data were collected, and patient first blood sample were taken. And this is at this moment that we have identified risk factor of developing acute kidney injury during hospital stay. And the second time point is occurs during hospital stay. Patients were carried a second blood sample, which included creatinine concentration, to know whether or not they had acute kidney injury. So to summarize, the idea is to predict the occurrence of acute kidney injury during hospital stay based on predictive factor available at inclusion. About the definition is a composite definition based on the KDIGO definition and the serum creatinine concentration threshold of 1 milligram by deciliter. We have excluded chronic kidney disease, patients with chronic kidney disease, and patients with acute kidney injury before delivery. And we include 297 patients, and we have 43 patients with pregnancy-related acute kidney injury, about 10% of overall patients. And we have identified 5 independent risk factors of acute kidney injury after PPH. Proton time under 50%, preeclampsia, high sensitive troponin T greater than 30 nanogram by liter, NT-proBNP greater than 400 nanogram by liter, and fibrinogen under 2.5 gram by liter. And based on this regression model, we have developed the Momaki score. Momaki score included each of the 5 independent risk factors previously described, and each variable were attributed a number of points according to its weight in the prediction of acute kidney injury during hospital stay after PPH. And for example, when we have 0 point, we have a probability of acute kidney injury during hospital stay under 3%. When we have more than 5 points, we have a probability of acute kidney injury more than 80%. The predictive performance of this model is good, with an C-index about 85, and the sensitivity and specificity are good too. Another interesting result of our study is that acute kidney injury during hospital stay is associated with a poor outcome during hospital stay. For example, we have more transfusion, more frozen flesh plasma and red blood cells transfusion, more coagulation abnormalities, lower platelet count, lower fibrinogen levels, PT levels. We have more cardiovascular abnormalities, which included an elevation in troponin level, BNP level, or abnormal EKG. And we have more advanced interventional procedures, which included hysterectomy and radioembolization. And we have more hemodynamic failure. So pregnancy-related AKI is associated with adverse outcomes during hospital stay. And the Momaki score could predict acute kidney injury from the early phase of the management of PPH, but also poor outcome during hospital stay. So to conclude, we have developed a good predictive performance risk score, an easy-to-use risk score, and it allows the early identification of patients with a more severe prognosis and at high risk of developing chronic kidney disease. And it underlies the interest of biomarkers in the management of PPH through the troponin T and NT-proBNP. So we need a validation cohort, but we are actually working on it. Thank you for your attention.
Any question? Moucho. Can you have the microphone to our... Ici, la juste première rang. C'est le monsieur brésilien, là. C'est le Paulisto.
Thank you. I thought it a very interesting study. And you mentioned that this risk score can lead to less mortality. And I'd like you to tell me, when is the exact time to use them?
Yes. Thank you for your question. It's a very good question. First, the first question is practical use of this score, and it allows us a more closely care of our patients at high risk of developing AKI, and we can know it at the early phase of the management. And it is interesting. We can perform a closely hemodynamic monitoring. We can avoid nephrotoxic drug. And the second point is that we can identify patients at high risk of developing chronic kidney disease, and we can, at the early phase, think to make an appointment to a nephrological follow-up after the hospitalization, because the mortality of PPH in the developed country is very low, but the mortality is a crucial issue. And about the second question, can you just add the time? Yes. So the time, it's at the early phase. The risk factor is at the early phase of the management of PPH. After administration of sulprostone, at the initial phase of the hemorrhage, and the median average of the second blood sample is 2 days.
Yeah, thank you. And to echo what you are saying, in fact, we just got a big government grant to give glyphosine as a trial, blinded, half of the patients with and half of the patient without, in patients coming out in critically ill condition. Because as we just discussed earlier, glyphosine is really a miracle today, improving vessels, improving the heart, and more importantly, is one of the few drugs that nephrologists are going to use, because it's one of the few drugs that is restoring and recovering kidney dysfunction. Then our study will start, named DAPA ICU, will start the next year with François Després, but it will give you the answer. Thank you very much for all this. And as you saw, we truly gave the microphone on time. Now it's the coffee break, and please, if you can reconvene exactly at 11:15 Berlin time. Thank you.
Good morning. We're going to get started and stay on time, or Alex will punish me and not allow me to come back. So on behalf of Musio, welcome to this session. Young experts on stage, COVID-19, sepsis, and heart failure. Our first speaker is Hugo Norden. He's a PhD student from Mascot Lab in Paris. Hugo will be talking about DPP3 in cancer and chemotherapy-induced cardiotoxicity. Hugo?
Thank you for this introduction. Thank you to accepting having me here, and I hope you all had a nice coffee break. Yesterday was the theme of troponin. This morning it's DPP3. I will present to you my work of DPP3 in cancer and chemotherapy-induced cardiotoxicity. It's the first part of my PhD project. A very quick reminder, you've seen these slides already. But DPP3 is an enzyme, mainly intracellular. It helps the cell produce antioxidative stress proteins, but it can also be found in the circulation as a CDPP3 will be called in this presentation. And my colleague Noma showed earlier these exact same graphs, but it seems to be predictive of poor outcome when high in acute critically ill patients. Something that hasn't been presented today yet is the role of DPP3 in cancer. Very recent papers showed that DPP3 is overexpressed in different types of cancer. And here it's a retrospective case control study on esophageal cancer that showed that when DPP3 is overexpressed in the tumor tissue, not in the circulation, in the tissue of the tumor, the outcome of the patient was much poorer, and these results were found in many other cancers. And therefore, the authors of these papers did in vitro experiments with depletion of DPP3 in cells, and it inhibited migration, proliferation, and it promoted apoptosis in colorectal and esophageal cancer models. And furthermore, they did in vivo models, and when suppressing the DPP3 expression in the tumor didn't grow at all, almost in the mice injected with the tumor, and the mice survived more. So the conclusion of this slide is that DPP3 seems to be like an oncogene, and it functions through a cyclin-dependent kinase pathway. The objective of this presentation is to answer to these two major questions. First of all, is DPP3 secreted by cancer cells and also maybe cardiovascular cells? And what does the effect of the inhibition of the enzymatic capacity of DPP3 on cancer cells and cardiovascular cells? And is it cancer type dependent, and is it condition dependent, stress condition dependent? So for that, we built a cell culture model where we had human cardiomyocytes, mouse ovarian cancer, mouse breast cancer, and we submitted them to stress in form of serum-deprived media or doxorubicin treatment, and we collected the culture media after 24 hours to measure if there were any DPP3 in the culture media. And we also inhibited DPP3 with our antibody protsizumab, and we studied the effect on cell viability. The second thing we did is a bit more complex. I hope you will understand, but we submitted the cancer cells to stress, and then we collected the culture media. And our theory is that there is a lot of DPP3 when the cancer cells are stressed, and we apply this media to human cardiomyocytes. So it would be a conditioned media. And after that, we measure the cell viability, and also we inhibit the potential DPP3 in this conditioned media with our antibody. Lastly, we have an in vivo model of doxorubicin-induced cardiomyopathy on wild-type and knockout DPP3 mice. And we inject them with doxorubicin for a week, and we measure the heart function, the DPP3 levels in the plasma for 3 weeks before sacrifice. So the first results here are quite interesting. Yes, the answer is DPP3 is released from cancer cells and cardiomyocytes. So in the middle here, you can see that on human cardiomyocytes, the more stressed the cells were, the more DPP3 you could find in the culture media. And it's not only mortality dependent. There's probably another mechanism to that, because, for example, in the middle of the overgraph on DMM, which is a serum-deprived media, you have more cell viability than on the doxorubicin treated cells, but you have more DPP3 in that culture media. So it's not only mortality dependent. These results were shown in the cancer cells lines we had too. Secondly, when we inhibited the DPP3 extracellularly with our antibody protsizumab, we fully restored the human cardiomyocyte viability after 24 hours when submitted to stress by doxorubicin. And we didn't restore any viability on the breast cancer cells. We did slightly restore murine ovarian cancer cell viability, but not as fully as human cardiomyocytes. Thirdly, this was the more complex experiment that I was talking about. We submitted our cardiomyocytes first to our regular stress with serum-deprived media and doxorubicin. We had indeed an increased mortality. Then we applied secretum, so culture media from cancer cells that were not submitted to stress in any ways, and we didn't have any particular impact on cardiomyocyte viability. And thirdly, what we did was we applied the culture media from cancer cells that were stressed by doxorubicin, and we had a significant increase in mortality of human cardiomyocyte. And when we applied our antibody protsizumab on this cell culture, we significantly restored the human cardiomyocyte viability. Lastly, The mice model with knockout mice for DPP3 showed that the knockout DPP3 mice are protected from the cardiotoxicity induced by doxorubicin, and also the wild-type mice that were submitted to doxorubicin had a significant increase in mortality after 3 weeks compared to the knockout mice. So all of this first part of my PhD project shows that DPP3 is indeed released by cancer cells and cardiomyocytes, and it's not only correlated with the mortality of the cells. And CDPP3 seems to impact cardiomyocyte survival when inhibited. The question that is remained to be answered is which one is important, the one secreted from the cancer cells or the one secreted from the cardiomyocyte? And the questions we have to answer in the future now are how does DPP3 affect the cardiomyocyte physiologically? Which kind of stress leads to a lot of DPP3 secretion? And we have to build an in vivo model of mice, not only with doxorubicin or chemotherapy, but also with tumor, as it would mimic more clinical situation for our human patients. I would like to thank all my team in Paris, and thank you for your attention.
Excellent job. Questions from the audience?
I was very clear, apparently.
Thank you so much for your presentation, very interesting. I have a question. Is the DPP3 also released by myeloid cells or like inflammatory cells?
So from what I know, the DPP3 is expressed in every cell type. Mm-hmm. Then if it's secreted by every cell type, I don't know. If we say that the secretion is mainly due to apoptosis or cell death, well then probably, yeah, it could be, yeah. And we're also going to, I didn't show this here, but we are also going to analyze on endothelial cells this whole protocol to add more value of like to represent a more human heart.
Fantastic. I was just saying that if you want to really dissect or exclude the secretion of DPP3 from myeloid cells or bone marrow cells, you just can do the bone marrow transplantation in mice and then subject to your injury. That will exclude all the inflammatory cells.
Okay, yeah, okay.
Thank you very much.
Thank you.
Now I'd like to call Daniela Mota from Brazil. She will talk about exhaled breath acetone in acute heart failure.
Good morning, my name is Daniela. I'm going to present a little about breath acetone chains in advanced heart failure patients on inotropes. I don't have any conflicts of interest. Exhaled breath acetone is a biomarker of heart failure diagnosis and chronic heart failure prognosis. The line of this research originated from a clinical observation. Heart failure patients, when are in decompensation, they emit a distinct odor. The first study with 89 heart failure patients showed that EBA can be considered a proper biomarker of heart failure diagnosis since EBA levels were higher in heart failure patients when compared to the control group without comorbidities, with P less than 0.001. In this data, EBA levels were showed elevated among heart failure patients with progressive increment according to functional class decline. EBA levels greater than 1.16 were used for the diagnosis of heart failure, and EBA levels greater than 2.5 were used for the diagnosis of heart failure decompensation, with area under the ROC curve values very similar to BNP. 1 year follow-up data showed that EBA levels greater than 3.7 were associated with an increased risk of death or heart transplantation. Although limited in its statistical power, such study was an important hypothesis generator regarding the important prognostic representation of this biomarker. But the role of EBA in advanced heart failure patients is unknown. In this study, our aim is to study EBA chains in decompensated heart failure patients admitted to the emergency room requiring inotrope use. Our study is a single-center, prospective, and observational one. Patients admitted to the emergency room in need of inotrope were invited to participate in this study. Breath collection using a portable, non-invasive device previously developed and described was performed at admission and after 48 hours. The samples were analyzed by spectrophotometry after erection with salicylaldehyde. The Institutional Ethics Committee approved the study. Wilcoxon test was used to compare EBA levels in the two collected samples, and SPSS was used for statistical analysis. All patients had two collected samples analyzed. 70 patients were included in this analysis. Most patients were male, 71%, mean age 54, more or less 12 years, mean ejection fraction 25, more or less 6%. Most patients had dilated and ischemic cardiomyopathy. As you can see, the median concentration of EBA at admission was 8.5, and after 48 hours of inotrope initiation was 2.2, with P less than 0.001. The reduction of EBA is in line with the improvement in right and left heart failure symptoms, with P less than 0.001. And to conclude, our data reveal high levels of EBA in stage D heart failure patients, and EBA levels decreases soon after inotrope initiation, reinforcing previous data on EBA as a biomarker of heart failure severity. Thank you very much.
Questions from the audience?
In Portuguese, please. No problem.
Wish I could. And we're from Brazil.
Everything is from Brazil now.
Yeah.
Yes,
I live in Rio.
Brazil.
They live in São Paulo. She lives in a beautiful city.
Yes.
Espírito Santo, Vitória. Daniela, congratulations for your brilliant presentation. I have two questions. I imagine that this biomarker probably is not specific for heart failure. So my question is, how it is affected by comorbidities such as decompensated diabetes, COPD, sepsis, things like that. And the other question is, did you compare to NT-proBNP in your work?
Good question. Thank you for your question. First, it's an important question because in your data we excluded renal dysfunction and diabetes, the first study. But the second, we included them. And there's not different between above. And about the second question, please? Okay. Yes, we did. And the rock curve values was very similar.
Any other question? Daniela, I'd like to know that this study, all the study was based on the smell of the exhaled breath of acute heart failure patients. Can we say that the most of this smell is acetone?
Yes.
Or there is another component. Thank you.
Yes. Great question, Professor. The first, by spectrophotometry, we saw only acetone. It's fantastic data.
Perfect.
Yes. and you intend to evaluate the prognostic value of this biomarker in advanced heart failure. Maybe the next year you can present.
Perfect. Thank you.
Thank you very much.
Now we will hear from Maria Teresa Lira, predictors of reverse ventricular remodeling in Chagastic cardiomyopathy.
Hi everyone, good morning. It's a pleasure to me to be here today, and I will present a part of my PhD, predictors of reverse ventricular remodeling in Chagas cardiomyopathy. I don't have any conflicts of interest for this presentation, and as you know, heart failure usually occurs after an initial insult, and this can lead a dysfunction ventricular. In some cases, in some patients, after you remove the initial insult or started treatment or mitral repair, resynchronization, or implant of assistant device, we can lead the patient to have a reverse remodeling and better outcomes, how we can see there, with the lower rates of mortality and the rehospitalization. Chagas disease affects 8 million people at the world, and we believe that 1.1 million lives in Brazil. Unfortunately, Chagas disease is the third etiology of heart failure in our country. And we know that this patient has a poor prognosis when you compare with other etiologies. But the studies about reverse remodeling usually include a small number of patients with Chagas disease. And we don't know the impact of reverse remodeling in patients with Chagasic cardiomyopathy. Based on this background, we created our hypothesis for this trial. Reverse remodeling is associated with better clinical outcomes in Chagas cardiomyopathy and can be predicted through variables identified in this analysis. This is a pilot study, observational, retrospective, and second center, and we evaluated 1,273 charts of patients with Chagas disease and clinical diagnosis of heart failure with reduced ejection fraction. The period occurs between January 26 to December 2022. This trial was approved by ethics committees of INCOR, of University of São Paulo, and our primary outcome was survival, and it predicts factors in 16 years of follow-up in two groups. The first group is left ventricular reverse remodeling positive. The patient have the first echo with ejection fraction lower than 30% and a subsequent echo with ejection fraction greater than 30%, or who have an increase of ejection fraction greater than 10%, respecting a minimum period of 6 months between the exams. And the second group is reverse remodeling negative. These patients don't have these criteria. How we can see in this first table, we have the baseline characters of 1,049 patients analysis for occurrence of reverse remodeling, positive or negative. We can see that we have difference between the two groups, like age, sex, NIHA classes, incidence of hypertensional infarction, and ventricular pacing contraction in 24 hours. If you look for the treatment, we can see that the usual treatment for heart failure don't have difference between the groups, but the use of furosemide was increased in the group with don't have the reverse remodeling. The comparison between the two dimensional echocardiography, we can see that patients who have reverse remodeling positive, to back, it's here, okay? Okay. We can see that patients who have reverse remodeling positive usually have a lower left ventricular diastolic diameter and a higher ejection fraction when compared with the other group. But we don't have difference in right ventricular dysfunction. In the second echo, we can see that patients with reverse remodeling positive, there are better outcomes, better results when compared the variables. Our primary outcome was mortality, and we can see, or heart transplantation, and we can see that patients with reverse remodeling positive, there are rates of total death or heart transplantation 35%. When compared with the other group, it's about 5 to 6%. And we don't have difference between the transplantations significant between the groups. Finally, we've done the univariated and multivariated analysis of many predictors for reverse remodeling. And I want to see to you the independent predictors of multivariate analysis for long-term mortality and reverse remodeling positive. We can see that reverse remodeling positive is an independent predictor for long-term survival in these patients. And there are others, like left ventricular diastolic diameter, left atrial diameter, ureal, NIHA classes, and systolic blood pressure. And we have independent predictors of reverse remodeling positive as age, left ventricular diastolic diameter, and moderate and severe tricuspid regurgitation. Finally, I want to show to you the Kaplan-Meier survival analysis patients without or with reverse remodeling. And we can see that patients who have reverse remodeling positive, there are a median survive 11 years, and patients who don't have reverse remodeling, there are a survive 8.8 years. So, we conclude that this present study suggests that the left ventricular reverse remodeling predict a reduction in long-term all-cause mortality in patients with Chagas disease, and it's associated with age, left ventricular diastolic diameter, and moderate severe tricuspid regurgitation. Thank you for your attention.
Any questions from the audience? Joseph?
Thank you for the presentation, very interesting, large database. I guess that probably the results would be different in the recent years if you add new treatments that improve the prognostic, like ARNI or IS-SGLT2 inhibitors, but probably they increase the ejection fraction. But I think it's nice for the old series. Because it finished in 2016, no?
Yes, finishes last year in 2022. But the number of patients with the new drugs is very short, 2 patients. So with, it's not relevant in this trial. But maybe it's a good thing for these patients because we can see that there are a higher incidence of death. It's 50%. When we look all Chagas, not the advanced heart failure.
Chagas disease for us is very challenging. Because we see big hearts with big left ventricular dysfunction. And I'd like to ask for the audience, did any of you treated or saw a patient with Chagas cardiomyopathy? You did. Perfect. Thank you. Just to know.
Can I make just one comment? Maybe your question will be answered in a few years. They are doing a study in Brazil with Chagas patients with sacubitril valsartan. The parachute study, it's ongoing.
Sure. Thank you.
Thank you.
Our next speaker is from Cape Heart Institute at the University of Cape Town. Julian Hovelman will be talking about assessment of adherence to heart failure therapy in peripartum cardiomyopathy.
Dear Chairman, dear colleagues, thank you very much for the introduction, and I'm very pleased to be invited to this great meeting to present some of my PhD work entitled Assessment of Adherence to Heart Failure Therapy in Patients with Peripartum Cardiomyopathy. So peripartum cardiomyopathy is a pregnancy-associated form of dilated cardiomyopathy which presents in previously healthy women towards the end of pregnancy and up to 6 months postpartum. The pathophysiology is multifactorial and still remains incompletely understood. Current knowledge is a multiple hit hypothesis which includes host susceptibility, which is increased due to genetic predisposition, and other risk factors such as higher maternal age, multiparity, or preeclampsia. And then there's a second hit, which is a peripartal trigger, which includes the still hormone prolactin, which is secreted by the pituitary gland for breast milk production, and it has, in the presence of oxidative stress, it is cleaved into a 60 kilodalton isoform, which then has a detrimental effect on the vasculature. Moreover, there is also a placental axis, which includes SFLT1, which is secreted by the placenta and also has includes two angiogenic imbalance. So from previous studies, we could show that a high prescription of heart failure therapy and a PPCM-specific treatment called prolactin, which inhibits bromocriptin, which inhibits prolactin, shows that there was reduced mortality in these patients, which is seen here for beta blockers and for ACE and ARBs after 6 and 12 months. And we could show that there was higher chances of LV recovery at 6 and 12 months for high prescription of bromocriptine in these women. However, no previous studies has investigated the role of adherence for LV recovery in women with PPCM. So in this prospective study conducted at the University of Cape Town, we included 36 women with PPCM who returned for a regular follow-up visit. And we collected ECG, echocardiogram, their medical therapy, and we screened for anxiety and depression and assessed health quality of life using EQ5D questionnaire. We assessed adherence twofold. Firstly, with assessing pharmacy refills in the past 6 months, and secondly, using liquid chromatography high-resolution mass spectrometry to objectively assess adherence to the heart failure therapy. So these are the baseline characteristics of our study. The women had a median age of 32.4 years, and they had a median time of 16 months past the initial diagnosis at the time of the adherence visit. We can see at the beginning they were mostly on guideline-directed medical therapy at the time. So on this slide you can see an overview of the detectable drug levels by liquid chromatography high-resolution mass spectrometry here on the left side. And we then went on to stratify the patients accordingly if they were, we defined them as adherents, if they were on, if all prescribed drugs for heart failure were within the therapeutic range. We defined them as partially adherent if more than one but not all drugs were within the therapeutic range, and as non-adherents, if none of the prescribed drugs were detectable in the plasma. So with that definition, 23 were classified as fully adherent, 53 as partially adherent, and 23.5 as non-adherent. When assessing pharmacy refills, we saw that 64% collected all their pharmacy refills in the past 6 months, whereas the other 36 did not. And we found that there was a significant association that adherent and partially adherent patients were more likely to have collected all the scripts. So we then went on to assess the association of adherence and LV remodeling in these women, and we found that there was better functional LV recovery in these adherent and partially adherent patients in comparison to non-adherent patients, albeit this was not statistically significant. And we also assessed the reverse remodeling by a left ventricular and diastolic dimension, which was significantly decreased in adherent and partially adherent patients in comparison to non-adherent patients. When assessing a self-related health status using EQ5D questionnaire, we found that non-adherent patients reported significantly more symptoms of pain and discomfort. And when we looked at the overall score, adherent patients reported lower scores for EQ5D, which is suggestive of a better self-rated health status. So here I would like to conclude that screening for non-adherence in this vulnerable population may be of clinical relevance, and adherence to heart failure therapy in PPCM was associated with LV reverse remodeling. And better self-related health status was associated with higher adherence levels. And our study highlights the importance of intensified education and counseling about the importance of drug therapy in this population. And with this, I would like to thank you for your attention, and I would thank to my collaborators from the Cape Heart Institute and the University of the Saarland. Thank you.
Congratulations, very rigorous methods with mass spec and EQ5D, quality of life. Great job. Questions from the audience? Frank, I think, okay.
Oh, thank you very much. That's an absolutely excellent paper. Thank you. I was just interested, did you get any sense of what the predictive factors were for non-compliance, so you can actually know where to focus your more intensive education?
Unfortunately, because thank you for the question, excellent question. Unfortunately, I could not show everything, but we also briefly mentioned that we assessed anxiety and depression. I could not show it because of the time, but we also could show a correlation between higher scores for anxiety and depression to be associated with non-adherence.
So in the U.S., if you didn't take your medicines, it's usually because you couldn't afford them, because we have a problem with insurance. What was the reason that they gave when you asked them why they didn't take their medicine?
Yeah, excellent question. Thank you. So these patients are all from South Africa, so they also come from very low socioeconomic backgrounds. And this study was performed during COVID times. So we did ask them a questionnaire, and some patients said they interrupted the medication because they could not travel to the pharmacy in the COVID era. But that was one of the reasons. But another reason was also that they did not think it was necessary anymore, because with peripartum cardiomyopathy, after you've started the treatment, they a high proportion recovers their LV function, they feel much better. So they did not understand the necessity to continue their treatment, some of them.
Thanks for the excellent job. I have a comment about the definition of adherence. It's not only to give the right drugs, life-saving medications, 1, 2, 3, or 4 weeks, but also to optimize the doses, and also to give the max tolerated doses, that the adherence is the combination of prescription with uptitration of that. There is labeling in European Society of Cardiology registries about that, using in previous trials. Gave you the same process in, you have the same process in this trial?
Thank you for the question. Yeah, that's absolutely right. We do see them regularly. We do uptitrate the medication according to tolerability, but we did not assess this in this cohort of patients because they quite heterogeneous in that some of them have recovered their LV function, some of them have not recovered their LV function. So actually, yeah, this was a preliminary trial of also because we do not know if we can stop some of the heart failure drugs in this population. So this was a preliminary study to in the future investigate this better.
One final question.
Have you checked the impact of bromocriptine on adherence? Because you mentioned anxiety and depression, and bromocriptine is known to enhance anxiety and depression. So are you entering a kind of vicious circle where there's already a background of mental illness that is potentiated by the treatment, which lead to less and less adherence?
Thanks. I did not know that, so thanks. I will look into that. We haven't assessed that, but it's a good point. I will look into it.
Great job with the questions and the presentation. Thank you very much.
Thank you.
We are now going to shift to the Senior Scientist Lecture by Fariel Azabani from France to talk about vascular effects of DPP3.
Thank you. Yeah. Yeah, okay, and to... Okay. Thank you. So, good morning, everyone. I'm quite happy to be here today. I will bring back DPP3 on some preclinical experiments. I'm sorry, but I promise it's the last time. I mean, at least from the Paris team. So, I mean, DPP3 is still a metallopeptidase. It's still present in the cells, and it can be also present in the circulation of acute diseased patients. To pick up just one cohort analysis we've done, this cohort of severely burned patients that are suffering from shock, where we saw that high levels of DPP3 were associated with circulatory failure, with systolic cardiac dysfunction, and with acute kidney injury. In the lab, I mean, using wild-type animals, we showed that the injection of DPP3 was able to decrease the cardiac function in those animals, as you can see here. Yeah, it works. On the other hand, using an antibody that was developed by Andreas Bergman in 144 company, protzizumab, that we named PCZ. PCZ is a monoclonal antibody that will inhibit the enzymatic activity of circulating DPP3. And using this protzizumab, we could actually reverse the cardiac dysfunction in a model of cardiac dysfunction induced by septic shock in rats. As it was said before, DPP3 is an enzyme, and one of the substrates of DPP3 in the circulation is angiotensin II. But there are very poor data, not poor, but very not so much data on DPP3, on the relation between DPP3 and blood pressure. There is this study that was published in 2016 by a Japanese team, the PANG study, which is a very nice study. The authors show that DPP3 infusion in hypertensive mice could decrease the blood pressure of those animals. What was interesting is that when they induce the hypertension using noradrenaline instead of angiotensin II, or when they use normotensive mice and they infuse DPP3, they had no effect on blood pressure.
On the other side of the slide, there are the DPP3 knockout mice who showed increased levels of angiotensin II, for example, but those mice had normal blood pressure, which is a bit puzzling. So the aim of my presentation is to show you the data we have on how DPP3 can modulate blood pressure, the RAS, renin-angiotensin system in vivo, the blood pressure, and the kidney function. To start with the RAS, we injected wild-type mice with DPP3, protzizumab, or PBS, and then we measured by mass spectrometry circulating RAS. As a control, you can see that the mice who had DPP3 have high DPP3, and the ones who received protzizumab had lower DPP3 activity, which is normal. But when we measure angiotensin levels, we saw that DPP3 injection was associated with an excessive degradation of angiotensin II, but also of angiotensin IV, which was described being a substrate also of DPP3. On the other hand, protzizumab injection was associated with an increased levels of angiotensin II, angiotensin 1 to 5, and angiotensin 1 to 7. Knowing now that DPP3 is able in vivo to degrade angiotensin II, we looked whether DPP3 can influence the blood pressure. So we took the same wild-type mice, not the same exactly, but we took wild-type mice, refinement, reduction in animal ethics stuff, but yeah, anyway. So wild-type mice injected with DPP3 or protzizumab or PBS, but this time we measured blood pressure using a pressure transducer, but this was done invasively and not by plethysmography. We did it also by plethysmography, and we couldn't see any change. And even invasively, we couldn't see any significant change of blood pressure in the mice that were injected with DPP3 or protzizumab. So we thought whether there is another system that can compensate for this degradation of angiotensins. We thought about catecholamines. It was quite easy thought, I must say. And it was really interesting, and we were lucky enough to see that DPP3 injection was associated with an increase of catecholamine release. On the other hand, when we inject protzizumab into wild-type animals, we could see a decrease of catecholamines release. Our hypothesis is that this catecholamines release post-DPP3 injection can compensate for the degradation of angiotensin II and then maintain a normal blood pressure. To verify this, we did another experiment, so we injected still DPP3 or protzizumab in wild-type mice, but this time we pre-injected the animals with labetalol, which is an alpha and beta adrenergic receptor blocker. And this time, when you inject DPP3 post-labetalol, you could see a decrease of blood pressure. And this confirms that the catecholamines release induced by DPP3 compensate for the degradation of angiotensin II and then the maintenance, and explain the maintenance of blood pressure in those animals. Our second question was, does DPP3 modulate the renal hemodynamics? This time, we didn't use the pressure transducer, but we used a flow meter. And what we observed is that when we inject DPP3, we saw an increase of the renal blood flow in the mice. And in opposition, when we inject PCZ, we saw a decrease of the renal blood flow. Blood pressure is stable, so this means that DPP3 decreases the renovascular resistance in those animals. To go furthermore in this, we looked whether DPP3, and to check if this effect of DPP3 on the renal blood flow is linked to angiotensin II degradation. We did this experiment. We checked the vasoreactivity of angiotensin II before and after DPP3 injection. So we took wild-type mice, we injected different range of angiotensin II doses, and then we injected DPP3, and then we re-injected exactly the same dose range angiotensin II. And we measured the mean arterial blood pressure and the renal blood flow before and after. And this is the variation that you are seeing. In gray is before and in brown is after. And what we could see is that DPP3 administration is indeed associated with decreased systemic and renal vasoreactivity to angiotensin II. We then checked whether this effect of angiotensin II is AT1 receptor dependent. So we did the same experiment then for labetalol, but this time we pre-injected the animals with valsartan, which is an AT1 receptor blocker. And what we observed is that the effect of DPP3 on the renal blood flow post-valsartan injection was lower in the animals when compared to DPP3 injection without valsartan pre-injection, showing that at least partially AT1 receptor is involved in this effect induced by DPP3 on the renal blood flow. Another substrate of DPP3 substrates are enkephalins and endomorphins. So to check if they are involved in the effects we are seeing on the renovascular resistance, we pre-injected the animals with an opioid receptor antagonist, naloxone, and then we measured blood pressure and the renal blood flow. And what we observed is that this doesn't affect DPP3 effects on both, actually, which means that in this setting, enkephalins degradation by DPP3 are not involved in the renovascular effects induced by DPP3. It was already, shown several times in preclinical models and also associations in cohorts that in sepsis or in septic shock, the infusion of angiotensin II will decrease the renal blood flow, and this was associated with an improvement of the renal function. So to check whether this increase of the renal blood flow in our animals post-DPP3 injection may affect the renal function, we measured renal function biomarkers, creatinemia and urea, and we also measured glomerular filtration rates, and unfortunately we couldn't see any effect of DPP3 on the renal function in this setting again. So to conclude, we showed that DPP3 modulates the RAS in vivo. This was, the first time someone showed this. DPP3 decreases systemic and renal vasoreactivity to angiotensin II. This effect seems to be at least partially AT1 receptor dependent. DPP3 has no detectable short-term effect on the renal, on the kidney function. It's healthy animals. Half-life of DPP3 is 30 minutes. The renal blood flow effect we saw doesn't last more than 1 hour. So it might be that the setting is not very good to assess the renal function. And last, we saw that increased catecholamine release might explain why blood pressure is still normal despite decreased vasoconstrictive angiotensins. I would like to thank the team in Paris, especially Adrien Picot, who did all these experiments. I would like to thank also 14-4, especially Karine Bourgeois. And thank you.
Excellent mechanistic talk in 10 minutes, too. Very great job. Questions from the audience?
I think I killed everyone.
No. Well, then I have a question. So, the AT1 receptor seems to be fundamental in this pathway, and we heard talks about cardiogenic shock. and now these blood pressure findings. So how do you suspect we should modulate the AT1 receptor in situations where we want to change, the impact of DPP3, or do we just not do that and look more for norepinephrine, et cetera, to sort of counterbalance the hypotension?
Thank you for your question. Something that Adrien also did during his PhD is we had this hypothesis that, there was a paper published saying that renin renin concentration and activity increase might reflect decreased angiotensin II concentration and might also reflect endothelial dysfunction leading to ACE decreased expression as well. And what we showed, because I showed only partially the RAS, but what we could see that is when you inject DPP3, so you decrease angiotensin II, you increase angiotensin I, so you increase the ratio angiotensin I to 2. We cannot measure angiotensins by mass spectrometry every day, but we have a very nice correlation with renin. So one can think of measuring renin, for example, to see whether this pathway is downregulated.
It makes sense. There's so many counter-regulatory functions of that pathway. We thought this was fundamental in COVID, right, with ACE2 binding, et cetera, and found that modulating that pathway didn't help. It may have caused harm. So there's so many feedback loops, and how do you actually modulate that to improve outcomes is quite challenging.
Yeah, and actually the half-life of angiotensin II in the plasma is 10 seconds.
It's impossible to measure, yes. Yep, and even renin, right, with just changes in posture, your renin changes dramatically. So, questions?
I think that, of course, you thought about it. In what kind of disease it will be interesting to have DPP3 as a drug?
You mean protzizumab or DPP3? No, protzizumab. The clinical indication today, I will not talk in the, Karine can say it more better than me, but the clinical indication today is shock, septic shock, cardiogenic shock, but yeah, that's the first clinical indication for protzizumab.
Perfect.
I have a question, because when you inject DPP3 and when you see the catecholamine, the response is very quick.
Yeah.
And when you put AT1 blocker, it blocks. Do you think that it blocks at the level of the periphery, or it is a central blocking? Because in the hypothalamus, there's a lot of AT1, and it's a major regulator of
course.
Adrenal function.
Yeah. It's thank you, Nicola, for this question. We are part of the same lab. It's a real option. Actually, one can think, when we inject DPP3 and we measure the blood pressure, you couldn't see it actually on the graph I showed, but we had like 5 millimeter mercury decrease of the blood pressure, which might, then activate the splanchnic nerve and then the release of catecholamines. We can only answer this question by using renal denervation models, or by, using AT1 receptor and then blockers and then measuring catecholamines. But we cannot really exclude another mechanism of recapture of catecholamines, for example.
Thank you.
Thank you.
We don't have time. Thank you for all the speakers in this session. And I'd like to call Oscar and Frank for the next session.
It's in our hands to get lunch on time, so big responsibility.
Where are you? Dr. Herr. There she is. Pre-sepsin. Been waiting all day for this one.
Can I start? Yeah.
Please.
Okay, yeah, thank you, Frank. Thank you, Oscar. Yeah, hello, everyone. I am Professor Mina Ho from Konkuk University, Seoul, Korea. So my topic is COVID-19 and some emerging biomarkers focused on pre-sepsin and interferon lambda 3. So as of mid-June, the cumulative confirmed COVID-19 cases were over 760 million, with cumulative deaths of over 6.9 million. And the situation by WHO region showed that the highest cumulative death in Americas, followed by Europe. And quite recently, WHO declared that the COVID-19 is now an established and ongoing health issue, which no longer constitutes a public health emergency of international concern. So it's time to transition to long-term management of the COVID-19 pandemic. And COVID-19 is becoming more predictable and manageable, but the pandemic isn't over yet. And ending the public health emergency of international concern does not mean the pandemic is over or that the COVID-19 has become endemic. So we are moving from emergency response to long-term COVID-19 disease management. And preventing, diagnosing, and treating COVID-19 to reduce its mortality, morbidity, and long-term sequelae are important, with early diagnosis, treatment, and clinical care, especially at-risk populations. And then the SARS-CoV-2 shows a complicated relationship among virus antigenicity, transmission, and virulence, which has unpredictable implications for the future trajectory and disease burden of COVID-19. So we should continue to stay ahead of changes in this era of uncertainties with diagnostic and therapeutic tools. And quite recently, last week, one of the hot academic topics was the UK bat study that found coronaviruses with potential to develop into human pathogens. So we don't know which would come in the near future. As we know, the main root of COVID-19 is ACE2 receptor, which is expressed in the lung and in the heart. In addition to the heart and lung, ACE2 is expressed in the intestinal epithelium, vascular endothelium, and kidneys, providing a mechanism for the multi-organ dysfunction. And 1 year after SARS-CoV-2 infection, patients may have an array of increased cardiovascular risk, so-called the COVID heart. And one recent study showed that among hospitalized patients with COVID-19 and elevated cardiac troponin level, the presence of cardiac scar was independently associated with cardiovascular outcomes at 12 months. Another important study also showed that the risk and burdens of cardiovascular disease were evident even among those whose acute COVID-19 did not necessitate hospitalization. So long COVID is not only fatigue or brain fog, but rather the constellation of symptoms and organ dysfunction that result from COVID-19 and persist or arise anew in the post-acute phase of the disease. So how best to identify, diagnose, and treat these patients is a critical area of future research. In our own small study, we explored the role of soluble ST2, a cardiac fibrosis biomarker, and found that it's useful for predicting clinical outcomes in hospitalized COVID-19 patients. And soluble ST2 was comparable to SOPA score, and it was significantly better than the clinical scoring system named critical disease. Regarding pulmonary fibrosis, post-COVID-19 pulmonary fibrosis is a novel sequelae of the current pandemic. And we also explored the usefulness of KL6. KL6 is a quite well-known pulmonary fibrosis biomarker, and KL6 was useful for predicting clinical outcomes in hospitalized COVID-19 patients too. So regarding presepsin, a recent review and meta-analysis has proven its utility, and presepsin is a promising biomarker that can express COVID-19 severity. So as opposed to other conventional sepsis biomarker, for example, procalcitonin, one theoretical advantage of measuring presepsin in patients with SARS-CoV-2 infection is that its circulating value may directly reflect the clinical severity of COVID-19 rather than solely mirroring the presence of co-infection or superbacterial infections, which may occur at high frequency in COVID-19 patients with severe or critical conditions. So routine assessment of presepsin in COVID-19 may provide valuable clinical information for predicting adverse outcomes, as well as for guiding the clinical and therapeutic decision-making. We also explored its utility, and we explored the prognostic utility of procalcitonin, presepsin, and the clinical VACO index for predicting 30-day mortality in hospitalized COVID-19 patients. And we could see the highest hazard ratio in presepsin, and it showed an add-on value to the clinical VACO index. And in our study, although most patients presented with sepsis or septic shock, the median procalcitonin levels in survivors and non-survivors were all below 0.5 nanogram per milliliter. So the prognostic utility of procalcitonin in COVID-19 was somewhat arguable, since it was in the normal range in most patients. And this may be due to the absence of bacterial infection or downregulation of procalcitonin by interferon gamma released during viral infection. Unlike procalcitonin, the median level of presepsin in survivors was below the upper reference limit, whereas that in non-survivors was approximately 4 times higher the upper reference limit. So compared with procalcitonin, presepsin may show better clinical utility in terms of prognosis prediction in these critically ill patients. So let's talk about interferon. Interferon lambdas are critical for maintaining a balanced antiviral response in the respiratory tract. And interferon lambdas lack the strong pro-inflammatory effects of type 1 interferons and are rather tissue protective and anti-inflammatory. And recent studies showed that interferon lambda 3 could predict COVID-19 disease severity. So we explored the utility of presepsin and interferon lambda 3 for predicting disease severity and clinical outcomes in COVID-19 patients. So our study population showed 67% of elderly patients, and the in-hospital mortality was 24% in the total patients. And sepsis or septic shock was diagnosed in 62% of the total population. In our data, both presepsin and interferon lambda 3 levels differed significantly between the two groups of non-critical disease and critical disease. And in the ROC curve analysis, SOFA score, presepsin, interferon lambda 3, and AG showed comparable performances for predicting disease severity. And for predicting adverse clinical outcomes, both SOFA score and interferon lambda 3 levels were comparable, and presepsin levels showed good performance for in-hospital mortality. And in the survival analysis, the combination of presepsin and interferon lambda 3 showed a higher hazard ratio than SOFA score, and these biomarkers showed greater risk of mortality when added to clinical assessment of SOFA score or AG. And in our study, the mortality rate was 24% in the total patients, and it differed significantly according to the biomarker level. It was significantly higher when both presepsin and interferon lambda 3 levels increased above its cutoff than when either one or no biomarker level increased. The elderly patients accounted for 67% of the total patients and 92% of overall deaths. The mortality rate was 32% in the elderly patients. And similar to the total patients, the mortality rate was significantly higher when both presepsin and interferon lambda 3 levels increased than when either one or no biomarker level increased. So actually, this was the first study that explored the clinical utility of these two novel biomarkers compared with clinical assessment in hospitalized COVID-19 patients. And both biomarkers, alone or added to clinical assessments such as SOFA score and AG, could be useful to assess and manage COVID-19 patients, especially in the elderly. And further large-scale studies would be necessary to verify the clinical utility of these reliable and objective biomarkers for predicting clinical outcomes in routine practice. So again, the multi-marker approach is quite important in COVID-19 too, in the context of sepsis and multi-organ dysfunction. So we can combine conventional emerging biomarkers together in the broad range of critical care, including COVID-19. Thank you very much for your kind attention.
Thank you for this interesting talk. Any comment from the audience? Any insight? I have to ask, most of these studies has been performed during the first or second waves with the more aggressive strains of COVID, and if this is the case, how it translates into the current COVID we are seeing in the emergency departments and in hospitals, because it seems that the severity have clearly going down after the first waves. So, and most of the data we have in the literature come from the first waves. My question is, does that data come from the first strains of the COVID? And if this is the case, how it could translate into the current strains?
Yeah, this data was obtained at the largest surge of COVID-19, actually. So it's not the recent data, but the main thing is that COVID-19 is not just a viral infection, and the severe cases are sepsis cases. So we could see that nearly 2/3 of the hospitalized patients had sepsis or septic shock. So we can get some kind of lessons from these patients that we can understand the COVID-19 severe cases. Still, we have COVID-19 severe cases, so we can learn some lessons of using biomarkers. When we think about the risk of COVID-19, age is very important clinical factor, so we could understand that they have a very high risk. And then using this biomarker, we could see that if the both biomarkers increased in the elderly patients, most of them died. But if the biomarker levels was not that high, even though they are elderly patients, they survived. So we can also apply those things to other septic patients. And then, yeah.
David?
So is this specific for COVID-19, or if you looked at influenza patients similarly sick in the ICU, would the biomarkers be relevant?
Yeah, so I think so. So currently we are measuring these biomarkers again in our sepsis patients, including more than 300 patients or so. So I would like to stratify the patients according to the age and the biomarker utility. I think I can find the utility of biomarkers in the aged people, even though they are at risk population.
Excellent. Thank you.
Thank you.
Next, we have my friend from the Netherlands going to talk about artificial intelligence. Prabhat Nanakaran.
Thanks for the invitation. It's a privilege. Because of the time, I'll try to be brief with my presentation. You know, we all talk about biomarkers, but nobody uses it. Not biomarkers, sorry. Algorithms, I'm sorry. And Freudian. What we did in the last couple of years is working with Ketan Paranape, one of our PhDs from US, and we just explore and publish some papers on why don't we use these algorithms more often. 3,000 algorithms were developed last year, and I don't know whether have used even one of them in the last couple of months. ChatGPT, this is a publication we wrote about a couple of weeks ago. ChatGPT, you know, most of your application letters, what young people write now are from ChatGPT. They write it down, they change some of the sentences and send it to you. So beware of that. What we did was, a couple of weeks ago, we got an abstract from Annals, and just ask ChatGPT to rewrite the abstract and show it to people, which is which, text 1 or text 2. Most of them got wrong. You know, so ChatGPT is making lots of impact in our practice. My journey with algorithms starts with this study, which was published in 2019 in Lancet Respiratory Medicine. This was about sepsis. Largest pre-hospital study in the world. Why did we do it? You know what happens with patients who have sepsis or suspected sepsis when they come to the ED? We take blood culture, we give them antibiotics, and some people start thinking after that, some people stop thinking after that, sorry. Can I go back? So what happened was, we did a study in the ambulance where we gave half of the patient antibiotics, other half antibiotics at the ED, just to show that most of these patients does not need antibiotics. They needed a diagnosis and think about the diagnosis. And this led to lots of discussion. We showed that the mortality did not decrease in most of the patients. This led to lots of discussions. Even the guidelines were changed. But my PhD, when she was watching Grey's Anatomy about 4 weeks later, this happened. Now, I can't, the sound is not there.
It is refreshing, actually, yeah. Talk to somebody about something other than the latest issue of the Lance.
Yeah. Did you read that article about pre-hospital antibiotics?
That was amazing. You read that?
Yes. Groundbreaking.
So when Gray's Anatomy talks at our study, I think I can go on vacation and stop it. So thank you. So what happened? What we saw was, in the young population, less than 65 years, you could see maybe some trend. So what we did was we used artificial intelligence. This was published in Chest last year. We did artificial intelligence, and we simulated to see if we had more young people, would it have mattered? What we showed was that after some age, you can give as many antibiotics you want to give, nothing seems to happen. So when you're old, sepsis is a disease of the elderly. When you're young, you give antibiotics earlier, it helps. Think about that. So what happened? We were doing all sorts of studies about blood cultures. What we found out was, you all know this, one of the most important reasons for antibiotic resistance is antibiotic overuse. We use about 30% more antibiotics than necessary at the ED. Same thing applies to blood cultures. We do about 10,000 blood cultures per hospital in the Netherlands. The positive rate is about 14%, out of which 50% is contaminated. And also most of the results come 3 days later. So if you look at it, about 17% positive, or 1.4% sometimes, contamination 50%, it affects treatment decisions in only about 2.8% to the max, which means that we do lots of tests without thinking about it. But does it harm? Yeah. If you have contaminations, it has been demonstrated, patients stay longer, they have more kidney failures, they cost more money, and their mortality is also high. Even in our hospital, we demonstrated that, which will be published soon. So what we did was, we thought we should try to reduce use of blood cultures at the ED. And that's why we came up with the algorithm. What we did was, we got our population of blood culture patients at the electronic health records and came up with the algorithm using age, sex, lab results, vital signs. Of course, the computer came up with the algorithm, and we validated it in our hospital and published it also. These are the baseline results. Take it from me that patients who had positive blood cultures were older, and further, there were not many differences because of the time. You can read this in BMJ Open, and we use all kinds of methods to come up with the algorithm. One of the methods was extreme gradient boosting, and if you're interested, I can explain it later after the talk what this is. We published the first paper in the BMJ Open. We just published the algorithm, which was validated in our own population. After that, we validated it in 4 other populations and published it in eBiomedicine last year. We took our training set, VUMC, our test set, VUMC test set, AMC, our sister hospital, also a big hospital, Sans Medicentrum, a small hospital, and we used a database, open access database from US Alto to validate this algorithm. And if you look at the populations, they are almost the same, except that the US population has less blood culture positivity, for 5.4%, and other populations had about 11.5% positivity, with also contaminations about 50%. And AUCs were, about 0.81, almost the same in all these populations. And if you look at the predictors which were computed by the computer, they were pathophysiologically plausible also: temperature, creatinine, CRP, lymphocytes. bilirubin. I mean, SOFA scores has bilirubin also. Just read all the factors the computer selected to compute the algorithm, which is plausible pathophysiologically also. And what we did was, we didn't tell the doctors, but integrated it in our EPIC system, the electronic health records. The ethics committee allowed us to do it. And then what we did was, in every patient, when they did a blood culture, we calculated the percentage positive, probable positivity percentage. So for each individual patient, we could do it. And we also did it prospectively in 1,000 patients, blindly. Nobody knew that we were doing it. AUC was the same. And we also asked, we had focus groups, asked people, why don't you use algorithms? And how do you want the results? And we decided on their advice to give them an absolute value of the culture. So I think we have gone through all these steps. We have spoken to the patients. We have validated it. And now we are going to start a large multi-center trial. There are lots of interest in Holland to take part. We want to include about 10,000 patients. We have got the funding just 2 weeks ago. So we'll be starting the ABC trial, where we are going to randomize patients and advise doctors. If the chance of having a positive culture is less than 5%, which is very restrictive, because we didn't want to go further, 5%, we asked them not to do the blood cultures. Eventually, we hope that it will also reduce antibiotic overuse, and we hope to reduce 30% of blood cultures doing this without affecting the clinical endpoints. And so, conclusion, algorithms, we don't use it. In my opinion, we haven't asked the right question and given the right answer. There are potential benefits of using algorithms. Next is a clinical trial, and we'll be starting it very soon. And this is our team which worked on all this work. Thank you.
Thanks, Prabhat. Nice talk. There is one question at the bottom of the room.
Hello, excellent presentation. We share a common interest. And I would like to ask you, if you're going to do the RCT, your algorithms probably consider a medical device.
Yeah.
So have you managed to secure regulatory approval? And if yes, I would like to know everything.
Yeah. We got the MDR, we got the approval of the Central Committee. We just got the approval of the Ethics Committee. I didn't ask for CE marking because I think we are going on the wrong way if you patent this algorithm and try to earn money with it. So we have kept it open. If you want to use it and improve it, work with us, more than welcome. We don't want to get rich. We want to just change the practice. So we got all the process have been gone through. We can start next week if you want to.
Okay, that's great. So even when you're altering patient care, you don't need any formal approvals to do that. So
No, we got all the approvals from the Central Ethics Committee of Netherlands and also our ethics committee in the hospitals and all the other hospitals. Patient consent have to be taken. You got to take
so
patient
it's not
consent.
Patient.
Yeah,
it
but
has
we
to
didn't.
be consent.
Yeah, so we didn't ask for the CE mark. That will come later.
Okay, thank you.
Excellent. Okay, we're short on time. Thank you, Prabhat. Dr. Hahn? Dr. Hahn? Going for a neurologist perspective on long COVID.
Hello, everyone. I'm a neurologist by training, so I'd like to switch gear a little different aspect. Actually, the biased here. Everybody is talking about the acute condition, but I'd like to talk more about the chronic long-term condition. So the benefit of last speaker is that much of the introduction has saved. So why we call COVID-2? So actually the SARS COVID-1 was named after 2002 outbreak of SARS. Then the COVID-19 is termed the new coronavirus 2019, caused by the so-called SARS-CoV coronavirus 2. So we call it COVID-19. So as Mina has already showed it, I Googled this morning that is updated version. So as Mina has already mentioned that thanks to the previous SARS infection, we already know that how the coronavirus enter the host tissue cells using the with the aid of transmembrane serine protease, the angiotensin converting enzyme 2 receptor, the contact point, and as you already know, is COVID-19 is not only the respiratory disease, but also the many organ is involved. So actually, it's multi-organ dysfunction has been shown. So the clinical presentation of COVID generally is very, very age dependent. So the youngsters almost all the youngsters has no symptoms at all. So we call it asymptomatic disease. The age is the major risk factors, and can determine whether the patient shows any symptoms or not. So the children has almost the children has asymptomatic, but the young adult suffered a very mild disease, like the symptom is fever, fatigue, dry cough, and malaise. And at the time, the chest X-ray shows the typical of ground glass opacity, is a hint of pneumonia. When it comes to the age over 60, the more severe symptoms appear, and the most critical period is the oldest old patient. So they suffer from the acute respiratory distress syndrome and acute cardiac injury and multi-organ failure, which is only managed by the ICU. See, most of the case of the COVID-19, the patients suffered the acute symptom, but eventually most of them recovered from the initial attacks without any serious sequelae. However, up to 25% of the initial recovery, they show the lingering or persistent clinical symptoms known as long COVID syndrome. So based on the WHO data, currently at least 77 million people suffered from the long COVID syndrome. But the concept of long COVID is still evolving. So WHO defined the long COVID syndrome using the Delphi method, the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. So the different health authority coined the different terms like the post-COVID condition, long haul COVID, post-acute COVID-19, even chronic COVID. Recently coined the term post-acute sequel of SARS-CoV-2, so-called PASC. This is a different definition of the various healthcare organizations. What is the common long COVID syndrome? It's General symptom is constitutional symptoms, extreme fatigue, tiredness, which is interfered in everyday life. Then symptoms get worse after physical or mental effort. We called it post-exertional malaise. And many respiratory and heart symptoms, even digestive symptoms, are more or less focused on the neurological symptoms. As the patient complain of difficulty thinking or concerning, we called it brain fog. And some patient shows definite depression or anxiety and relentlessness. And most of them complain of sleep problems and cruciating headache. And the dizziness when you stand up, we called it postural, due to postural hypotension, then lightheadedness, so the postural dizziness. And due to the peripheral involvement, patient complains of pins and needles sensations. And as you know, well, the decrease in the ability to smell or taste is a typical oral symptoms of COVID-19. This paper written by the researchers working at Washington University at St. Louis, they investigate after the 1 year the onset of the COVID break, estimate the risk and burden of incidental neurological disorders at 20 months following the acute SARS-CoV infection. What they found was that the stroke, both ischemic stroke and hemorrhage stroke, was the prevalence and incidences increased. And as you know, well, the brain fog is a problem. As I told you before, the pins and needles symptoms, and episodic disorder like migraine and seizure disorders, and even some patients shows the Parkinsonian feature, and mood disorders, and rare symptoms in musculoskeletal disorders, sensory disorders, even Guillain-Barré syndrome. So actually, this paper is written by a science writer, and he described his own symptoms as brain fog. So we called it the various neurological symptoms. The patient with COVID symptom is termed neuro-COVID. The postulated pathomechanisms like the cytokine-associated immune dysregulation and anti-neural antibody, because autoimmune disease, and the direct or indirect neuroinvasive infection. And one of our recent theory is that the SARS-CoV-19 triggers reactivation of the latent virus like the Epstein-Barr or herpes simplex, which can further trigger inflammatory cascades. And neurovascular dysfunctional blood-brain barrier is leading to pro-inflammatory cytokines and pro-thrombotic materials, which cause the neuroinflammation, accounts for the entire brain injury. And hypoxia and in the cellular level, hypoxemia and metabolic disturbance cause central nervous system injury further. So at the gross level, recently a British group published in Nature what they found. They used the UK Biobank data. It's the patient who suffered from COVID-19 definitely shows the thinner gray matter and decreased brain volume. So as you see here, compared to control, the brain volume and cortical thickness are greatly reduced. after the COVID-19 infection. I'm more or less focused on the neurodegenerative disease. As I told you before, some patients suffered from the Parkinsonian feature, which is not a typical feature, but because most Parkinsonian disease can go long, with long duration, but in such a short period, some patients definitely suffered from the Parkinson feature. This probably related to the neuroinflammatory changes. Same is true the Alzheimer's disease. So also the most important mechanism of the involved in pathogenesis of Alzheimer's disease is amyloid beta protein and abnormal tau phosphorylation, but nowadays neuroinflammation is a very important one. So the last part of my talk is focused on the interactions between COVID-19 and Alzheimer's disease. The first clinically relevant issue is that does Alzheimer's disease enhance the susceptibility to COVID-19? As you know well, the highest death rate occurred in the institution. Most of them are suffered from chronic disease like the Alzheimer's disease or Parkinson's disease. So what they found was that the ApoE4 is the best known strong genetic factors causing the sporadic Alzheimer's disease. And then the patient with, this paper came from the Finnish group of their autopsy series. What they found was that the patient who suffered from severe COVID-19 was ApoE4 is associated with most severe symptoms, including hemorrhagic spot in the brain. And this is the same result from the Chinese people. The COVID-19 infection and disease severity in ApoE4 allele. So the Alzheimer's disease increase COVID-19 morbidity and mortality. So the contributing factors, most of the Alzheimer's patients advanced age, and as you know well, the patient with dementia, they cannot take care of themselves because of cognitive dysfunction. And as I told you before, the ApoE4 increased the risk of severe SARS-CoV-2 infection. And increased activity of ACE2 receptor, which is normally the arsenic-converting enzyme 2 receptor is not profoundly expressed in the brain, but for some reason in patients with Alzheimer's disease, it is overexpressed, which is make them more susceptible to COVID-19. And the other way, the SARS-CoV-2 exacerbate the existing AD pathology or clinical symptoms. This paper using the Mendelian randomization method, then what they found was that COVID-19 may contribute to the development of Alzheimer's disease. So the COVID-19 may promote the initiation and the progression of Alzheimer's disease through the genetic susceptibility and viral neuroinvasion, which directly to the cognition and mood-related structures. Underlying for that is neuroinflammation again, and blood-brain barrier disruption is associated with microglias. And there is some evidence that potential amyloid precursor protein metabolism dysfunction, which result in the much more amyloid beta protein accumulation in the brain. And definitely long-term hospitalization patient shows the immobility and they show delirium. So should we expect the number of Alzheimer's disease in the coming years? This short paper published in Journal of Alzheimer's Disease, what they found that after the COVID-19, the new onset Alzheimer's disease was compared to the health control. The hazard ratio was 1.65, especially elderly people aged more than 85 years, and gender difference is more susceptible in women. This is how SARS-CoV-2 might cause Alzheimer's disease. Should we include a prospective trial of antiviral or immune-enhancing therapies for future to reduce the long-term COVID? I think so. Then what are the current therapeutic strategies? Actually, right at this moment, no specific therapeutic agent that can arrest or prevent neuro long-term COVID. As like before, the strict personal hygiene, vaccination, an oral antiviral agent, and balanced diet is the key. This is currently available antiviral agent. The last, can we prevent the brain fog and neuro-COVID? Recent paper showed that treatment of COVID during the acute phase definitely decreased the post-acute score of COVID. So the treatment with acute phase with steroid and antiviral agent is very useful to reduce the impact of PASC. This is the WHO recommendation for the nutrition patient with COVID-19. As what they recommend is take as much antioxidant as possible. Recently, I found that this article, Mediterranean diet is a potential strategy against the SARS-CoV-2 infection. So if we stick to the Mediterranean diet, it can potentiate our immune system and reduce oxidative stress, reduce inflammatory responses, and eventually it prevent the long-term COVID-19 through the chronic low-grade inflammation reduction. So this is the active ingredient of the Mediterranean diet. And I'd like to end my talk by raising some questions. How long does the long COVID last? I don't know, but some researchers told that in case of Parkinson's disease, will be as long as 20 years possible, because the previous viral infection, the patient with Parkinsonian feature was appeared after the around 2 decades. What are the prognostic biomarkers for long COVID? Actually, I asked mostly the laboratory medicine people to solve this problem. And how soon will the precision medicine be available to target the underlying pathomechanism like the chronic long-term low-grade neuroinflammation? It's to be answered. So I stop there. Thank you very much.
Thanks. Thank you very much. Any comment from the audience? Do you think that in this long COVID, there is a part of the patients that in fact they are suffering from chronic fatigue syndrome, which is started by the COVID infection, like other infections? I mean, yes, for sure there is a long COVID syndrome, but sometimes I think there is a mix on that of in the physiopathological. What is your thought?
Yes,
about that?
There is lots of reports, the similar pathophysiology between the chronic fatigue syndrome and the long COVID. So in a sense, chronic fatigue syndrome is the main pathophysiology is the chronic low-grade inflammation. So same is true for the long COVID.
All right, I think it's time for lunch. Thank you very much for all the speakers and all of you.
Okay, welcome everyone to the start of the afternoon session. A few people still coming back from lunch, but we need to get back on track, so we're going to have some very efficient chairing here by Christian. So our first speaker is Miriam Pargar from Switzerland. Hi Miriam, welcome, and is going to talk about perioperative myocardial injury, which is a really fascinating and challenging topic, so I look forward to hearing more about it.
Dear chairs, dear colleagues, I thought my planned subject on resource usage and safety would be a bit dry and not helpful for digestion right after lunch. So I decided that I would like to talk to you about implementation science and how to bridge the no-do gap instead. But first, a bit of background on our PMI project. Many surgeries take place globally as well as in Switzerland. Mortality rates are with 7.7% higher than previously anticipated. A quarter of those surgeries are done in cardiovascular high-risk patients, which are especially vulnerable. We were able to show in Basel that 13% of those high-risk surgery patients experience a perioperative myocardial infarction/injury, short PMI, defined as an absolute increase in cardiac troponin of over the 99th percentile above preoperative values. But far less than 10% of those patients show symptoms of myocardial ischemia, leading to missed diagnosis and treatment of this cardiac complication. This is particularly grave since mortality of patients with PMI is significantly higher, and the one-year mortality rates with patients with PMI is 17 to 49%, depending on the etiology. In Basel, we started with an active surveillance for PMI, where we identify high-risk patients before their surgery. We then measure troponin preoperatively as a baseline, and then postoperatively on day 1 and day 2 after the surgery. If we detect a PMI, the patient receives a cardiology workup. Our efforts in this field are even supported by the new ESC guidelines from 2022, which recommend a systematic troponin screening in this high-risk population with an evidence level of 1B. But this is sadly not enough. It is estimated that it takes a mean of 15 years to get evidence-based practices implemented, and only as little as 14% of evidence-based practices are ever implemented. So you could provocatively so say that 86% of biomedical research is wasted, summing up to $268 billion US. Implementation science tries to bridge this no-do gap. This bridge tries to bridge the trial world with the real world. The active surveillance for PMI also suffers from the same problem. Even though it is now guideline recommended, other hospitals in Switzerland and worldwide are hesitant to take up this practice. A lot is still unknown before the screening can be widely implemented. So we started Implement PMI, a prospective multi-center pre-post comparison study to add to the knowledge base. As part of this, we prospectively asked ourselves the question, which implementation strategies do we need to make this active surveillance for PMI work in other settings? We planned to implement the intervention in different hospitals, namely the cantonal hospitals of Olten, Solothurn, and Lucerne, and university hospitals of Geneva and Innsbruck. We identified barriers which could hinder the implementation in those settings and mapped them to the updated CIPHER framework. We called them assumed barriers, since we anticipated those before implementation. Then we selected implementation strategy to help us overcome those barriers and reported them according to the ERIC taxonomies and the Proctor model. Here you can see a simplified graphic model of the CIPHER framework. It describes where barriers can take place, namely the outer setting, the inner setting, individuals, the implementation process, and the innovation in itself. I will now show you some examples of barriers that we found in our project. In the implementation process, we had the problem that we did not fully assess the setting prior to implementation. So our information on the context, where we wanted to implement this innovation, was limited. For the outer setting, we had to adapt to different cantonal and country-specific conditions and laws, and also manuals and algorithms for the diagnosis and management of PMI are not known or not widely available. In the inner setting, we anticipated, based on our experience in Basel, that the information flow and the communication between departments and disciplines may be difficult. And on an individual level, we thought that maybe we could lack persons to lead the efforts to implement the innovation, provide support, and also take responsibility. Now I will report to you one of the implementation strategies that we used to overcome some of our barriers. When we report implementation strategies, it is always important to name them, define them, and specify them. So we named our implementation strategies after the ERIC taxonomies. Then we defined them according to the widely accepted method paper of Powell et al. And then we specified them after the Proctor model. In our case, we specified that we would have a study coordinator and doctoral students. They would provide training to the implementation team, to the cardiologists, and to the anesthetists. Then we also said that they should do this training throughout the study, but also at least 2 times. As a justification, we already had some studies that this implementation strategy is effective when trying to implement guideline-recommended screenings or complex interventions. So I will conclude with some of my key messages. Gaining knowledge in the implementation of evidence-based practices could reduce research waste and save money. An implementation strategy should address barriers and be adapted to the context to facilitate the implementation. And also, when reporting implementation strategies, one should define and specify them precisely to inform further implementation. Thank you very much.
Okay, super presentation. It is open for questions. Implementation science is really important and not done well, and I really admire the approach you're taking. Very thoughtful.
Thank you.
I'm fascinated to know what your markers of success are going to be for the implementation of this particular program. I don't know if you have got that far yet in terms of defining exactly what they're going to be, but I've been interested in your thoughts.
So, of course, we defined some implementation outcomes that we want to assess. We are not that far to give you some results right now,
No.
but we will, of course, look at the reach. So how many, when we are then in the post-implementation phase, how many patients got the screening in the end? Then also, if they had a PMI, how many of those patients then also had a cardiac consultation. We will look at the costs. Yeah, it's just some of our examples. Yeah.
Okay. One other thought. In my experience, implementing things that make the lives of the person who's got to do the implementation easier is much more successful than doing something that makes their life more difficult. Do you think that in your consultations that you've done so far, there is a group of clinicians that are ready to embrace this beyond the biomarker enthusiasts that we have in Basel? Because my experience speaking to anaesthetists and surgeons in this space is that they are more reluctant than we are in terms of embracing the concept. So have you identified barriers from specific patient groups?
So, yeah, of course, we had some instances where we had surgery disciplines that kind of opted out and said they don't want their patients to receive screenings.
Okay.
And in this case, we were just going on without those disciplines.
Okay.
So when implementing it is always important to try to adapt. In your innovation, you always have core components of the innovation that you cannot adapt. So for us, it is that those troponin measurements have to take place. But there are a lot of things around there that are adaptable, and it's important to adapt the innovation to the context to then facilitate the acceptance and adoption, of course. We also had a center that was not planned initially and wanted to start.
Okay, yeah. Good. Well, that's encouraging, but I think that's a great philosophy, adapt, and you'll learn a lot from this process, I'm absolutely sure of it. Very well done. Thank you.
Thank you.
I would now like to ask Dr. Noemi Glaner to come to the podium. Miriam nicely introduced to you the concept of the active surveillance for PMI, and that, of course, once detected, PMI is detected, these patients need a cardiac consultation to identify the phenotype and the necessary workup. So Noemi will educate us whether having a cardiac consultation then is of any good to the patient, or it's only increasing the cost of care. So what is the latest science, Noemi?
Thank you, Christian, for this introduction. Dear Chair, dear colleagues, as we've just heard now from my colleague Miriam, and also yesterday from our industry partner, perioperative complications are an emerging topic, and as there has been growing evidence that perioperative cardiac complications are frequent and are associated with high, short, and long-term morbidity and mortality. Actually, there has been a study published in Lancet in 2019 that showed that postoperative deaths is among the leading causes of deaths worldwide. And as we also heard before already, the detection of perioperative complication poses specific challenges, as symptoms are often marked and therefore overlooked if there's no targeted surveillance. So therefore, we have the new 2022 ESC guidelines on the management of patients undergoing non-cardiac surgery, and they now recommend with a class 1 perioperative biomarker screening for early early detection of perioperative complications. So now we have identified the big problem, but there is an even bigger problem because evidence on how to improve the outcomes of this patient group is scarce. So there was one trial, the managed trial, that showed that dabigatran twice daily lowered cardiovascular complications in patients suffering from myocardial injury after non-cardiac surgery due to ischemic cause. However, as we gained more knowledge about PMI, we know more and more that PMI is a very heterogeneous disease with various underlying pathophysiologies such as type 1 or type 2 myocardial infarction, acute heart failure, or also extracardiac causes such as sepsis. And the identification of the most possible pathophysiology is crucial for the selection of the most appropriate therapy. So within the last 10 years, we have built one of the largest and best described cohort of patients undergoing major non-cardiac surgery. And these eligible patients participated in the PMI surveillance and response program. As you've heard, they received the perioperative biomarker screening. And then in case of a PMI, the structured institutional response included the assessment for possible PMI symptoms and the recording of a 12-lead ECG. In addition, a cardiac consultation was triggered. And then the scope and the sequence of the cardiac workup was defined by the treating cardiologist. So for this analysis, we wanted to evaluate the association between cardiac consultation and major adverse cardiac events and all-cause death within 1 year. MACE was here defined as a composite of cardiovascular death, MI, acute heart failure, and life-threatening arrhythmia. We then used Cox proportional hazard models to evaluate the association between cardiac consultation and our outcomes. So moving on to the results, we had a total of 1,875 PMIs from a total of 14,300 screened surgeries. We then further excluded patients with a postoperative ICU stay and patients with multiple PMIs within 1 year. This left us with a cohort of 1,060 PMIs, and 58% of the patients received postoperative cardiac consultation. Here you can see a small table of some baseline characteristics of the cohort. The median age was 77 years, and 55% of the patients were female. And as you can see, the history of different cardiovascular disease was evenly distributed between the two groups. In total, 16% of patients suffered from a MACE within 1 year. And here you can see the result of the Cox model with an adjusted hazard ratio of 0.56. So we can say that cardiac consultation was associated with a 44% reduction in MACE after 1 year. Here you can see conditional effects plot of 3 patient examples with a low-risk patient to see a high-risk patient. And on the y-axis, you see the probability of being free of MACE, and on the x-axis, you see time. In dark blue are patients that receive postoperative cardiac consultation, and in lighter blue, patients that did not. And as you can see, among all the levels of patient risk, we see that patients that receive postoperative cardiac consultation had less MACE after 1 year. And another observation is that the higher the risk of the patient is, the more pronounced this difference between the two groups gets. So moving on to the secondary endpoint, all-cause death, 13% of patients died within 1 year after their surgery, and the Cox model showed here an adjusted hazard ratio of 0.7, so cardiac consultation was associated with a 30% risk reduction. So now, to finish, I want to show you this table, 2 examples of postoperative cardiac diagnostics in relation to the recommendations from the cardiac consultation. So first, we see that patients that receive postoperative cardiac consultation had, in general, more postoperative cardiac diagnostics performed. Now, when we look at the recommendations from the cardiac consultation and how they were adhered to, we see some differences. For example, recommendations to perform an echocardiogram during the index hospitalization was followed in 70% of the cases. However, recommendation to perform a myocardial perfusion imaging, mostly in an outpatient setting, was not followed as well. Of course, there are some limitations that merit consideration. First, even though we provided an outline for the cardiac workup, in the end, this was defined by the cardiologist in charge. Also, adherence to the implementation of the recommendations by the cardiologist cannot be completely followed up. So I would like to summarize. Patients with PMI receiving postoperative cardiac consultation with further cardiac workup had less MACE and lower mortality within 1 year after undergoing major non-cardiac surgery. Thank you for your attention.
So Noemi, this was outstanding. For those of you who were impressed by Noemi on stage, we will be even more impressed tomorrow morning seeing her on the football field. So coming back to the topic, could you perhaps describe in more detail why within this active surveillance program not everybody has received a cardiac consultation? I think that's important to understand why there were two groups.
Of course. So reasons for patients to not receive a cardiac consultation were mostly, I think, about half of the patients that did not receive a cardiac consultation. It was due to this PMI happening on the weekend. And we defined in the beginning that due to, of course, some shortages in staffing, that we will take a different delta on the weekends to trigger a cardiac consultation. So it was not the normal 14 nanograms per liter that was used during the week, but it was a delta of 50 nanograms per liter. So that's one reason. And then another reason was also that we defined in the beginning that if there are other more urgent patients that need to be seen, the cardiologist in charge can decide to not go to the patients that suffer from a PMI. These are the two most common reasons why the patients did not receive cardiac consultation.
I have a follow-up question. It's really interesting data, and the first time I've seen data from the implementation of one of these programs, so it's fascinating. I think your adherence is pretty good considering actually these are complex patients, there's a lot going on, a lot to think about beyond cardiac investigations, but of course an echocardiogram and a markup perfusion scan does not improve survival or reduce MACE. So what treatment differences were there between the two groups that might plausibly have influenced these outcomes, because the potential for bias within the selection of patients for consultation is quite high. So can you explain what you think the mechanism of improved outcomes is?
I mean, of course, that is the million-dollar question, and I think I cannot answer it fully so far, but what I believe is that it's like just the whole bundle of care that improves the outcome, and especially that a cardiologist was involved in the postoperative care of this patient, and the cardiologist went to see this patient clinically with that there was even a possibility to intervene if there was something really amiss with this patient.
If there are no other questions, thank you very much. I like the concluding remark there. I wholeheartedly believe that cardiologists, just by being cardiologists, improve outcomes for patients. That I completely understand that. So we're going to welcome Jasmine Buchel on the stage. Hi, Jasmine. This is a really interesting topic. We have not, at the great meeting, had many sessions on myocarditis, but I think it's been a pretty hot topic in the last couple of years, particularly with concerns around the association between vaccination and myocarditis. And I've often puzzled why it's more common in young males than females. So I'm hoping that you're going to be able to provide an answer.
I'm not sure, but thank you for the introduction. Dear Chairman, dear colleague, today I speak about sex differences in patients with acute myocarditis. Acute myocarditis, as many of you are well aware, is a condition characterized by the inflammation of the heart muscle. And it's caused by infectious or non-infectious diseases such as toxins or autoimmune conditions. It's often manifesting as chest pain, shortness of breath, and can lead to severe arrhythmias, heart failure, and even death. But what we must recognize is that this condition does not affect men and women in the same way. Recent studies found differences in higher incidence in men, differences in baseline characteristics, and variation in clinical presentation and symptoms. But what are the unanswered questions that remain regarding sex differences in acute myocarditis? So the open questions are if there are differences in ECG findings, in cardiac biomarkers such as troponin or NT-proBNP, differences in cardiac imaging like electrocardiography or also cardiac MRI, and differences in in-hospital outcomes. So therefore, this study aimed to investigate to study the sex differences in acute myocarditis, focusing on clinical manifestation, baseline characteristics, diagnostics, and also in-hospital outcomes, which includes the heart failure, the in-hospital death, and severe arrhythmias. We defined severe arrhythmias as the occurrence of sustained ventricular tachycardia, ventricular fibrillation, and also cardiac arrest. To achieve our goals, we conducted a retrospective cohort analysis. And our study design involved an examination of medical records, allowing us to gather substantial patient data. We included patients hospitalized for acute myocarditis at the intensive care unit between 2000 and 2018. All patients were over the age of 18 years. The acute myocarditis was diagnosed by a cardiologist based on medical history, clinical examinations, ECG finding, and laboratory markers. We excluded all patients with coronary artery disease proven by left heart catheterization. And in total, we included 215 patients in our cohort. For statistical analysis, we performed the chi-square test or Fisher-Exact test as appropriate to compare the differences between male and female patients. So our results revealed several differences between male and female regarding the acute myocarditis. And in our cohort, women constituted a quarter of the patients and were older at time of diagnosis compared to the male patients. This also we can see in this bar chart, the red line representing the female, and they show a higher age at time of diagnosis, and the blue line for the male patients with a younger age at time of diagnosis. Furthermore, we saw that women have more dyspnea at admission compared to male patients, and exhibited signs suggestive of a reduced pumping ability, such as cardiac murmur or edema. Also, we can see at the ECG at admission that male patients presented more often with ST elevation and women more with T wave inversion. So regarding the biomarkers, we could find a higher level of NT-proBNP in female patients and a lower, and this was a difference. And surprisingly, despite these higher NT-proBNP levels in female, the left ventricular ejection fraction was within the normal range for both sexes. Then the cardiac MRI showed as well as the measurement with the transthoracic echocardiography, similar left ventricular ejection fraction between the sexes. And the presence of edema and late gadolinium enhancement were observed without significant differences in women and men. However, there were disparities in the occurrence of severe arrhythmias and also heart failure, which were more likely in women. Further, even if not significant, a higher percentage of women experienced in-hospital mortality due to acute myocarditis. Our study has several limitations. First, it was a retrospective cohort analysis with its inherent limitation. Second, we recruited the patient out of the intensive care unit, which might therefore, our present cohort representing more severe forms of acute myocarditis. And third, cardiac arrhythmia were ascertained by automatic rhythm analysis and from the patient data management system, but direct telemetry tracing were not available. So in summary, in our cohort, we found that women are older and present more often with dyspnea at admission, which is coherent to recent studies. But what we found was a difference at the ECG findings at admission, where the ST elevation was more often in male patients and the T inversion more often in female patients. Regarding the cardiac biomarkers, in our cohort, the women had a higher level of the NT-proBNP, but similar ejection fraction in both sexes. And in contrast to men, a higher occurrence rate of severe arrhythmias and heart failure was detected in female. Now we ask ourselves why the differences. But the underlying mechanism is still unclear, but there are ongoing discussions regarding the sex hormones such as estradiol and testosterone. And for this reason, it's important to investigate in further researches which could help to improve the outcome for all patients. Thank you for your attention.
Fabulous presentation. We've got a question from Martin. It's a really interesting data set, and I have congratulations on pulling together a really interesting set of data. I don't think I've ever seen quite so well characterized before. Martin.
Yeah, thank you very much for your nice presentation. From my perspective, a patient with myocarditis who go to the ICU is a rare condition. So most patients do not go to the ICU. I think you had 215 patients in 18 years, so approximately one per month. And my question is, what is the gold standard for the myocarditis diagnosis you did? Is this MRI or something else or a mix? And the second question is, so myocarditis is a disease, even if you call it acute, patients come to different time points in the hospitals. Some come 2 days later and have different troponin, maybe different NT-proBNP. So would this be also a bias which could influence the gender difference you showed, so that maybe in the female cohort the patients come 2 days later and therefore the biomarkers are different?
Yeah, to the second question, for sure it's a bias. We also look of the time of symptoms before hospitalization, and this does not differ between male and female. But maybe the symptoms occur later in females, so we don't know. And also, but it's interesting to see at this in future analysis. And the first question, yes, we have not a lot of patients, but we're planning to have more patients also from the emergency room and then compare. And the diagnosis was with clinical examination, also with the MRI or transthoracic echocardiography.
Thank you. Thank you. It was a very, very nice work and very nice presentation. You didn't touch in the treatment part of the patient management, and also there was no patient was submitted to a cardiac biopsy. Could you clear this?
Yes, cardiac biopsy, it was done, but not in many cases, maybe in 3 or 4 cases, because it's restricted availability. That's a reason for this, but yes. So what was the second question?
The treatment, especially
yes.
if any patient took, for example, corticosteroid.
Yeah, we also analyzed the treatment, but there were no difference. But we will analyze it more to see if there are differences also in the treatment between the sexes.
Thanks for the excellent work. According to my experience, there is higher incidence of rheumatic disease in females versus males. And possibly, underlying cause in some cases is rheumatic disease. According to my experience, also, fulminant myocarditis is more frequent in females than males. In some cases, there is underlying giant cell myocarditis. That is useful if you have the history of these patients according to rheumatic disease.
Yeah, but we have 3 cases with giant cell myocarditis, but these were 2 females and 1 male. So, yes.
Thank you. So I'd like to ask Beata to come to the podium. Dr. Monovic will give us a presentation on the importance of bleeding in cardiovascular disease. Beata.
Hello, thank you, Christian. Thank you for the invitation. It's a great honor to be part of this fantastic meeting and the privilege to talk about an interesting but tricky topic of bleeding in cardiovascular patients. There are a few things why bleeding in cardiovascular patients is a tricky field. First of all, there is no precise data describing the population at risk and suffering from bleeding among cardiovascular patients. Cardiovascular meaning those treated with antithrombic and antiplatelet therapy. So it's very difficult to establish the incidence. It's thought that it's pretty high and higher in clinical practice than in clinical trials. Where data are presented regarding very specified and narrow populations, like in those figures here on the right, data coming from a randomized control trial, a very specific vascular scaffold for dual antiplatelet therapy, and on the left, data from a very also specific Asian population of atrial fibrillation treated with oral anticoagulants. The next thing why we consider bleeding in cardiovascular patients a tricky thing is the very, very high clinical impact of the events. It's represented in the population of acute coronary syndromes, where bleeding actually has similar prognosis to that of cases with ischemia. What's more, after 30 days from acute coronary syndrome, the prognosis of bleeding is thought to be even higher than this of recurrent myocardial infarction, what is seen in the figure on the right, where blue stands for MI, red stands for bleeding, and the size stands for magnitude of the events, depending on the type of bleeding. Moreover, bleeding is considered and thought to even increase the risk of ischemic events at follow-up. What was shown in Horizon's AMI trial, again, a trial, so a very narrow population specific here with admitted with STEMI, where almost 8% of patients suffered from bleeding after an ischemic event at the follow-up, and almost twice as many, so almost 16% of patients suffered an ischemic event following a bleeding event, all within 30 days from STEMI. The next reason why bleeding is regarded as a tricky field in cardiovascular patients is the very complex step-by-step pathway from the assessment through reduction of the magnitude to treatment. And taking into account the first step, the assessment of the risk of bleeding, we come with several factors, every of them very tricky and very complex. Even at the very beginning of the problem, by defining the bleeding, we encounter problems. We get confused by the variety of scales different between studies, which makes it extremely difficult to compare between trials, between the specific populations. That's why, regarding all the factors, we need to work up some kind of unifying definitions, like, for example, the PARC definition for defining the bleeding. On top, we always have to consider the opposite weighing pan, which is the assessment of the risk of thrombosis in every patient that we consider at risk for bleeding. Going further with the steps, we go to the very interdisciplinary field of the medical branches with the highest burden of bleeding, from 2 to 4% for gastrointestinal bleeds, up to even 50% for intracranial events. Although it's a variety of patients and with many symptoms, many different sites of bleeding, many different symptomatology, they all have one thing, may have one thing in common, which is they're treating cardiologist or consulting cardiologist who may introduce antiplatelet and antithrombic treatment, which increases the risk of bleeding very much. Thus, making the symptomatology very difficult, often overlapping the symptomatology of the primary disease itself, which again makes it extremely difficult to identify potential victims of our cardiologic treatment. The final step is the treatment, and it's not as easy as we all think, because we of course are equipped with many guideline recommended strategies for the management of bleeding after antiplatelet and antithrombic treatment. However, as it was said at the first presentation, all the guidelines are implemented in a very low percentage of patients and cases. And the ESC guidelines are mostly written, read, approved, and implemented only by cardiologists. So nobody needs to remark us that it's always better to avoid than to treat. And not all of you may be aware of a very fine method, a preventive strategy, which is broadly available, very cheap, even not recommended, but even requested by patients themselves, mostly in Europe, especially in Switzerland, which is a folk method, a medieval prayer called the secret. This is a method. I was also quite surprised while reaching this paper. This is a method aiming at stopping or reducing the bleeding in patients in the perioperative or periprocedural period. So it seems like magic. But Stefan Cook with his team in Fribourg, Switzerland, addressed this in a randomized trial. And randomized patients undergoing or awaiting coronary angiogram to a control group, so with the standard of care, versus patients with the standard of care and the secret. The secret as a prayer was implemented by 14 volunteered secret makers. So these are people who are trained to provide such a method. But the results were not more than expected and showed, of course, completely no impact of this method on the incidence of bleeding. However, patients had a better follow-up in a short term. They reported lower level of stress. So maybe this is kind of biofeedback method, maybe of a possible good future in medicine. Anyway, to address the question if we as the specialists in Western medicine in 21st century, if we are able to influence the incidence of bleeding in a better way than this medieval method, together with my colleagues in Zabrze in Poland, based on the experience from long-lasting cooperation with Christian and his fantastic team in Basel, with the PACE in syncope studies that we are very thankful for, we came up with a registry with the acronym BLEEDACT, standing for Bleeding After Cardiac Treatment, which is a prospective investigator-initiated registry on real-life non-cardiac bleeding among cardiovascular patients, with the main aim to explore the knowledge on the phenomenon of bleeding in non-cardiac departments. With the help of the educational platform of our Polish National Society, we created or we proposed a CRF to gather data on the patient-related and bleeding-specific data, and data from the follow-up on the short and mid-term regarding the hard endpoints and the endpoints related to bleeding, all in patients admitted to non-cardiac departments, especially those treated from cardiovascular reasons, with special attention to the type and indication of this treatment, antiplatelet or antithrombic, with the special focus on those patients who experience bleeding either in acute or on periprocedural setting. So unfortunately, I cannot present you any results as we are just about to launch the registry in upcoming months. So my take-home message would be the kind invitation to all of you, the members of the great network, to join this registry to help us solve this tricky issue on the multidisciplinary and multi-center platform. Thank you.
So Beata, thank you for this nice presentation and for highlighting this important problem and for initiating and hopefully leading over the next years important research that will allow us a better understanding this issue. Questions on the topic or possibly for the details of the registry? Yes, please.
Okay, thank you for the opportunity. So my name is Dr. Putri Kamila. I'm cardiologist, so this is a very much a pretty hot debate in cardiology. Most of cardiologists are like, we tend to more cautious or concerned or maybe afraid in ischemic event. We tend to like, we're not really that concerned of bleeding, but we are very afraid that our patient might be getting ischemic events. So what your presentation just now is very interesting in terms of, as a cardiologist, we have to take considerations in prescribing our patients antiplatelet, for example. But my question is, what about maybe giving them a less potent antiplatelet type of medications rather than maybe just shortening it or not giving it at all? What do you think about it? Can we maybe prescribe them with less potent antiplatelet rather than not giving the antiplatelet for the patients? And the second one is, I agree that most of the guidelines is based on Europeans populations, whereas from Asia, we do have this sense of a higher bleeding risk in Asian patients. And we still use another forms of antithrombotic medications such as like vitamin K antagonists and everything. So we still use that. Do you really think that this can be applied to other populations rather than maybe European populations? Thank you.
Thank you for your question. Really, it's a broad topic and hard to close in one question, one answer. However, regarding the first one, I guess that the registry will give us some information about any modification of treatments that would balance the risk of thrombosis and bleeding in the real world. Because all the trials we have, they of course give us some remarks and some indications. However, those patients that bleed, we don't see actually, and we are not completely aware of the problem on the scale in the real life. So that's why we went out of cardiology and asked non-cardiologists of their feeling first, and they feel very happy actually with this topic. Unlike the cardiac surgeons, like we thought, well, there was a talk, I think, first or second, that they are not much happy to join because it was their complication. Actually, bleeding is our complication that makes that is very problematic to treat by other disciplines of medicine. So I hope this would be another side of view and give us some information more. And about the second question, in Europe we also have some recommendations for the high-risk patients of bleeding. And of course, we also implement some preventive strategies, preventive methodology. We reduce the doses, we adjust, we change the agent within the group of drugs. However, again, we don't see what's next actually in the field, out of the hospital. So I hope that our registry will give some answers to this.
Excellent. Thank you, Beata.
Thank you.
Neue Männer braucht das Land. Martin and John, you want to join, please?
Dear colleagues, we don't want to waste time and go ahead. My name is Martin Möckel. I'm from Charité. I'm a cardiologist leading the ED here at Charité. And together with John, it's not Holger, although he looks similar, very similar, but Holger's not available at the moment, so he steps in. And we go directly into the first talk. And the first talk is about echocardiographic pattern of left ventricular function recovery in tachycardia-induced cardiomyopathy. This is a really interesting topic because the assessment of the LV function in atrial fibrillation and tachycardia by echo is very demanding, and I'm very keen to see your results. Please.
Thank you. Dear chairs, dear colleagues, dear friends, I'm very grateful to be here in front of you today to present the findings of our study involving arrhythmia-induced cardiomyopathy and more specifically tachycardia-induced cardiomyopathy. To illustrate just how tricky it is to diagnose arrhythmia-induced cardiomyopathy, I will start with showing you two patients. The first patient comes to our clinic with a very dilated left ventricle and a very dilated left atria, having atrial fibrillation and a poor left ventricular ejection fraction. We decide to treat the atrial fibrillation using pulmonary vein isolation, and 1 year later we see a dramatic improvement and recovery in the left ventricular ejection fraction, and the mitral regurgitation also improves significantly. So what kind of disease does this patient have? Well, of course, it's the arrhythmia-induced cardiomyopathy, because after treating the atrial fibrillation, the left ventricular function recovered. We have a second patient, comes with a very similar picture, so a very dilated left ventricle, a very dilated left atria in atrial fibrillation. We decide to adopt the same treatment, pulmonary vein isolation, and 1 year later there is absolutely no improvement. Why? Because this patient has idiopathic dilated cardiomyopathy, so we do not know basically which disease caused which disease. Was it the left ventricular dilatation that led to the appearance of the atrial fibrillation, or was it the other way around? Now, what is arrhythmia-induced cardiomyopathy? It's a subtype of acute heart failure that is caused by atrial fibrillation or atrial flutter or sustained tachycardia, in which case it is called tachymyopathy, or it can be induced by right ventricle pacing, and it can also occur in the case of frequent PVCs. Now, regardless of this, there are several questions that remain unanswered, like, is this completely reversible, just like everyone is telling us? How does the left ventricular geometry look like after we treat it? And do these patients have diastolic dysfunction, or do they really recover completely? Does this translate to an improvement of symptoms if we adopt treatment of the arrhythmia? And last but not least, what are the outcomes? Now, these are the questions that we are trying to answer in the AICM registry, which is a retrospective and prospective registry, the largest of its kind in the world. And in the retrospective registry, we have almost 2,000 patients with a suspected arrhythmia-induced cardiomyopathy. And this is the distribution of the arrhythmias in this cohort. Around 80% have atrial fibrillation and 22% have ventricular extrasystoles. And of course, some patients have more than one kind of arrhythmia. And at the same time, we have started the prospective recruitment of patients. At this very point, we have around 400 patients included, but we intend to include around between 1,200 patients to 1,500 patients in the next 5 years at a minimum of 5 centers worldwide. Now, as for the methods of the paper I am trying to show you today, we used some very strict methods of selecting the patients. So the patients had to present with a baseline echocardiographic examination with a very poor ejection fraction and an active arrhythmia. And at the follow-up, they had to have a normalization of the left ventricular ejection fraction, or at least 15% improvement in the left ventricular ejection fraction. Then 2 cardiologists took a look exactly why this happened. Was it the treatment of the arrhythmia that led to this improvement? In this case, the patient had arrhythmia-induced cardiomyopathy. Or was it some other kind of treatment like stenting or like valve replacement therapy? And we included 238 patients, 31% were female, and the median age was around 70 years old. And there was also almost 2 years between the first and the second TTE examination. When completing the gold standard of diagnosis, 127 patients had tachycardia-induced cardiomyopathy, and 111 had other forms of cardiomyopathy, around half of them having ischemic heart disease. So compared to patients with other forms of cardiomyopathy, tachycardiomyopathy patients had a persistent dilatation of the left atria and the left ventricles despite the treatment and the recovery of the systolic function. The fractional shortening improved drastically more than the controls, and almost 60% of the patients had persistent diastolic dysfunction after treating the arrhythmia. These findings were published earlier this year in ESC Heart Failure, but there are several questions remaining unanswered, like, is arrhythmia-induced cardiomyopathy truly a new cardiomyopathy? For this, of course, we need outcome data, and there is truly no data currently published, and we are actively working on it. And I would like to show you some of the preliminary results. So regarding the rates of heart failure decompensation and cardiovascular hospitalization, we see that tachycardiomyopathy and other forms of cardiomyopathy look basically the same. So the rates are comparable, with the mention that in case of isolated tachycardiomyopathy, the rates are a little lower because most of the patients can also be treated ambulantly. Now, the most important probably is the rate of death and life-threatening arrhythmias. And here we see basically the first problem. Patients having tachycardiomyopathy, isolated, but also overlapping on some other form of cardiomyopathy, so impure tachycardiomyopathy, have worse outcomes. Of course, the numbers are very small, and there is a low number of outcomes, so this can also be just a matter of randomness. But this raises an alarm signal that we may have missed this kind of arrhythmia for quite some years. To draw a conclusion is way too early, I think. But what I can already say is that arrhythmia-induced cardiomyopathy has been missed for years, that each arrhythmia-induced cardiomyopathy episode leads to a further remodeling of the left atria and the left ventricles, and that despite the recovery in the left ventricular ejection fraction, persistent diastolic dysfunction is very common. The first look at the outcome data provide a worrisome perspective from my point of view, and for this reason, early discovery and treatment of this kind of acute heart failure is warranted, but at this moment is very hard to do. Thank you for your time.
Yeah, thank you very much for this elegant presentation. So yeah, please.
Thank you for the presentation. Which is the cutoff for considering tachymyopathy? If it is 100, or what do you consider this is tachymyopathy? It is related to the heart rate.
For the purpose of our paper, we use the heart rate of 100 beats per minute to name it tachymyopathy. But of course, in case of atrial fibrillation, we know that the frequency varies a lot.
I have also a comment. From a clinical point of view, there is also a clinical dilemma in emergency department. If there is pre-existing dilated cardiomyopathy, a non-dilated cardiomyopathy with new onset atrial fibrillation versus tachycardia-induced cardiomyopathy, which is the factors that will recognize its condition in this setting? The dimensions, the reversibility after restoration.
So in case, I can only speak about the atrial fibrillation because there has lately been published a score to predict patients that will recover the ejection fraction after treatment of the atrial fibrillation with pulmonary vein isolation. This was the Antwerp study and was published some days ago. And they found that in left atrial dilatation, patients with paroxysmal atrial fibrillation and patients having no known etiology of heart disease are likely to recover, so that are likely to have arrhythmia-induced cardiomyopathy. And this was validated in our hospital as well.
Okay, one final question in the back.
Hi, thanks a lot for the talk. I'm just interested that the patients who go back into sort of sinus rhythm, you say the diastolic filling pressures are still high and that doesn't resolve. And I just wonder if you thought about these patients are actually on the spectrum of the heart failure, preserved ejection fraction, and actually their risk of arrhythmia is just higher, and whether or not the baseline demographics are different from heart failure, reduced ejection fraction, if you know what I mean, in terms of their weight, prevalence of comorbidity like hypertension and diabetes, etc.
So from our data, there does not seem to be any baseline differences regarding patients with preserved ejection fraction and reduced ejection fraction. They are, from our point of view, they are comparable, and there seem to be some completely unknown factors that are leading to a worse decrease in the systolic function in these patients, but at this very moment we are unable to tell you, I'm unable to tell you exactly what are these factors, and we are giving our best to research it in some further studies.
Okay, thank you.
Thank you.
Let's move to the next speaker, who is Desiree Carmine from Switzerland, who will present data about the association of blood pressure, cognitive function, and brain lesions in patients with atrial fibrillation.
Dear Chairman, dear colleagues, thank you very much for the opportunity to be here today. I'm very happy to present a part of my doctoral thesis with the title Association between Blood Pressure, Brain Lesions, and Cognitive Function in Patients with Atrial Fibrillation. Let's start with some background information. Atrial fibrillation is the most common cardiac arrhythmia, affecting up to 1 out of 3 individuals. Also, hypertension is a very common condition, with a global burden that reached 1 billion people in 2019 and representing a leading modifiable cause of premature death. Both conditions are known to increase the risk of brain lesions and cognitive impairment, and a cross-sectional study in patients with atrial fibrillation had already shown an association between blood pressure levels and brain lesions. Considering the high frequency of both atrial fibrillation and hypertension and the increasing global incidence of dementia, a better understanding of their longitudinal association may be relevant. The aim of this study is to assess the impact of blood pressure on presence and volume of new brain lesions after 2 years, and on cognitive function over 7 years. Today, I won't speak about the cognition part because it's still work in progress. Patients selected for this analysis were enrolled in the Swiss atrial fibrillation study, a prospective ongoing cohort study that enrolled 2,415 patients across 14 centers in Switzerland. Patients are seen each year, and at each visit, we perform cognitive testing and collected several clinical variables. At baseline and after 2 years, we also performed brain MRI, standardized brain MRI. For this analysis, we only included patients with available blood pressure measurement at baseline, as well as data from brain MRI at baseline and after 2 years. Patients also had information about cognitive assessment at baseline at least one cognition follow-up over 7 years. Our main predictor was continuous systolic blood pressure, but we also categorized blood pressure according to the European Society of Cardiology guidelines of 2018. Our main outcomes were new lesions after 2 years. We define new lesions as actual new lesions, but also lesions already present at baseline, but with an increased volume after 2 years. Relevant findings were ischemic lesions, which comprehended large or small infarcts involving or not involving the cortex, and white matter lesions. For our statistical analysis, we performed logistic regression analysis to assess the association between blood pressure and presence of the lesions, and linear regression analysis for the volume of the lesions. Let's jump to the result. We enrolled 1,213 patients. 74% were male with a mean age of 71 years. Mean Chatwell score was 3 points, and mean blood pressure was 135/79. 90% of our patients were on oral anticoagulation. At baseline, 35% of patients had ischemic lesions, and almost everyone had white matter lesions. After 2 years, 5% of the patients had new or enlarged ischemic lesions, and 18% had new or enlarged white matter lesion. You can find here a bar chart of the prevalence of the ischemic and white matter lesion over the different blood pressure categories. Here, we couldn't find any significant difference among blood pressure categories. You can see here 2 forest plots for the multivariable adjusted logistic and linear regression model for prevalence and volume of the lesion. Here you can see the odds ratio, and here the beta coefficients with their confidence interval. Adjusting variables were, among others, age, sex, several comorbidities, and oral anticoagulation. We couldn't find any significant association between continuous systolic blood pressure and presence and volume of the lesions, but also across increasing blood pressure categories, using optimal blood pressure as our reference. Let's just pick an example to clarify it. Patients with hypertension grade 2 or 3 had an odds ratio of 2.18 compared to patients with optimal blood pressure for having new ischemic lesions. Considering that the confidence interval also include 1 and the p-value was greater than 0.05, these results weren't statistically significant. Very similar results could also be found for new white matter lesions. Strengths of this study are the detailed patient's characterization, the large amount of data available, and also the standardized brain MRI we performed. On the other end, main limitations are the unclear generalizability due to the inclusion criteria and also the residual confounding due to the study design. To sum up, we couldn't find any significant association between baseline blood pressure level with new ischemic lesion or new white matter lesion after 2 years. It could sound like good news. However, a long-term follow-up is still warranted to determine the impact of blood pressure on the development of new brain lesion after 2 years, or after a longer period of time, in patients with atrial fibrillation. Thank you very much for your attention.
Thank you for these very interesting results. How to measure cognitive function by mini-medal or other tests? Cognitive function.
For cognitive function, we mainly use the MoCA score, but we also perform tests for semantic fluency, digit substitution, symbol substitution test, and yeah.
The other point is that cognitive function is related with low patient compliance to the treatment. There is a vicious cycle that leads possibly to ineffective medication in these patients due to low compliance in medications. Is there any thought about that?
That's a very good question, and it's a very interesting point. Not really. We don't have any information about compliance of the patient. Yeah, we can ask the patient if they take the medication, but it's not a stable answer. But it's a very interesting point that we can thought about development, and a good question.
Okay, there is also a question here. Joseph.
Just a comment. The statement that there is no relation with his blood pressure is a little bit strong, because I think the hypertension 2 and 3, usually there are not many patients with these categories, and probably the tendency was very clear, but with a wide standard deviation. But I think the series is larger with more patients with grade 2 and 3. This will be significant for sure.
Thank you for this this comment. Yeah, it's true. I can only say that in this cohort we couldn't find significant association, but yeah.
Okay, one final question here.
Yeah, so I mean, there is an association with high blood pressure and brain ischemia. I mean, if you give angiotensin receptor blocker, it will prevent stroke and ischemic event. Do you think that the reason you don't see any association is because you take your patient too late, meaning that their organism had time to adapt to the high pressure regimen and therefore is less susceptible to mismatch between blood pressure and the vasculature?
I'm not sure that I understood the question, sorry. But I think we didn't see any significant association, maybe because 2 years are just not enough to see this significant change in the volume in the incidence of new lesions.
Okay, thank you very much. So the next speaker is Adrian Schweigler from Switzerland, and he's talking about the prediction of adverse cardiovascular outcomes in patients with AFib and cystatin. So please go ahead.
Thank you very much for the introduction. I'm very honored to be here and speak about my dissertation topic. I'd like to speak about kidney function by creatinine and cystatin C, adverse cardiovascular outcomes in patients with atrial fibrillation. So, there's an issue with the, yes. So imagine we have a patient with newly diagnosed atrial fibrillation and a reduced kidney function. What do we do? I think we all know this patient has a high risk of stroke, so we calculate the Janssen score and probably give him oral anticoagulation. But even though the patient now is on oral anticoagulation, he has an increased risk for ischemic events and major bleeding, as well as an increased overall mortality. In this situation, an accurate estimation for the kidney function is key for proper risk assessment. We normally do that in clinics by estimating the GFR based on creatinine. That's how we do it in clinics every day. But how could we improve our GFR estimation in clinics? Well, maybe that's the answer. Cystatin C is a protein produced in all nucleated cells all over your body. It is almost completely reabsorbed and catabolized in your kidneys, and it is independent from muscle mass, which is one of the major limitations of creatinine. It is also not affected by autoimmune or consuming disease, although this point is in a lot of discussion recently. Again, some trouble with, yes. To my study design, we have almost 4,000 patients from 2 big observational multicenter cohort studies, the SwissAF and the BTF study. Here you see the map of Switzerland with all the centers. The main inclusion criteria was, of course, atrial fibrillation, an age over 65, and no acute illness for the past month. Then we collected blood samples at baseline and calculated the GFR. We did 3 different kinds of calculations. So there was one based on creatinine as the gold standard, one based on cystatin C, and a combined formula with both biomarkers together. Then we did multivariate Cox regression analysis and calculated the hazard ratio. Our primary outcome was major adverse cardiovascular outcomes, events, short MACE. This is a composite of stroke, systemic embolism, myocardial infarction, and cardiovascular death, so mainly ischemic events. And in addition, we did major bleeding as well. Aim of the study was to compare the association of the 3 different GFR models with MACE and major bleedings. Already coming to the results, here you see the baseline characteristics stratified by the combined GFR. You can see that from our 4,000 patients, 71 was the mean age and 28% were female. You see the CHA2DS2-VASc score, and you can nicely see that the lower the GFR, the more comorbidities the patients have. Here we see the type of atrial fibrillation, and here you see the higher the GFR, the more paroxysmal AF the patients have, and the later or the lower the GFR, the more permanent or persistent atrial fibrillation. Here you see that 84% are on oral anticoagulation and 48% on VKA. That's mainly because the baseline of the study was 8 to 10 years ago. Now it's a bit lower and a bit more NOAC. Here you see a forest plot of the hazard ratio of the multivariate Cox regression analysis. Here on the bottom, you see that it's adjusted for 11 different possible confounders, and the results are standardized. So all results are per 1 standard deviation to make them all comparable with each other. You can see that MACE is significantly associated with all 3 different GFR models, as well as cardiovascular death. But more interesting is that major bleeding is not associated with the GFR based on creatinine, but still is significantly associated with the GFR based on cystatin C and the combined one. Here you see 2 ROC curves for my 2 major endpoints and the 3 different GFR models and the area under the curve. I can tell you all GFR models differ from each other significantly. And as you can see in both graphs, cystatin C seems to perform the best. Already coming to the conclusion. So GFR based on cystatin C is associated with ischemic events, as well as major bleedings and cardiovascular death. So maybe it gives a more complete risk stratification in patients with atrial fibrillation and reduced kidney function. We also have some limitations. Due to the study design, no real causality can be inferred. And we have a quite small number in the lowest GFR group on the 30, but it's still over 200 patients. And as always, there's still further research needed in this field to really be sure about the data. And with that, I want to thank you for the opportunity to be here, and I'm really looking forward to present my data then in the ESC in August. Thank you very much.
Yeah, thank you very much. Any questions from the floor? Meanwhile, I would like to ask you, I think the rock curves were quite similar. They are numerically different, but the difference is very small. So do you think that this translates to some clinical benefit if you assess your patient with cystatin instead of the more cheap and more available creatinine method?
Yeah, I knew that point's coming with the cost. It is one of the major limitations, the cost of the cystatin C. I think even though the rock curves are quite similar, it is significantly different. And I think that cystatin C is also associated with major bleedings. It gives a better or a more complete risk stratification. I think it could improve our stratification in this special setting I told you.
Any more questions? So what is your thought about other new renal markers like, let's say, NGAL or KIM1 or PENK?
Well, I cannot say a lot about other biomarkers because we really were limited because the study was not focused on nephrology. But I can say that I think with this data, maybe cystatin C would be interesting to have further research about.
However, the clinical use of cystatin is limited. I think in only one trial, the ROSE trial, was the endpoint. In all other trials, the GFR changes is the endpoint in clinical practice. That means that we need more data about that in clinical practice. Okay, thank you very much. And we will move to the next speaker, who is Peter Raphael from Switzerland also, who will present data about the association of smoking with structural brain deficits in atrial fib switch, atrial fib registry.
Yeah, thank you very much for the introduction. And good afternoon to everyone, and thank you to give me the opportunity to present you my work, cigarette smoking and structural brain deficit in patients with atrial fibrillation. So some background information at first. Structural heart disease like atrial fibrillations and cardiovascular risk factor like blood pressure are associated with the presence of brain lesions. And on the other end, we have smoking, who can affect directly the brain structure, but also indirectly by the elevations of cardiovascular risk factors. And smoking habits are very, very different and variable, and they can have a different effect on the brain. Like smoking duration and the doses of cigarette smoke per day can affect differently the brain. So we wanted to analyze the association between smoking and brain deficits in patients with atrial fibrillations. In order to do so, we performed a cross-section analysis of 728 patients from the CCF cohort study, whom my colleague already spoken about, and we excluded the patients with no MRI or missing smoking informations. Smoking characteristics were self-reported by questionnaires, and we use a standardized MRI to detect the white matter lesions graded by the Fonseca score, the small non-cortical impacts, and the gray and the wider matter volume. SNCI were defined as hyperintense lesions with a diameter smaller than 20 millimeters, not involving the cortex, and white matter lesions were identified as hyperintense lesions in periventricular or deep white matter regions. We then performed an adjusted multivariable logistic and linear regressions. The predictor was smoking status, defined as never, ex, and current smokers, cigarette smoke per day as collected at baseline visit, and we also asked for the smoking start and smoking cessation. With that, we calculated smoking durations and the time to smoking cessations. The outcome were incidence of small non-cortical impacts and white matter lesions if the Fonseca score was equal or greater than 2, and the volume of gray and white matter. Here are some baseline characteristics, and the first thing is that the major group was never and ex-smokers, that the never smoker were more female, and that the current smoker were younger and had more history of diabetes. Ex-smokers suffer more of heart failure, coronary heart disease, myocardial infarcts, The alcohol consumption differs substantially, with never smoker having the lowest consumption, ex-smoker drinking significantly more, and the current smokers having the highest consumption. And the current smokers were less likely to be under anticoagulation therapy and suffer more of paroxysmal atrial fibrillations. For the smoking characteristic, the current smokers, they reported to smoke less cigarettes per day, but they smoke also for longer time, like 46 years compared to the 24 years of the ex-smokers. And then we divide intersil for the analysis. And time since smoking cessation was a mean age of 29 years, and we divide it in 4 groups for the analysis. The first result is that about the incidence of white matter lesions if the FASECA score is equal or greater than 2. And the first thing, there was no significant association in the smoking status, but we find it in the smoking years, in the smoking durations. With patients who smoke between 19 and 30 years and more than 45 years, having more probability to have a white matter lesions compared to patients who smoke less than 18 years. Then there is the incidence of small non-cortical infarcts, and there was again no significant associations in smoking status and this lesion, but there was in time since smoking cessation, with patients who stopped smoking between 11 and 15 years and more than 16 years prior assessment, having less likely to have a small cortical infarct compared to patients who stopped smoking prior 5 years the assessment. Moving on to the brain volume, and here you can see the results of the gray matter, and there was again no significant association in the smoking status. But in the cigarette smoke per day and in smoking durations, we can see that the patients who were in the highest group of cigarette smoke per day and smoking duration had the less gray matter compared to the lowest group. And about the volume of the white matter, we found an association in the patients who stopped smoking between 11 and 15 years compared to patients who stopped smoking more recently. They had more white matter compared to these patients. So some of the limitations were that our groups different a lot from each other by the smoking status and the cross-sectional nature of the study. But the strength were that we comprehensively collect the smoking habits, and we use an MRI standardized. And to conclude, we found no significant association in structural brain deficits for smoking status, but an association between incidence of brain lesions with smoking durations and time to smoking cessation, and a significant association between the doses and the duration of smoking with gray matter and time to smoking cessation with white matter. So thank you for your attention, and now I'm happy to answer some questions.
Thank you, very nice presentation.
Thank you.
Any question? Here.
You showed that in particular in ex-smoker, there were people that were more prone to substance abuse or use. I mean, they were drinking more and they were less compliant with their treatment. So how can you distinguish the sole effect of smoking, or formerly smoking, from a more general behavior towards various substances?
The last words?
Substances like alcohol, cigarettes, etc.
Yeah, it's difficult to do so. We adjusted for the alcohol consumption and also for like other factors that can affect the brain structure. Like we collected a depression score, and we adjusted also for that. But the nature of the study, it's difficult to differ from the two things. The better we could do is collecting the alcohol consumption and adjusting.
So thank you very much. For the sake of time, we are going on.
Okay, thank you.
So the next presentation is from Simon Weidlich from Switzerland. There he is, and he will talk about impact of clinical expertise and choice of smart device on accuracy to detect AFib via single lead ECG. So please.
Thank you. Good afternoon, everyone. I'm happy to speak about impact of clinical expertise and the choice of smart device on accuracy to detect atrial fibrillation via single lead ECGs. So I have no conflict of interest to declare, and let's start. Since 2020, smart devices or single lead ECGs that are 30 seconds or longer are allowed for atrial fibrillation diagnosis. And smart devices often come with an automated rhythm classification automated classification. And there are an estimated over 210 million users of smartwatches worldwide this year. But the problem is with this automated rhythm classification that around 20% are inconclusive and manual interpretation is needed. And the other problem is if manual interpretation is needed, there are several different smart devices. Each has a different curve, each has a different design and other processing. So our aim was to compare or to see how the clinical expertise influence the accuracy to correctly identify atrial fibrillation with this smart device generated single lead ECGs, and if there's a difference between the smart devices. How did we do that? We made an online survey and distributed the link for the answers. And inclusion criteria where they had to be 18 years or older, they had to provide online informed consent, and they had to be medical personnel, so medical students, residents, or specialists. And the quiz consisted of, included 10 patients, 5 had atrial fibrillation, 5 had sinus rhythm. We recorded 5 single lead ECGs from each patient with 5 different smart devices. So in the end, we had 50 different single lead ECGs. The participants could classify or rate them in blocks of 5, so not all rated all 50 single lead ECGs. The possible answers were sinus rhythm, atrial fibrillation, or inconclusive. And inconclusive with the intention to diagnose, sorry for the words, we counted them as false negative or false positive. So we used the following 5 smart devices: the Apple Watch 6, the Samsung Galaxy Watch 3, the Withings Scan Watch, the Fitbit Sense, and the AliveCore Cardio Mobile. And we made a comparison between cardiologists, internal medicine residents, and medical students, as well as between the smart devices, previous ECG knowledge, and preference in single lead ECG design. Here's the baseline data. As you can see, females were represented with 55%. The median age was 27, so rather young. 21% had previous experience with single lead ECGs. In the cardiology, specialist cardiology, there were 69%, so 30 had no experience. And the average looked ECGs per week were around 1 to 25. So overall, we had 450 participants, which rated 10,865 single lead ECGs. The overall median accuracy was 64%, and a rather large amount of 22% were labeled as inconclusive. Here you can see that the accuracy to correctly identify atrial fibrillation via single lead ECG is significantly dependent on the levels of expertise. But if you look at the sensitivity and specificity, we see that bachelor students only had accuracy of 50%, so not better than a coin flip. But interestingly, specialists in cardiology weren't so good either. They only had an accuracy of 81% and a sensitivity of 72%. And if you look at the different smart devices, we could not find a significant difference. So it doesn't matter which smart device the ECG was. But if we ask the participants if they had a preference in design, well, there was some tendency seen. But even though there was no significant difference between the smart devices used, we could see that if someone had a preference in a certain design, they were better regarding that design. Vice versa, so if they disliked design, they had a worse accuracy. So to conclude, single-lead ECGs can be very difficult for interpretation and challenging to classify. And the clinical expertise plays a role on the accuracy. And the choice of smart device doesn't seem to play a role, but the preference in design could influence the personal accuracy. So thank you for your attention.
Yeah, thank you for this interesting data. So any questions? So my question is, what was your gold standard for AFib? So do you had a 12-channel ECG of the same episode, and that's your gold standard, or do you have an echo? Or?
No, exactly. It was a 12-lead ECG we made right before the 5 single-lead ECGs.
Okay, thank you. Yeah, one question, Luella.
So based on your study, which smartwatch should I buy?
That was very clear, I think.
Well,
can we talk about that in the break, please?
Sure.
So okay.
Okay, thank you.
Okay, one final question.
Okay.
Sorry.
I'm sorry.
What kind of implementation could be done to smartwatch to reduce the number of inconclusive measurements?
Well, with the new coming AI, that's a good point. So we're also working with an AI algorithm, and with that, the inconclusive rate is way lower.
Okay, thank you. Last speaker. Last speaker is Anda Boularga from Scotland. Rapid rule-out pathways in the real world.
Thank you very much. Thank you very much, dear audience, for letting me present. I'm kind of crashing this kind of topic. I'm going to go back slightly to our beloved high-sensitivity cardiac troponin and acute coronary syndrome. My name is Anda. I'm one of the research fellows working with Professor Mills in Edinburgh, and I'm going to talk in the next 7 minutes about the performance in the real world of an early rule-out pathway for myocardial infarction. I'll keep it brief, I promise. So I don't have any conflicts of interest to declare. And just a little bit about the background. We all know very clearly, as the guidelines suggest, that we should be using early rule-out pathways for myocardial infarction with high-sensitivity cardiac troponin when assessing patients with acute coronary syndromes, with suspected acute coronary syndromes. It's challenging, and whilst this has been widely applied in clinical practice, these pathways have been derived from selective patient cohorts in research studies. And the question is whether the performance of the pathways and also the effectiveness of these pathways differs when applied to real-world, day-to-day clinical practice. So there was this large prospective patient cohort study done a few years back that looked to evaluate the influence of patient selection on high-sensitivity cardiac troponin testing and myocardial infarction across populations in the UK and the US. And the study authors showed that when troponin testing is performed widely, then elevated cardiac troponin concentrations are very, very common. However, the underlying cause for this is more likely to be myocardial injury rather than myocardial infarction. As such, they concluded that the selection of patients for high-sensitivity cardiac troponin testing influences the prevalence of myocardial infarction. The positive predictive value improved when things like symptoms and signs and underlying risk factors were considered. Furthermore, the authors also showed that there is variability across practices with troponin testing across the pond and across the world. So what we aimed to do was to evaluate how the selection of patients influences the performance, the diagnostic performance of the high-stakes early rule-out pathway when considering patients with suspected acute coronary syndrome. So we had 2 cohorts of patients. All these patients came to the emergency department across 3 acute care hospitals in Scotland. These patients had suspected acute coronary syndrome. All these patients underwent high-sensitivity cardiac troponin testing with the Abbott Architect high-sensitivity cardiac troponin I, and the diagnosis was adjudicated according to the 4th universal definition of myocardial infarction. We had 2 cohorts of patients, so I'll quickly explain about that. So we had an unselected cohort of patients. These were patients coming into hospital, all consecutive patients, as part of a service evaluation work. And we also had a more selected cohort of patients consented to take part in a research study that were enrolled during daytime hours by research staff. So our study populations, so the unselected patient cohort, those involved as part of clinical practice, comprised of 1,242 consecutive patients with suspected acute coronary syndrome, and the research study we had 1,695 patients consented to take part in research. Very briefly about some baseline characteristics. As you can see here, the median age was similar in the 2 cohorts. There were slightly more females in the consecutive patient cohort, in the unselected cohort. Chest pain was the primary presenting symptoms in both cohorts. And 1 in 7 patients had evidence of elevated cardiac troponin. However, interestingly, similar to previous data, the prevalence of myocardial infarction as a final diagnosis was lower in the unselected cohort. So, just going to the results and talking about the performance of the high-stakes pathway. I first want to concentrate on kind of the first step following the initial troponin testing. So we look at the low-risk category, those with a result of less than 5 nanograms per liter, the intermediate group, 5 to the 99 centile, and those in the high-risk group with ECG changes or troponin concentrations on admission of more than the 99 centile. So you can see here that in the unselected clinical care cohort, there were more patients in the low risk, whilst in the selected patient cohort, there were more patients that went into the intermediate category and required serial testing. So the next step of the pathway is to look overall at the diagnostic performance, those ruled out and ruled in. And as you can see here, in the unselected patient cohort, more patients were ruled out, whilst with excellent negative predictive values, similar across both cohorts, whilst when we think about the rule-in of the pathway, in the unselected patient cohort, there were less patients ruled in with a lower positive predictive value. So very quickly here, we also classified the patients who were ruled in according to the underlying adjudicated diagnosis. And as I mentioned before, you can observe some differences here. So there were more patients with a type 1, 4B or 4C myocardial infarction in the selected patient cohort. However, when thinking about acute or chronic myocardial injury, there was a difference there as well. We had many more patients in the unselected patient cohort. So the performance of the early rule-out pathways for acute myocardial infarction are likely to differ when applied to clinical practice because the prevalence of myocardial infarction differs in these populations. In clinical practice, there are fewer patients ruled in with a lower positive predictive value for myocardial infarction. However, there are more patients safely ruled out admission without compromising safety. Thank you very much, and I just want to thank all my colleagues and mentors and supervisors, and welcome any questions.
Thank you, Ada, for this very nice practical study. Is there any evidence for cost effectiveness about this project?
So we haven't...
How many time save in emergency department with this protocol?
So
if there is saving also costs?
Yes, so thank you very much for that question. So part of the high-stakes trial and also the follow-on historic trial, we have showed that the implementation of the high-stakes rollout pathway has significantly improved the flow of patients in the emergency department with kind of less length of hospital stay. So yes.
Question is, this troponin was from laboratory measurements or from point-of-care system?
So all these troponin testing was done laboratory.
Laboratory. Yeah. What about the point-of-care systems with high sensitive?
So it's again, a very great question. I think this is kind of the next area that we're working on to develop to improve the efficiency of implementation of these pathways. But I haven't tested in this work here now.
Thank you very much for this very interesting talk. But your first conclusion in the last slide, you said positive predictive value is low because the incidence is low. Is that correct? Positive predictive value is low because we include wrong patients in the pathways.
So again, a very, very good question. So I think there is kind of a number of reasons why this may be the case. Those patients that we include in research studies, perhaps they are more selected patients, patients who want to participate in are kind of the worried patients about their health with maybe more risk factors for cardiovascular disease. Whilst we know from this data and previous data that in patients who, in the overall kind of day-to-day population, there is more patients that we would be testing that will have other reasons for an elevated cardiac troponin rather than myocardial infarction. So I think it's influenced by that as well.
Okay, so thank you very much again. So I close the session. We consumed 20 minutes of the break, and I asked one of the organizers whether we want to shorten the break a little bit. So let's reconvene in 20 minutes at 4. Yes. Okay, so back here at 4 p.m., please.
One minute to go. Please take a seat and we'll try to be in time since we have still some more communication to be done. So, okay. It is now my great pleasure to chair with my co-chairman, Professor Ruella Vaughan from UK, this session on proteomics and AD, Young Expert on Stage, 7-minute presentation plus 3-minute discussion. So let's start with the first presentation from Arinal Charul Achar from Indonesia, cooperating with our group in Italy. He's going to talk about enibacimab in the treatment of patients with acute heart failure, a pilot study in Indonesia. Please, Arinal.
Thank you, the chairman, for the nice introductions. Good afternoon, ladies and gentlemen. I'm Arinal Herul Ahyar from Universitas Gadjah Mada, Indonesia. At this great occasion, I'd like to share and talk about our collaborative research with Great Network Italy entitled Enibacimab in the Treatment of Patients with Acute Heart Failure, a Pilot Study in Indonesia. So, acute heart failure has short-term mortality during and after acute heart failure hospitalization, in which it's correlated with rehospitalization events. And unfortunately, there were no available treatments currently in improving this outcome. And this poor clinical outcome could be predicted by the high level of bioadrenomedulin after 7 days of decongestion therapy. And to address body congestions, a common intensified diuretic therapy might be harmful to the renal functions and furthermore could worsening the patient's mortality rate. And pathophysiologically, the bioadrenomedulin will increase as a response to body congestions. And bioadrenomedulin itself acts on the vascular endothelial cells to promote vascular integrity, and it also acts on the vascular smooth muscle cells to regulate the vasodilations. So let's talk about enibarcimab, or formerly known as adrecizumab. So enibarcimab is a humanized monoclonal antibody that dose-dependently binds to adrenomedulin, but doesn't significantly inhibit the adrenomedulin functions. And enibarcimab itself is assumed to be able to increase the functional intravascular plasma level of adrenomedulin, hence it could inhibit the fluid redistributions and intravascular fluid accumulations as the therapeutic goal of acute heart failure treatment. However, enibarcimab profile in acute heart failure treatment is still not widely known, so our study was aimed primarily to evaluate the safety and tolerability of increasing doses of enibarcimab in acute heart failure patients class functional 2 until 4 based on the standard of the care. And our study was a multi-center prospective open interventional phase 2A clinical trial and also a preliminary study that conducted in Malang and Yogyakarta Heart Center, Indonesia. Okay, 20 subjects were treated open label with enibarcimab during 48-hour period following hospital admissions upon the completion of eligibility and informed consent signature, in which each 10 subjects will receive dose of 0.5 milligram per kilogram body weight or dose of 2 milligram per kilogram body weight, while the remaining 10 subjects received only the standard of care alone. So the administration of enibarcimab itself given in the fashion of dose escalation cohort. And during the first hospitalizations, all subjects were evaluated daily for the safety profile and tolerability profiles. And as additional value, we also evaluated the clinical efficacy and through the assessment of composite congestion score and also dyspnea score, and also serial biomarkers measurement that including bioadrenomedulin, NT-proBNP, proenkephalin, and also HS-troponin I that was utilized to exclude any acute coronary syndrome events during the first hospitalizations. All subjects were hospitalized at least 5 days, and after that, all patients will be discharged and will receiving a telephone call as the follow-up of the 90 days since the first enrollment. During this 90 days period of follow-up, all patients will be evaluated for the deaths and rehospitalization events. And let's see our baseline patient characteristics. We found that there were no significant clinical difference in baseline patient characteristic, either on demography profile, clinical profile, or laboratory profile. And let's move to our result. First, we found that there was strong relationship between composite congestion score and dyspnea score at the baseline level. And enibarcimab infusion at the both doses could comparably improve the clinical features of acute heart failure at the parameter of dyspnea and composite congestion score that markedly seen on the first 24 hours following enibirtumab infusion. Next, the clinical improvement of clinical features in acute heart failure patient might be explained by the increase of bioadrenomedulin and along with simultaneous reduction of anti-proBNP plasma level that were sustaining for at least 96 hours following single intravenous administrations of enibirtumab. And obviously, the higher dose or 2 milligram per kilogram body weight of enibirtumab produced more significant, stronger effect in the reduction of anti-proBNP plasma level and increase of plasma bioadrenomedulin. And moreover, we revealed also there was a linear relationship between proenkephalin and plasma creatinine level at the baseline level. And surprisingly, the enibirtumab administration could show its diuretic properties, as we can see at the net fluid balance percentage change. And interestingly, the enibirtumab itself showed its diuretic properties without any impairment of renal function. As we can see here, there were no significant increase of creatinine or proenkephalin during the first hospitalization period. And last, as our primary endpoint, both doses of enibirtumab showed comparable tolerability profile, even though at the higher dose of enibirtumab caused a slight reduction in systolic blood pressure following 1 hour infusion of enibirtumab. And promisingly, the higher dose of enibirtumab resulted in shorter length of the first hospitalization. And happily, we also revealed that both doses of enibirtumab achieve a good safety profile, as there were no significant difference in rehospitalization events and also death events during 30 days, 90 days, and also 30 days, 60 days, and also 90 days follow-up. Collectively, we also found that subjects treated with enibirtumab had a better trend in improving all-cause 90 days all-cause mortality. So to summarize, we can conclude that the first and the most important point from our preliminary study is in acute heart failure patients, both doses of enibirtumab showed safety, were safe and well tolerable in acute heart failure patients. And secondly, as an additional point, since our sample size were quite small, we also can promote that enibirtumab infusion resulted in a significant increase of plasma intravascular bioadrenomedulin with the improvement of acute heart failure symptoms and congestions without any significant deterioration or worsening of patients' hemodynamic status. And last but not least, we recommend that a larger multi-center randomized control trial should be conducted to scrutinize the safety profile and clinical efficacy of enibirtumab in the acute heart failure patients. That's all my presentations. Thank you for your kind attention.
Thank you. Thank you very much, Arinal, for this very preliminary, interesting results on a new drug in acute heart failure. Now, the discussion is open. We have just time for 1, 2 brief questions from the audience. Luella, you want to start?
Yes, I've got a question. Thank you very much for an interesting talk. Did you, of course, acute heart failure is a syndrome rather than an individual disease per se. Did you look at the causes of presentation for the heart failure and whether there are any differences between the two groups?
Yeah. Thank you for the great questions. We had already also analyzed the etiology of heart failure, but we didn't show it this presentation. Mostly our subjects were etiologically came from the hypertensive heart disease and ischemic heart disease. But all among 3 groups, they were no significantly difference.
It seems to me that's really very interesting preliminary data that show that the drug is safe and then we need a multi-centric larger study to see the efficacy. No other question from the floor? Thank you very much again, Arinal, for a nice presentation.
And then next up we have Fidelio Giacomo, who's going to talk about the role of DDF3 in risk stratification in critically ill patients in the emergency department. Thank you.
Good afternoon to everybody. I'm Giacomo Fidelio. I'm an emergency physician from La Sapienza University in Rome. Today I would like to share with you our very preliminary results on ongoing study about the role of DPP3 in risk stratification of critically ill patients in the emergency department. Our initial question, which is the same one asked by this morning by Professor Tavares, was what could be the role of DPP3 in the critical care setting, and in which kind of patient could be useful the detection of DPP3 level. So, as you already know, DPP3 is a proteolytic enzyme involved in the metabolism of different peptides. The most prominent substrate of DPP3 is angiotensin II, the main effector of the renin-angiotensin system, which is implicated in the regulation of the cardiovascular system. And in healthy state, DPP3 is located intracellularly, and then it contributes to maintain the normal cell function. But according to the recent finding, when massive cell death occurs, for example, during cardiogenic or septic shock, probably after a massive cell death, DPP3 is released into the bloodstream, and here inactivates angiotensin II, leading to cardiovascular depression, and so hemodynamic instability and multiple organ failure occurs. However, previous clinical studies have shown the prognostic properties of DPP3. In particular in septic patient, in cardiogenic shock patient, and in severe ill burn patient. But to note that the most data about DPP3 are primarily focused on patients admitted to intensive care unit, but we have no data, few data about the emergency department. So this is our study. I want to underline that it's a very preliminary study with very preliminary results. Prospective, observational, single center, performed in San Giovanni Addolorata Hospital in Rome. We admitted patient only red code, so code 1, and after the triage assessment, in addition to the classic test, venous blood sample was taken, and for the detecting the DPP3 levels using the Nexus CB10 analyzer, that is a point of care with results in 20 minutes. The aims of our study were to determine if DPP3 level at the emergency department admission is associated with poor patient short-term outcomes, to investigate the role of DPP3 as an early marker of organ dysfunction and or death, and at least to compare the predictive value of DPP3 with clinical risk score. These are patients' characteristics. The median age, we divided patients into groups, survivors and non-survivors group. The median age was 83 years old, and the non-survivors were younger than the survivors group with a significant difference. Cardiovascular comorbidities were the most frequent coexisting condition. First hypertension, followed by atrial fibrillation, chronic heart failure, and 30% had cancer. 35% of patients had a diagnosis of shock, and most of them died. And in particular, if we focus our attention in death in the emergency department, 13% of patients died in the emergency department, and all these patients had shock. All these patients had high levels of DPP3, And all these patients had a length of stay in the emergency department lower than 24 hours. If we look at parameters, we can see that the median value of DPP3 was 38.6, with no significant difference between the two groups. And also other markers of organ dysfunction, such as lactate or high sensitivity troponin I, weren't a significant difference between the two groups. But we find a difference in clinical risk score, in particular Muse and shock index. So we focused our attention in the relationship between Muse and DPP3. Muse is a clinical risk score frequently used in the emergency department. It is based on hemodynamic parameters, and a value greater than 5 is associated with a high probability of intensive care unit admission and poor outcomes. And as you can see, in patients with Muse greater than 5, DPP3 was very high, with a significant difference. And this characteristic, this relationship is maintained in the patient with shock. So we analyzed the relationship between Muse and DPP3 to predict 24-hour mortality. We used a value of 39, which is too close to the nanogram, which is the upper normal range of DPP3 level in plasma of healthy individuals. And if we analyze that in the first 24 hours, DPP3 with a cutoff of 39 is strongly predictive of mortality. But if we combine Muse and DPP3, the predictive value for 24-hour mortality resulted to be increased. So, in conclusion, I want to repeat that it is a very preliminary study, very preliminary results in the emergency department, and it is important because we have done this study in the emergency department, and high level of DPP3 strongly correlate with mortality of 24 hours. Combining Muse and DPP3, the predictive value for 24-hour mortality resulted to be increased. These information are important because we have prochizumab, that is a monoclonal antibody for DPP3, that could represent a potential therapeutic option for these critically ill patients. But obviously, further large multicentric studies are required to confirm our very preliminary results. Thank you.
Thank you for that very interesting talk. Questions? Yes, at the back.
Thank you for your talk. I had just one question. Do you intend to measure other time points?
Sorry?
Do you intend to measure other time points?
Yeah.
I mean, longer than the 24 hours?
She's asking about monitoring the efficacy of any treatment. This is the question, right? Yeah. No, so far, you can answer.
Oh. We perform one single detection of plasma level of DPP3, only one, at the admission to the emergency department.
Yeah, but for the outcome of the patients,
yeah.
I mean, you look for just at discharge from the emergency or when the patients...
No, absolutely not. For admission to intensive care unit.
So you use a point on care. Are you measuring on plasma or on
plasma?
Whole blood? So the 20 minutes is the time the point of care measures,
yes.
Right? So it means you add 10 to 15 to 20 minutes for the preparation of the samples.
Yes.
So it's not, you don't have the result in 20 minutes, you have the result in...
Yeah, we have a result in 22 minutes.
Okay.
Yeah.
If I may comment, because by chance I know some details of this technique. I don't know how you've done it, but just to tell you that the system is capable of getting results within 20 minutes. So you can pipe it, whole blood on the device, and there is a microfluidic system in this disc. You know, the apparatus separates cells from plasma in the apparatus, and after 20 minutes you have the result. You can also pipette plasma directly on the
Yes.
system, but whole blood is possible as well.
I don't think we have time for other questions. Otherwise, we can just thank you, Giacomo, for your. Otherwise, French people will ask for DPP3 for 3 days, right? Stop, French people. Okay, let's move now on Angie Reed, again from Italy. She's talking about high-sense troponin I as a detector of pulmonary vessels involvement in pulmonary embolism. Please, Angie.
Okay. So, good evening. My name is Angie Riad, and I am an emergency physician from La Sapienza University of Rome. And I'm here to talk about the high-sensitive cardiac troponin I as detector of pulmonary vessels involvement in pulmonary embolism. Okay, this year we published an article on Medicina about the utility of combining high-sensitive cardiac troponin I and PESI score for risk management in patients with pulmonary embolism in the emergency setting. And we suggested to use troponin to properly stratify the patients even in the presence of a low PESI score or a negative radiologic imaging. Moreover, in the same time, we thought about a radiologic score that can help us to be able to predict cardiac involvement that can mirror the presence of myocardial injury and could be useful in the emergency department. So we hypothesized a CT score for pulmonary embolism that combined together the lung involvement and the vessels involvement. That does not require in-depth radiologic knowledge, and it's easy to use in the emergency department. If we look at these radiologic images, for example, it's easy to understand that here the lung involvement is bilateral and that involves the principal artery. So our result score is 2, and that reflects a very severe lung involvement. At this point, we have four different severity levels, from the mild lung involvement until the very severe lung involvement, and the severity of pulmonary embolism was inversely related to the score points. Then we tried to analyze the relationship between the CTPA score and high-sensitive troponin in a total of 355 patients. And our study was divided in two parts, a retrospective observational one and a prospective observational study. Both of them, all the patients were collected in two different centers in Rome, San Giovanni Addolorata Hospital and Sant'Andrea Hospital. And as you can see from our statistical result, the more severe is our TAC score, more is the relationship, more bigger is the relationship between the CTPA score and high-sensitive troponin I. But this relationship, this correlation become even more significant if we identified only two large groups of CTPA score, the low-moderate group with a CTPA score upper than 3, and the severe, very severe group with a CTPA score lower or equal than 3. I reminded you that the total of patients is 355 patients. As you can see, 65% of patients with a severe, very severe involvement had a significant relationship with the troponin I. And then, as we know, pulmonary embolism correlates with the right ventricular dysfunction. And according to the line guide, this dysfunction can be detected by an echocardiographic way, but even by measuring the dimension of the right ventricle itself through the CT scan. And this is what we did. So 75% of our patients with a CTPA score lower than 3, that I remember you, it's the severe involvement, had a larger right ventricle diameters, and even the ratio results increased. But the most important result, it's about mortality, because in our CTPA score lower than 3, so the severe patients, the value of mortality within 30 days, it's around 25% compared to the 8% in the low-moderate CTPA score. So, in conclusion, it seems that in patients with pulmonary embolism in the emergency department, the CT score we proposed could be easily calculated by the emergency physician and correlate with the presence of myocardial injury according to high-sensitive troponin I. There is a significant correlation between the severity of pulmonary embolism at the CT score and mortality and right ventricle dilatation, particularly if you consider as a cutoff a CT score lower than 3. Our aim in the future will be to try to correlate together the high-sensitive troponin, the right ventricular dimension, the CT score, and even the mortality in order to have a better risk stratification in these patients. But we already know that more multicentric, larger studies are required to confirm our preliminary data. Thank you.
Thank you, Angie. I think this is going to be a step forward for emergency physicians to do a decision by themselves. So you are not waiting anymore for radiology to make the conclusion, right? You can analyze the CT scan, you can have right ventricular function, you can have troponin, and this is going to be a massive impact on time decision making, and this is a final objective, that you are going to make your decision without waiting for other people telling you what to do. This, I think, is the main concept that I think we would like to have in the future. Now, the discussion is open. Sure.
There's a program, an AI program reading CTs for us. Are you intending to compare it?
We can try. Why not? Sure.
Good idea. Let's wait to cooperate on that.
Yeah.
So the performance for troponin is already that it has a 97% negative predictive value for death in P at 30 days. And for BNP, it's even better. It's actually 98% negative predictive value. So actually, do we need anything else other than troponin and or BNP anyway?
Don't know. No, I don't think so. But
you have an idea, Lorella, on that?
Oh, Frank.
So I did one of these studies, and we looked at saddle emboli, which don't show up with a BNP or a troponin. And we had like 50 of them, and 100% of them were dead in 3 months, usually because of their underlying cancer, which was the most common reason they had a saddle emboli.
Oh.
But they don't really get flow abnormalities until something breaks off and causes a trouble. So I don't know how you handle saddle emboli in your score.
No, I don't understand. Can you repeat again?
Yeah, saddle emboli, you know that big thing on the arch? It hasn't gone to the lung yet, but you can see it on the CTPA.
Yeah, we see. Yeah, we studied the CTPA. We did like a group with our radiologists in the first parts of our training to understand how we can calculate by ourselves this score. And probably our score is really easy because you have only to follow the contrast in the imaging. So it's really easy, and it's not so difficult like the radiologic score already existed. I don't know if you talk about Canadli score or Ganima score that can help you in the pulmonary embolism, but it's a little bit difficult for us to perform it.
I'm just saying that at some point you can't just look at the markers.
Just look?
The markers will not reflect severity in a patient with just a saddle embolus. You will have normal troponin, normal BNP, and the patient's going to be dead in a month.
Yeah,
Those
sure.
people got to get admitted and get anticoagulated, and they have their underlying disease dealt with.
Okay, but I think that our idea was that the troponin reflected the myocardial injury. So if you have an elevation of troponin, probably it's more possible that you will die.
No, I mean, Frank, you're right. This is, what is the guidelines issue? They recommend troponin. They don't recommend high-sensitive troponin. They have to go forward because, as Angie said, high-sensitive troponin is detecting the ongoing myocyte cell death. I fully agree with you that if patients coming with a large right ventricle and the massive involvement is already there, right? The mortality, even if you have a cancer. But I think we opened a new door. In the first paper we published, the paper that she showed last year, PASI score was not reflecting the severity. and the isentroponin was doing better.
Yeah, because we have like a 20% of people with a very low PASI score with a high level of troponin. So this is the reason why we try to project this kind of CTPA and can even detect this kind of patients.
Great, thank you very much. Okay, and next up we have Ana Garcia, who's from Spain. So for a slightly different change in topic, she's going to talk about frailty and detecting frailty in the ED with a full ER registry. Thank you.
Okay, thank you. Dear colleagues, it's my pleasure to take part in this meeting and to present data from the FOLER registry. Falls are a really important geriatric syndrome and a real challenge for clinicians. Falls are very common. 1 out of 3 adults 65 years or older living in our community fall each year. About 30% require medical attention, and 5% require hospitalization to treat severe major injuries. But also falls are a risk factor for recurrent falls, loss of independence, nursing home admission, and death. The only good news is that falls can be prevented, and the emergency department offers the opportunity to identify patients who are at higher risk of suffering these adverse events. So the FOLER registry is a multicentric registry that was born a few years ago with the idea to improve our knowledge regarding fallers and fall-related visits to our emergency department. This is an observational prospective study, including consecutive patients, 65 years or older, treated for a fall in 5 Spanish emergency departments. Enrollment of patients was conducted during 52 randomly selected days between a period of 1 year, between 2014 to 2015, and variables were recorded prospectively while the patient was in the emergency department or during hospitalization. The FOLER registry has provided us with interesting data, and several studies have already been published, but today I would like to focus on this study. It was a study that we performed to investigate the immediate outcomes of the fall, and we found that almost 50% of patients who have suffered a fall experienced or manifested having fear of falling again. Fear of falling is not usually assessed in the emergency departments, but it has negative connotations because it can trigger a negative vicious circle, leading to reduction in physical activity. This leads to sarcopenia, more muscle weakness, instability, and recurrent falls. And all these elements are common in frail patients, and some of them are also definitory of the frailty syndrome. In addition, in longitudinal studies, the fear of falling was associated with a decline in functional and cognition and disability. And we have less information regarding the association of fear of falling with mortality because very few studies have been conducted, and the studies that have been published to date show contradictory results. So the objective of our study was to investigate if there was association between the presence of fear of falling and mortality after long-term follow-up. So this is a secondary longitudinal analysis of the FOLER cohort, included community-dwelling patients discharged directly from the emergency department. Fear of falling was assessed by using a single question with 2 possible answers, yes or no. The outcome was all-cause mortality at present, and it was recorded by review of electronic medical charts. Independent variables included demographics. The comorbidity burden was assessed by using the Charlson Index, functional status by using Bartel Index. We also recorded for geriatric syndromes and fall-related variables. So after excluding patients who live in nursing homes and patients who were admitted at index episode, and also we excluded 60 patients in which we lack data regarding fear of falling, the present study included a total of 1,080 patients with a median age of 79 years. Almost 70% of these patients were female, and 43.8% died during the follow-up period. First, we look for differences between both groups, patients who were dead at the end of follow-up and patients who remain alive. And as you can see, patients who were dead were more likely to be older than 80 years, to be male, to have a higher comorbidity burden, to have a higher prevalence of any degree of functional dependency, and to have a higher prevalence of geriatric syndromes. And when we look for fall-related variables, patients who were dead at the end of the follow-up were more likely to have a domestic fall, to fall at nighttime, and to be unable to stand up after the fall. On the contrary, these patients were less likely to identify an extrinsic factor as the cause of the fall, and were less likely to suffer a fracture. Regarding fear of falling, it was more prevalent in patients who will die during the follow-up period. The relationship between fear of falling and the outcome, all-cause death, was also assessed by using survival analysis. And as you can see in the survival curves, the probability of mortality was higher in patients who expressed to have fear of falling again at the index fall. And the hazard ratio for mortality was 1.342, and it was statistically significant. But after adjustment for covariate, fear of falling lost the significance. So to conclude, fear of falling was common in community dwelling patients discharged from the emergency department after a fall-related visit, but it was not an independent risk factor for mortality. The study has limitations. Fear of falling was evaluated by a single question, and we have other methods to assess the fear of falling. It was evaluated only once, and this is a dynamic, it can be a dynamic process and change over time, and we don't have data on fear-related activity restriction. So to conclude, fear of falling should be considered a marker of mortality risk rather than a causal risk factor for death. However, given that it has been associated with other negative outcomes, it may be useful to identify fear of falling in order to design preventive strategies in these patients. And thank you very much for your attention.
Thank you. Any questions? Christian.
Very important work, thank you. How would you design an intervention to address this? So you have identified a single very important question, so what will you do with that information?
Yeah, it's a very interesting question, but we don't have, I think I don't have an answer, because the role of emergency physicians, clinicians, in preventing falls is uncertain. We can identify these patients, but then we need to have clear pathways to follow up these patients. I don't think that we could manage these patients in the emergency setting. We need to identify them, but then to have the opportunity to send the patient to the primary care physician or to a Volksklinikum to intervene. So, these high-risk patients need a multidisciplinary holistic approach, and they need the intervention of several professionals. So it's difficult to manage from the emergency room.
Any other questions? I have a very quick question. Emergency departments are frequently not very nice places. They're busy, they're overcrowded, and they can be terrifying in themselves. Did you get any sense at all whether this changed by day of the week or time when the question was asked? Because actually the conditions in the ED may in fact actually affect the answer that the patient gives.
I'm not sure if I understood you correctly. Sorry.
So the whole entire point is that EDs are not very nice. And
Yeah,
if you
yeah,
come
yeah.
into the ED on a day when it's busy and horrible, you might be more likely to answer
Yeah,
that
yeah.
you're afraid because the environment makes you afraid.
Yeah,
Did you
yeah,
get any sense of that?
This is a big limitation of a limitation of this approach because fear of falling was as only once a very close time in the emergency setting. And were patients who were directly discharged, so they were asked very close to the fall index, to the index fall, and this is a limitation. We don't know if this feeling changed over time.
Thank you very much, Anna. Let's move to the last presentation of this session, phenotyping acute heart failure in the emergency department, point-of-care ultrasound and novel biomarkers from Effie Polizoglopoulou from Greece.
Long name.
I hope that I was able to pronounce correctly.
Long name, I'm very Greek. Thank you for the invitation. I'm emergency physician too, and I'm the chair of the ultrasound section of the European Society of Emergency Medicine. So the first part of my lecture is my expertise. No conflicts. As we know, it's very important to identify, to understand the different acute heart failure phenotypes, but not only to understand, but to identify them upon presentation in the emergency department. And this is already noticed in both of the previous guidelines of the European Society of Cardiology and the current ones. And also, it's highlighted that we can use both ultrasound and biomarkers in order to identify these phenotypes during the initial diagnostic workup in the emergency department of all these patients with acute heart failure. Let's start with point-of-care ultrasound. This is a very valuable tool in order to identify the different phenotypes. And now it's widely used in all emergency departments and not only in the emergency department. So what we can do with different imaging modalities, we can combine our results and our findings in order to have a non-invasive assessment of cardiac structure and function. Also, we get information about systemic hemodynamics, and we can assess elevated venous pressure and check for extravascular fluid in the lungs. Regarding lung congestion, we know already we have so many studies on this topic, and what we know is that in the acute heart failure setting, it has an extremely high diagnostic value. It has a great sensitivity and specificity, and also it's a rule-in tool and rule-out for other conditions which mimic acute heart failure. Also, it has a prognostic value at discharge, because we can identify residual congestion and accordingly tailor our decongestive treatment at home. And also during hospitalization, we can monitor our treatment, optimize our decongestive treatment according to our lung ultrasound findings. But it's not only lung ultrasound. This is one part of what we can do with ultrasound. And we can combine the internal jugular vein findings, the B lines, as we said, the lung congestion, and to assess the renal venous flow. All together, with all of these, we can put them all together and improve our decision-making and tailor our treatment, decongestive treatment. And here we can see, in a recent review of the European Society of Cardiology, how how good are these tools, these sonographic modalities? Lung ultrasound has a great diagnostic value. As I said, it correlates very well with natriuretic peptides and with invasive cardiac hemodynamics. For the other modalities, we don't have many studies, so we don't have good results so far, but definitely they have a good prognostic value. Of course, we have to keep in mind their limitations. Now, to move in combination as an additional tool, we have biomarkers which are involved in different pathophysiological pathways in acute heart failure. So there are so many, and every day we have more and more. Some of them are well studied, some of the others are under investigation. Where we can use it, use them in the setting of acute heart failure as diagnostic tools, as prognostic tools to assess congestion, and of course, as we said before, in shock for DP3. Regarding natriuretic peptides, we discussed already so many times. We have many studies for many years. Our knowledge is well established, so according to the guidelines, they are a recommendation for the American guidelines, recommendation 1A as a tool for decision-making upon presentation in the ED. In the latest European guidelines, it's a recommendation 1B as a rule-out tool. And let's see some other biomarkers. Due to the time limitations, we will discuss a few of them. As we know, in acute heart failure, we have systematic inflammation. The team of Christian Mueller studied interleukin-6, one of these biomarkers, and what they did, they divided the different acute heart failure phenotypes, and they found that in a large population, something like 2,000 patients, they found that concentrations of interleukin-6 were highest in patients with cardiogenic shock compared to those with hypertensive acute heart failure. And and importantly, this biomarker is a strong predictor of 1-year mortality. So we have one study focused on different phenotypes. Most of the studies are in general about acute heart failure. They don't focus on different phenotypes. This is one of them. Another one, recent one, compared patients with de novo acute heart failure and patients with decompensated acute heart failure. And what they have shown that there are differences in key biomarkers, not the inflammatory biomarkers, but biomarkers for perfusion, speaking about lactate, and especially it was statistically different, as significant at discharge, and congestion biomarkers like natriuretic peptides, and they found that even though they had a small population of 250 patients, they found that there are differences between those two phenotypes. A few years ago, we had this publication coming from the GREAT network about proencephalin and its correlation with renal dysfunction. We know already that PENK levels reflect cardiorenal status in acute heart failure, and what they have shown that in patients who experience worsening renal function during hospitalization, the levels at discharge during hospitalizations were worse compared to those on admission. And this was the difference between those who didn't have renal worsening during hospitalization. Also, it's a great prognostic marker for in-hospital mortality and mortality during follow-up. And in the same line, Professor Parisi's team started a study which is in progress. Here are the preliminary data. We measured the PENC upon presentation in the ED by using a point-of-care system with whole blood. So the result came out in 15 to 20 minutes after presentation in the ED in acute heart failure patients. And in order to check what's the role of this biomarker in the worsening renal function. And what we have shown that they are positively correlated with creatinine, low creatinine, lactate, pro-BNP, and troponin, but most importantly, it's associated with increased worsening renal function and is the strongest predictor of mortality. We measured it after 48 hours during hospitalization, and so far, we have seen that we can use it as a predictor of worsening renal function. And what we can do, we can adjust, we can adapt our treatment, the congestive treatment, according to these findings. So upon presentation in the ED, we have an additional tool in order to decide how much we will treat the patient, how aggressive we will be or not. In summary, we can talk for hours for biomarkers. This is a very nice summary of the existing biomarkers coming from the European Society of Cardiology. We already talked about natriuretic peptides. CA125 is an old biomarker. We know it from many diseases and from cancer. It represents the pulmonary systemic distribution, and it's a marker of congestion. It's widely available, but still we need large-scale studies in order to put it in our everyday practice. About bioadrenomedulin, again, we can identify congestion and the residual congestion. It's a systematic, it represents systematic distribution. It's not widely available. Soluble ST2, again, it represents pulmonary systemic distribution, and it's useful for risk stratification. CD146, it's again represents venous congestion and is a marker for this. Again, it's not widely available. And hemoconcentration, we know it many years. It's easily, we can assess easily and interpret these results. And again, we can, with this, maybe it's helpful to interpret kidney function during the congestion. So, in summary, we have tools in order to improve our decision-making, in order to tailor our the congestive treatment for those patients, and to improve our phenotyping, we can say. So together with natriuretic peptides, we can use some circulating biomarkers in order to identify which is the predominant phenotype of congestion. Some of them are useful for monitoring and guiding the congestive therapies, but we need further studies in order to determine which of these can which of those we can put in a multi-parametric approach, probably a score, multi-parametric score, in order to assess congestion. Thank you.
Thank you. Thank you so much, Effie. It's really interesting talk, coupling point-of-care ultrasound with biomarkers. If I can start just to ask you, if you have just money for 3 biomarkers and just point-of-care ultrasound, in order to have therapeutical implication, which you would like to choose? You know, you have shown a lot of biomarkers, but which are the most that are giving you therapeutical implication?
In the emergency department?
Of course.
A part of ultrasound.
Yeah, ultrasound is there.
Okay. Definitely natriuretic peptides.
Okay.
We can use them, and now probably they are more cheap than before. These point-of-care systems, I think, are very useful because you can have the results in a few minutes. So probably promising, I can say promising, not something established. PENG will be
Proencephalin, you mean?
Yes, yes.
And
bioadrenomedulin, probably.
Yeah, that's
I'm
also
not
because
sure, to be honest.
Rinal showed that enibacimab should be a therapeutic option. Thank you. Yes, Martin.
Yeah, thank you for this nice overview, and I would like to support the idea that ultrasound is immediately available within seconds. And I mean biomarkers, so if I measure PANC, I need maybe 1 day or so, and the beauty and the challenge of acute heart failure is that it's acute. So what is your perspective on modern biomarkers which may be promising but not available in the situation where you see your patient?
Which? Can you repeat, please?
Yeah, so the question is, I mean, this new modern biomarkers, if they are not acutely available, you cannot measure them acutely at nighttime, on Sundays. So how can we prospectively incorporate that into our diagnostic algorithms? Because the acute heart failure is, let's say, the first 12 hours.
Martini, she was showing point of care.
Yeah.
She was showing that these biomarkers are available point of care.
Exactly.
Yeah, but
point of care.
Okay, okay, question other way around. I mean, so even at Charité, it's a big hospital here close in Berlin. I'm not available to have a point of care staff which, let's say, runs point of care assays according to the rules and legal rules we have. So you would need a kind of a satellite lab or something like that? Or do you think that these markers will be available on fully automated, no maintenance, centrally integrated systems, and which systems are that?
I think in order to answer and give precise answer, we need more studies about cost effectiveness. I'm not ready to say what are we gonna do in this case. Definitely, I will support ultrasound.
Okay, there's still room for discussion in the future. So thank you very much again, and now we leave the podium for the next session.
Okay, we have to change fast here. High pace in this room. Yeah, on behalf of my co-chair, I welcome you to the next session. It's a senior scientist lectures and a master lecture, so this is now the cream on the cake. And the first speaker is Anna Isayeva, and she will talk about the complement lectin pathway in the diagnosis of coronary artery disease. Please.
Dear colleagues, dear chairmen, I would like to present the finding of our research, which focused on very specific part of the immune system, known as the complement system, precisely on its role, on its diagnostic and prognostic role in patients with coronary artery disease. Coronary artery disease known to be silent for decades. However, in symptomatic patients, coronary artery disease can significantly decrease quality of life and limited everyday activity. At present time, we use very sophisticated visualization methods to diagnose functionally relevant coronary artery disease, and these methods associated with radiation and contrast risk, as well as they are not very available and expensive. And from clinical point of view, it can be used inappropriately in patients with very low pretest probability of coronary heart disease. In this situation, a good alternative to visualization technique can be using of biomarker. They are quite simple to be used. They are widely available, inexpensive, and not related to adverse effect. The complement system, the complement immune system is known to be related to atherosclerosis, and today I would like to draw your attention to the lectin pathway of the complement system. 2 words about the biology of lectin pathway. It's not adaptive immune system. It doesn't change during individual's lifetimes. It cannot be influenced by antibodies and CRP. And lectin pathway is a cascade protein system. The main function of the complement system is to recognize damaged cells and to initiate protein cascade, and on final stage, they create a membrane attack complex that is able to diminish damaged cells or change cells. Let me say 2 words about main players. Ficolin, Ficolin and IMBL are both pattern recognition molecules. Their function is to find damaged cells and to initiate the complement cascade. And MAP19 is a regulator molecule that can influence the intensivity of and can control function of H-ficolin and MBL. We performed a single-center prospective cohort study, and all patients underwent rest and stress test, a single isotope emission tomography, and also we used data of coronarography, of angiocoronarography, and fraction flow reserve to detect coronary artery disease. We performed 1, 2, and 5, 5 and 8 years follow-up. And in this study, we focused on the 5 years follow-up. Initially, we had 1,618 consecutive patients with suspected coronary artery disease. After excluding patients with low eGFR and those without available follow-up data, finally we had in analysis 1,571 patients. We measured our molecules before the stress test, immediately after, and 2 hours after the stress test. Let me proceed to results. H-ficolin. It demonstrates significant increase immediately after the stress test, following decrease to baseline level after 2 hours. However, we did not confirm any diagnosticability for this molecule. MBL, as well as H-ficolin, also increased immediately after the stress test with following decrease, and also no diagnosticability was confirmed to MBL. MAP19, as well as 2 previous players, decreased after the stress test significantly, then decreased in 2 hours, and also did not confirm its ability to distinguish patients with and without functionally relevant coronary artery disease. Going to prognostic value, I would like to say that we tested different cutoff because it was the first study in field of complement in stable patients with coronary artery disease. But in case of H-ficolin, we found out that only patients with very high concentration of H-ficolin had high rate of myocardial infarction. However, in Cox modeling, H-ficolin did not confirm its prognosticability. MBL also demonstrates in Kaplan-Meier analysis the ability to predict myocardial infarction, but after adjustment to other factors, it completely lost its diagnosticability. And MAP19, among studied molecules, it has the most potential and is able to predict myocardial infarction risk even after adjustment to other factors. However, its predictive value was not very prominent. So our study has limitation. It was single-center study, and it might not reflect the diverse patient population. We did not evaluate the relationship between our markers, the complement system markers, and other inflammatory markers such as interleukin, tumor necrosis factors, and CRP. And we did not account for the impact of statins, ACE inhibitors, aspirin, drugs that potentially can change outcomes in patients with coronary artery disease. In summary, I would like to say that none of study molecules confirmed the ability to distinguish patients with functionally relevant coronary artery disease and without it. However, MAP19 shows potential as prognostic marker for myocardial infarction. Thank you for your attention. I would be happy to answer your questions.
Yeah, thank you very much. I appreciate very much that you show a negative study. So mostly we only see the big difference, but this is very important also to show negative studies. In your introduction, you said that there's maybe a challenge to overuse CT angiography, but what do you think about overusing biomarkers? Is that not also a challenge? So it's so easy to measure, just one blood draw, sent to the lab.
From the point of view of costs and radiation, biomarkers is not so difficult to use in clinical practice. And of course, it's like a good idea to find biomarkers that can show functional changes in heart, but I think that we have different cohort of patients and may study visualization technique and biomarkers in patients depends on the risk of probability of coronary artery disease.
Mm-hmm. Any questions?
I think then we go to the next speaker. Thank you so much. So the next topic is biomarkers again, natriuretic peptides by Nicolas Vodova.
Thank you. So you all know natriuretic peptides are as gold standard biomarker in heart failure. And biologically, those natriuretic peptides also have many beneficial effects to mitigate the effect of heart failure. And from a metabolic standpoint, they are all synthesized as a pre-pro-NP. The signal peptide is removed, and this signal peptide is important because its metabolism is completely independent from the rest of the peptide and can be used as a surrogate of production. The resulting pro-NP can be heavily glycosylated and will be cleaved into the N-terminal fragment and the major peptide. The major peptide will produce cGMP via its receptor NPRA and can be also eliminated by protease such as neprilysin. And because of the beneficial effect and because neprilysin is known for a long time, one way to potentiate the effect of natriuretic peptides in heart failure is to inhibit neprilysin, and this is the case with sacubitril/valsartan, also known as Entresto, who showed improvement in heart failure with reduced ejection fraction. But Entresto came with a poisonous chalice, which is that BNP increased after initiation of the treatment while anti-proBNP decreased. And we found the exact same thing, is that BNP remained stable while anti-proBNP decreased, which was quite unconventional. And based on this result and the various hypotheses that were drawn to explain those differences, we decided to take a deeper dive into the metabolism of natriuretic peptides and also as biomarkers. So most of what I'm going to show you relies on 73 patients with FRF who were switched to Entresto, and we have 3 time points before and a month and 3 months after initiation of the treatment, healthy volunteers. We measure BNP with Abbott, anti-proBNP with Roche, and MR-proNP with a Cryptor assay, and we also use various flavors of mass spectrometry. So first of all, from a physiological, pathophysiological standpoint, FREF is a major ANP defective state. And to cut a very long story short, what we found that in FREF, pro-ANP production is limited, chorin activity is decreased, which overall leads to a lower than expected production of ANP. And Entresto completely reverse and enhance this via three mechanisms. First of all, pro-ANP production increases, pro-ANP cleavage increases as well, and ANP half-life is increased because it's no longer degraded, leading to a 4 to 5-fold increase in ANP. When it comes to BNP, the situation is slightly different because here you have pro-BNP, you have the signal peptide, you have the anti-pro-BNP, the molecule, and furin activity. And what you can see is that everything is higher in the heart failure as expected. And when you put sacubitril valsartan, we just observe a slight increase in furin activity and a bit in anti-pro-BNP production. When it comes to BNP itself, normally in many species, neprilysin should have cleaved here, but in human it cleaves here to produce BNP 532. Once again, kind of as expected at baseline, BNP 132 and 532 are higher in FREF compared to control. But when you block neprilysin, you obviously lose 532, which results in increased level of 132. And this is important because BNP 132 is a very good activator of the receptor, while BNP 532 isn't. So overall, FREF is probably not a BNP defective state, although Entresto improved BNP cleavage and BNP activity. So now we know that. How does it translate into biomarkers? And a major problem with natriuretic peptides is glycosylation, because glycosylation can mask epitopes, and therefore you don't measure exactly what you think you do. If we look at MR-ProANP, so these are the three molecules that can be detected by the assay. You have the two epitopes here, and one of the epitopes can be glycosylated. And when we measure MR-ProANP in this cohort, you can see that it decreases after the initiation of the treatment. But if we measure the signal as it should be, if there was no glycosylation, you see that the biomarker should have increased. The reason it decreased is because glycosylation increased as well. So you have increase in the signal, you have an increase in the interference to the signal, which is greater, and therefore you have a decrease in the result. And also, we looked at MR-ProANP versus the signal peptide pro-ANP and ANP, and there is absolutely no correlation whatsoever. Anti-pro-BNP is exactly the same story, because you have here the two molecules that are recognized by the antibodies, and the epitopes in orange. One is glycosylated, and we have the exact same story. Anti-pro-BNP, as I showed, decreased, while the signal should have increased, and the reason for that is that in both instances, the glycosylation increases and therefore masks part of the signal. BNPSA is different because, as you can see, there's no site of glycosylation, so BNPSA are insensitive to glycosylation and mostly detect pro-BNP, full-length pro-BNP. So now what we looked was, how does that compare when it comes to the production itself? So we looked at BNP assay versus pro-BNP signal peptide as a kind of surrogate independent measurement of production. And as kind of expected, it correlates very well. But to have very, very big surprise, and to the cat's surprise, anti-pro-BNP performed better, overall, and also across the clinical landscape. Here you have control, you have FREF plus or minus Entresto, you have acute heart failure, and you have acute dyspnea of non-cardiac origin. So both are very good surrogates, but anti-pro-BNP seems to be more consistent. And of note, because there were debates, in FREF, BNP and anti-pro-BNP are equivalent. As a kind of conclusion, I would like to give you two messages. The first one is the metabolism of ANP and BNP is way more complicated than we initially thought. And acute heart failure, and that's data I presented at a great meeting 10 years ago, is possibly the most optimal BNP state, and we don't know for ANP, while FREF is clearly ANP defective state with BNP unclear. And Entresto reverse this defectiveness and also enhance the system. So now we know that our natriuretic peptide is still good biomarkers? And the answer is obviously yes, because they were defined as measurement able to discriminate between different populations, irrespectively of metabolism and biology. And also, if you interpret your BNP and NT-proBNP result as a surrogate of pro-BNP production, it's still true. However, what you can't do is to draw any biological interpretation from MR-proNP, because in the end, we don't know what it is a surrogate of. And also, if you want to interpret your data in terms of how much natriuretic peptide is active, I mean, our data suggests that you can't do that as well. And as it said, and if you do, the cat will be judging you. Thank you.
Thank you so much for your presentation. Is there a question from the audience? I actually have a question. You were talking about you call it the theoretical concentration, so what glycosylation is not a problem with your anti-proBNP assessment. I saw like an abbreviation, or how are you sure what the exact anti-proBNP concentration should be when the glycosylation is not interfering? Can you explain to me?
So what we measure using mass spectrometry, so we measure anti-proBNP. So it's capillary electrophoresis coupled mass spectrometry, so we know the length is correct, and then we can measure. So we measure anti-proBNP based on a fragment that is not glycosylated, and then we measure glycosylation by LCMS. So we have the amount that is glycosylated, the amount that is not glycosylated, and that's how we...
Okay, that was not, that's clear now, and I can see someone of Roche is still in the room, so your suggestion is to adapt antibodies in the current assay, or what is your message to Roche?
I mean, I have no message really, but no, the thing that is absolutely incredible with the anti-proBNP assay, and that was really surprised us, is so you have a measurement that does not reflect really what's going on, because anti-proBNP, for instance, decreased, while in reality it should have increased. But the thing is, at the time the assay was developed, glycosylation was not known, and nobody tested the single peptide. And despite that, and by kind of pure serendipity, you have a biomarker that performed better as a surrogate of something that it shouldn't have measured than BNP. So I think that given the current state, I mean, things shouldn't be changed. So yeah.
You said that you have a very elaborate study based on 73 patients, so you deep characterize this group. Do you think that this group is overall representative for the, let's say, scope of heart failure, or do you think there could be other constellations, other patients with different patterns?
So, I mean, compare, for instance, to Paradigm, the patients were slightly worse. They were more NYHA3, for instance. But when you compare it to other studies, for instance, Jim Januzzi sampled different BNP-SA, and discussing with them, basically we have the same kind of trends overall. And also, I mean, these are just a part, the tip of the iceberg, because we have measured more than 100 different parameters, and all the time everybody is kind of, the variation are quite consistent across the cohort. So we think that even though it might not reflect every single cohort, it's still reflective of the metabolism that will occur in any patients.
Okay, any further questions? No? Okay, thank you very much. So the next lecture is by Navin Sutaha from the Netherlands, and at Charité there's one famous researcher called Stefan Anker, and he almost always said the fatter the better, and he talked about the obesity paradox. But now we learn about obesity-related heart failure with insights from proteomics, and I'm keen to see the lecture. The stage is yours.
Never mind. All right. How do I go back?
Go back.
Yeah.
This one.
All right. Well, Good evening. It's great to see that some of you actually survived. My name is Naveen Sutahar. I am from the Department of Cardiology, Erasmus Medical Center, Rotterdam, the Netherlands. I have no conflict of interest for this speech. I don't know if it's a good thing or a bad thing, but I just move on. So I was reading this interesting article in Nature Reviews Endocrinology 2 weeks ago. It talks about obesity and how it has become rampant. So let's focus on the right end, right corner. That's the total world. When we have more time or when you're bored, you can take a look at all these subcategories. It's very interesting. But I was a little concerned when I took a look at the right-hand side of men and women. During the last 20 years or so, or maybe 30, maybe 35, we have a 3x increase in obesity. And now we have to put that in perspective with the 2x increase in population and look at the massive burden of obesity that we are having today. And the thing is, well, terrible news, it's going to continue. There are some countries fighting to be number one. So it's something that's largely ignored, but it's going to be the next biggest problem, let's say in the 20 to 30 years. It's a huge burden on healthcare, and it's a risk factor for so many diseases, including heart failure. So today I'm going to speak about obesity and heart failure, obesity-related heart failure. My topic is a little more chilled. It's no acute setting, no emergency setting, no acute heart failure. It's a couple of general population studies and one stable heart failure patients. So it's not about diagnosis, it's about biology, and it's about prediction. Well, we probably know all of this. There are many mechanisms that we know of heart failure and obesity. Reduce physical exercise, psychological factors, very important. People ignore it. It's that probably causes obesity in many and also continues to other problems, obesity-related conditions like type 2 diabetes, hypertension, pulmonary mechanisms, cardiovascular disease like MI, AF. All are obesity-related conditions that can lead to heart failure. Well, what we focus a little bit more when we go further is cardiac hemodynamic structure function, cardiac lipotoxicity. There's even a theory that, individuals with extreme obesity, their heart kind of changes from muscle to fat. And then obesity-related myocardial damage, inflammation, oxidative stress. Now, speaking about the last 2 points, how do we get that information from obesity-related myocardial damage, inflammation, oxidative stress? From biomarkers. For instance, troponin can give an example of how much myocardial damage is there in individuals with obesity, inflammation, CRP, and so on. That's when biomarkers come into play, and that's what I'm going to talk about. So focusing on protein biomarkers related to obesity and heart failure. I mentioned this before. So let's start with a general population study. This is the PREVENT study. It is something like the Framingham Heart Study from the northern part of Netherlands, from Groningen. It's general population, 8,200 individuals. We published this, I think, a couple of years ago. So it's 8,200 individuals, relatively young people, 49 years, 50% women, 41% overweight in a country like Netherlands, and 16% obese. And we had a follow-up of 11 years and 357 heart failure events. Well, how does obesity impact levels of heart failure biomarkers? These are 13 classic biomarkers measured by ELISA techniques. So to give perspective, I'm adding this slide. So we measured all these 13 biomarkers that everybody talks about, NPs, cardiac troponins, endothelin-1, PI-1, CRP, etc. for inflammation, galectin-3 for fibrosis, adrenomedullin, everybody knows that. So we said, how do they relate to obesity in PREVENT studies? So that's the answer. Except for natriuretic peptides, which are lower in individuals with obesity, almost everything else is positive. So increased troponin T, indicating myocardial damage, and all the other biomarkers reflecting inflammation and fibrosis. So that's a very good hinge point for us to have our discussion today. Well, we know that. Well, to add another example, there was a previous study called Obesity, Subclinical Myocardial Injury and Incident Heart Failure, again with troponin T. So maybe there is some obesity-related myocardial injury after all. Well, now Framingham Heart Study. So these are relative measures. These are not ELISA measures. Oh, well, sorry. So this is one point I thought I should mention to you today. So now people have this great theory. If NT-proBNP is low in individuals with obesity, its predictive value is lower in individuals with obesity. No, absolutely not. It has nothing to do with the predictive value. Just like we make a hypothesis saying NT-proBNP levels are higher in women, it has a higher predictive value in women. No, we just kind of destroyed that theory in this study, but that's for future. We can discuss it over later in the evening. It's even there in guidelines, unfortunately. But coming back to our topic today, this is the Framingham Heart Study. And here they measured all these cardiovascular biomarkers, but not in absolute terms, but in relative terms, something like an O-link panel. Again, you see 71 biomarkers measured, approximately same 50% women, 49 years, but 26% with obesity, much more than in the Netherlands, 10% higher in the United States population. 41 were related with obesity. Here's a huge list. You can read it later when you have time, but for us to just focus on. Of the biomarkers positively related to obesity, leptin, CRP, PI1, and adrenomedulin were the most important. Likewise, amongst the negatively associated, NT-proBNP and the IGF-BP family, more or less in line with our PREVENT study. So this assay actually works in that population. Now, this is the focus for today, obesity-related proteins in heart failure patients. So this is stable HFrEF patients, 373. Multiple, 4,000, greater than 4,000 proteins were measured using the SOMA logic, and multiple measures were made. So we're talking about more than 3 measurements. And mean age of 63 years, 25% women, of course, HFrEF, much more male predominant, 25% obese, followed up for 2.1 years. Now, what do we see here? These are associations. There were approximately of these 4,250 proteins associated positively or negatively with obesity. We cannot go through all of them, but again, hinge point. CRP positively related, NT-proBNP negative, troponin neutral, fatty acid binding protein, which is something of heart, so that's something related to troponin, so that's positively related. So there were multiple proteins positively or negatively related, and it works. So among these proteins that were positively or negatively related with obesity, we saw which one was associated with outcomes, adverse clinical outcomes in heart failure patients, kind of taking the gold out from some electronic items, so we're kind of reducing it. So we have, again, approximately, I would say, 30 proteins which were associated with outcome. Amongst these, some important proteins, which I don't want to go through now. But what we did additionally, okay, well, maybe we can just go through very briefly. So another point I would like to make here. So there is no logic here. We cannot make an assumption that a protein is negatively related to obesity means it's a good protein, and a protein that's positively associated with obesity is a bad protein. Nothing like that. Maybe what I would dare to say is if a protein is positively associated with obesity and also positively associated with outcome, maybe it is a bad protein. But we can't say anything regarding the others. For instance, NT-proBNP. It's negatively related to protein, but it's positively related to outcome. And it's a good guy, BNP. So no logic there. But just to put perspective, I would focus on the positive associations. So that would be insulin growth factor binding protein cleavage molecule, that's HTRA1, fatty acid binding protein, and a DNA repair protein that is associated with senescence and PI1. So these are the proteins that I would focus on. Now, what we did additionally is we not only used all the time points, it's joint models, it's a pretty complex modeling. What we did is we did not just take into consideration the temporal evolution of all these 4,000 biomarkers, but we also adjusted for multiple factors, including NT-proBNP, temporally. So we adjusted for the complete evolution of NT-proBNP. So these are very harsh adjustments. So what results come out probably is quite useful. So what we see again here is, can we go back one slide, please? Yeah, so again, what we see is, except for the fatty acid binding protein, the cardiac one, all the other 4 proteins were actually significantly associated with outcome. Now, why? Because they were not that related to NT-proBNP. That's why they survived. So they are indicative of other pathophysiologic pathways that are not captured by NT-proBNP. So conclusions, well, we can use all these sophisticated protein studies to see the pathophysiology of obesity-related heart failure. That is a possibility. We can use some of these proteins for prediction. And some of these proteins also have some predictive value above and beyond the temporal evolution of NT-proBNP. And these are, for instance, serine protease, HTRA1, DNA repair protein, and PI1. Other proteins of interest are fatty acid binding protein 4 and the IGF-BP family. Thank you very much for listening.
Yeah, thank you very much. For me, it was a rather complex talk. Yeah, please.
I have to apologize. I'm a hepatologist, so I'm going to ask you a hepatology question. Is there any correlation between NASH and heart failure in the obese patients? Because the mode of exodus of patients with NASH, with non-alcoholic fatty liver disease, is not their liver, it's actually congestive heart failure.
Well, that's a great question. Me personally, I've never looked into it. And I'm not sure if any of these biomarkers also reflect NASH, but we do have the NASH endpoint in the PREVENT study and the Rotterdam study. Maybe it's worthy to look into it. Yeah.
Great. Thank you.
Yeah, thank you.
I also have a question, if nobody in the audience. So I'm from the lab, so I was a bit triggered by your comment that you were talking about bad and good markers or proteins. So I was wondering if you don't like the confounding part with biomarkers, then I think we can close our lab because most of the biomarkers do have impact, for example, obesity, but you have more other confounding factors too. So I was wondering if you thought about a solution of this, and or should we wait for AI that maybe we not use the biomarker as a biomarker anymore, but more go to a complex prediction model? So
No, we must use biomarkers. We must apply our thinking and our intelligence. But what I wanted to say is not a very simplistic point of view. So for instance, if a biomarker is reduced in obesity, it does not automatically make it into a good biomarker or a bad biomarker. We have to use that information, use our intelligence, and kind of maybe discuss it and see if it actually makes logical sense along with a biological experiment before we rapidly conclude anything. So that was kind of my message. All right. Thank you.
Thank you so much for the opportunity. Very great presentations and the issues. I would like to ask whether in this study you differentiate the subtypes of heart failure. Is it like what you said, it's stable heart failure patient? Do you have any data or differentiation between those with preserved or reduced indifference of the proteins that been presented in this subtypes of heart failure group? Do you have any comment on that or maybe data?
I do have, yes, absolutely. So these are HFrEF patients, and we measured 4,000 proteins in multiple time points. That's very expensive, actually. So we do have data of HFpEF patients and so on. But what I also look for is maybe some other people also measured using the SOMA logic. So it's good to put all these data together, maybe in a different heart failure setting. So what I showed was HFrEF, and that's why it was also predominantly men. But we do have for HFpEF as well. Yeah.
Thank you so much.
Thank you.
It's time for the next presentation. Very welcome to John Parisis. And he will talk about cardiogenic shock.
Okay, I would like to thank Christian, Alex, et al. For this invitation. I will speak about the concept of team shock and the activation of team shock in the emergency department. Sorry, this is the first one, huh?
No, the second.
Second, sorry. Okay, my disclosures. I will present some data from our early experience at the ASSIST registry of Attikon University Hospital. I will speak about what is a cardiogenic shock team, the function and aims, and who are the patients managed by a cardiogenic shock team. You can see that the mortality in cardiogenic shock is still high. This is the CardioShock trial, the results of CardioShock trial. In hospital mortality, 37% in these patients. And the mortality is higher in patients with acute MI versus heart failure-related cardiogenic shock, at exactly similar results in registries like European Society Long-Term Registry. You can see that in hospital mortality also 36%. It is higher 1 year after the hospital discharge. In our position statement of Acute Heart Failure Committee, we decided to keep also the US classification in 5 stages because I think that the early intervention in these stages is crucial in order to interrupt the progression of the disease. And if there is limitation due to no so clear distinction between the stages, based mainly on serum lactate that is no ideal marker of cardiogenic shock. In cardioshock trial, we found that 80% of patients had positive lactate, but 20% negative lactate levels. But I think that it still works in clinical practice because it is related, especially in stages 4 and 5, with excessively high mortality. 4 is the refractory shock, at 5 is the cardiac arrest, the extremis, is the final stage of cardiogenic shock. This highlights the need for early intervention in the early stages in order to prevent the progression to late stages. The only intervention the last years that improve cardiac outcomes in cardiogenic shock is the cardiogenic shock team-based interventions. You can see here the results of 3 programs. The Utah Cardiac Recovery Shock Team, there is improvement of mortality in this population. The Innova Heart and Vascular Institute project, also there is improvement of survival of these patients. And finally, retrospective data from US registry, shock team-based interventions versus non-shock team, there is lower CCU mortality in cardiogenic shock cardiogenic shock team-based interventions. In this way, for first time, US guidelines for heart failure upgraded also the inotropes for the use of cardiogenic shock in recommendation 1 versus European Society of Cardiology guidelines that the recommendation is very weak, is 2B, and this means that there is need for early intervention, more effective intervention in these patients. And for the first time, there is also a recommendation in these guidelines about the management by multidisciplinary team experience the shock team in these patients in order to improve outcomes with recommendations to 8. Thus, what is the shock team? It's a core group of medical specialists collaborating in the multidisciplinary cardiogenic shock management to include rapid diagnosis, early recognition, and early staging of cardiogenic shock. Second, identification of specific cardiogenic shock phenotypes. MI-related, heart failure-related, other causes. Third, recommendation and facilitation of definitive appropriate interventions. The choice for mechanical support, for cath lab, for right heart catheterization in these patients. 4, the recognition of utility and the engagement of palliative care in some patients, and finally, triage of patients to the appropriate clinical care environment. And what is the staff of cardiogenic shock? In this US approach, the staff includes critical care cardiology, advanced heart failure, intervention cardiology, cardiac surgeon, and also ECMO services. In our department, we have added also another person, the emergency physician. Why? Because it's the first contact of the patient to the hospital in cardiogenic shock. We speak about shock team and shock doc. Shock doc is the key doctor who will start the activation of cardiogenic shock team from emergency department in order to facilitate all the other services of cardiogenic shock team at hospital interventions. What is the characteristics? There is also the staff. Is there a centralized way to activate the shock team? Yes, it's necessary. Is necessary the shock team at 24/7 service? And finally, is there a shock team member in hospital 24/7? It's not always necessary because there are some other forms for communication, like phone communication or web platform communication in this case. I will show later our approach with WhatsApp platform in order to communicate all this shock team. And this is, from my emergency department, a roadmap for the optimal management in these patients starting from the ED. In the first 3 minutes, we need the initial approach, the physical examination, ECG, echo, and also POCUS, lung ultrasound, IVC measurement, blood test, lactate, natriuretic peptides, troponin, some new biomarkers. We use also some new biomarkers like biodromedulin, also PENK1 from point-of-care systems. In order to identify the etiology, there is a good risk stratification, and finally to initiate the management with fluid resuscitation, vasoactive agents, oxygenation support, and to activate also the shock team in order to decide who patients will go to the cath lab, who patients will go for mechanical support, who patients will start other interventions in this stuff. And you can see also the timeline, from 30 minutes, 60 minutes to 2 hours to complete all this procedure in order to save time and to improve the outcomes. Another algorithm is the Utah algorithm. You can see here this algorithm, clinical suspicion, activation of cardiogenic shock team from emergency department. There was also classification in STEMI, non-STEMI. In STEMI, there is approach to go to the cath lab in order to underwent the patient's PCI, and also in some resistant cases, consider mechanical support or right heart catheterization. In the cases of non-STEMI, related with heart failure cardiogenic shock, there is from the cardiogenic shock team consideration also from the beginning of right heart catheter insertion for catheterization in order to select the appropriate mechanical support, right, left, or both right and left, short-term mechanical support. That is very crucial also based on hemodynamic parameters like CPO and PAPI index, pulsatile pulmonary artery index. And after that, you can see here from US registry, there is higher use of PAC with shock team, lower overall mechanical support, but higher advanced mechanical support at lower CCU mortality, increased use of Impella, tandem heart, no difference in ECMO, lower incidence of aortic balloon pump. And finally, in this multidisciplinary team approach reduces also cardiovascular death and also other complications in ICU, sepsis, bleeding, and other also lethal causes in these patients. But still, there is need for more trials, because if you see all the trials, there is the heterogeneous group of patients included. For example, patients with cardiac arrest exceeded from 23% to 62% in other registries or trials. You can see also the mean lactate from 5 to 2 to 2 to 3. There is a variation in the population in these registries. That means we need more prospective data, and we need also a continuous ongoing registry for these patients, also with shock team services. Because if you see here the working group cardiogenic shock in US, we can see that there is some difficult situations. For example, in out-hospital cardiac arrest, there is high mortality still. And also the mortality is higher in non-STEMI than STEMI. And there is no explanation about that. But this is also an observation derived from the ongoing registries. And finally, in the same way, in patients without coronary artery syndromes, you can see here in heart failure-related cardiogenic shock also the variation. There is de novo, acute decompensated, the mortality is higher in de novo, various etiologies, no rules for the optimal management of these patients. Thus, I think the ideal cardiogenic shock center, a team, we must, this criteria, a commitment to leading and improvement the management of cardiogenic shock with dedicated time for key individuals, incorporation of evidence-based practice, identification of best practices in this services, open culture of learning, good registries, multidisciplinary education programs, and research infrastructure and collaboration with other cardiogenic shock networks. Finally, I will present our experience. We activated the cardiogenic shock team the last years, involving cardiology department, emergency department, intervention cardiology, coronary care unit, intensive care unit, and cardiac surgery. For suspicion of a cardiogenic shock, we use very similar criteria for hypoperfusion, metal status, cold peripheries, lactate over 2, urine output, echo is also with ejection fraction lower than 40, severe valve disease, severe right ventricular dysfunction, hypotension, or need for vasoconstrictions. We have also some criteria for stage A, because missing data for stage A in registries is at risk, cardiogenic shock at risk. For example, some criteria is heart rate over 100, anterior ST elevation MI, acute coronary syndrome with pulmonary edema at low ejection fraction. Next is to see if there is coronary syndrome, to transfer the patients to cath lab, or non-coronary syndrome related cardiogenic shock, transfer the patients to CCU, and finally we decide for some palliative care in some cases with severe comorbidities, metastatic cancer, and also neurological deficits. The activation is from the ED, from ED physician or ED cardiologist, communicate with the interventional cardiology, coronary care unit, with support of ICU physician and cardiac surgeon. There is this specific platform, 24-hour online platform and WhatsApp application. And finally, we have also permanent registry at audits, monthly audits at mortality, morbidity meetings in order to improve our steps in this direction. You can see here the preliminary results, 35 patients. Majority of these was due to acute MI. 1/3 had cardiac arrest, 60% intubated, cath lab interventions in 2/3 of patients with PCI at half of patients, and mechanical support in 11%. You can see here the classification. More of them was in stages 3 and 4. The etiology was STMI or non-STMI, but 11% had decompensated chronic heart failure. The mortality was relatively high, but it's lower than previous years. It's 10% lower than previous years with the shock team. It's still near to 50%, but we speak also very severely ill patients. 1/3 had arrest, 60% intubated, and the ejection fraction was very low. The place of death was mainly in CCU, and the majority of deaths was 24 hours from ambition, while the other peak was between 4 and 7 days from complications in ICU, sepsis. The main etiology of death was multi-organ failure, refractory shock, anoxic brain injury, and the second cause was sudden cardiac death, and finally the third cause was sepsis. And from live patients, the vast majority discharged to home, and some of them for rehabilitation in other centers. These are the preliminary results. The registry is ongoing with the shock team services, and in my conclusion, I think the cardiogenic shock teams come to cover an unmet need in the management of cardiogenic shock. We need early recognition, multidisciplinary expertise, shared decision-making, standardized care. I will advise to adjust cardiogenic shock team structure and operation to local need and resources, and finally, Aticon assist registry sub at running. Thank you very much for your attention.
Thank you, Professor Parizis. Is there time for a short question and a short answer? Yes. Oh, two. Oh. One question.
Thank you, John, for this excellent presentation. I have some concerns about shock teams in ED, because usually shock patients should be in another environment, should be monitoring in another place. And then probably the role for shock team is those who are for palliative care to decide, or in another scenario in the community hospital also may have another option to consult them what to do with these patients. But I think the shock team is a very important step in the treatment, but not for emergency department.
Yeah, I agree, but my advice was to adjust according to the rules or the resources of each hospital, because in my hospital I have very well organized, structured resuscitation room with 7 beds, with monitoring, very good doctors with very good training in emergency medicine, that we have everything that we need to start immediately the treatment in this patient, also to start the short-term mechanical support, some cases, with ECMO or intra-aortic balloon pump. But you have right, it's also very crucial decision about the palliative care in some patients, and also to guide also the other interventions, possibly in the ICU, CCU, if there is no available, well-structured and organized resuscitation room.
One final short question, please.
Yes, if I understood well, the meeting of the cardiogenic shock is only by the phone, not in physical meeting. Is that?
What is the question?
If I understood well, the meeting of the cardiogenic shock team is only by phone, or not in physical, not physical?
No. There is the ED physician and also cardiologist, coronary care, but if you need to discuss some more services with cardiac surgeons sometimes, or ICU, you have also phone platform.
Thank you.
But initially there is collaboration of cardiologist, intervention with ED physician.
Okay, thank you very much.
All right, ready to get to the last session of the last day, and we have all the best speakers now. The first one is Múcio Tavares, live from Brazil, the influences on viruses and cardiac diseases.
Thank you very much, Nick and Frank, and it's an honor to be here. And this is really a new concept. Beside what happens in viruses, there is a real impact in cardiovascular diseases. But just to put everybody in the same page, I would like to talk a little bit about the influenza history, because influenza is the most common viruses. And the first reference starts with Hippocrates in 412 before Christ. The name influenza comes from Italian Salvatore. It means the influence. And some references say that about astrological unfavorable influence, like the period of cold. The first pandemic happened in Russia in 1889 with the H3N8 virus. Since then, four big pandemics. In 1918, H1N1, with 5 million deaths. In 57, with the H2N2, 4 million deaths. In 68, the age 3 and 2 million deaths, and 2009, the age 1 and 1, with between 152,000 to 575,000 deaths. You may all remember this 2009 pandemic. And this picture is what was done at that time. You see how large it was infirmary for influenza is a real picture. The World Health Organization estimating that flu affects 5 to 15% of the world population, with almost 3,000 to 6,000 deaths every year. But when there is a good match, vaccination reduces 40 to 60% the need for emergency care or doctor appointment. A good match is because the virus can shift, that is a complete change in the hemagglutinin and neuraminidase, or drift. There is a small change. And we can see what is a drift and a shift. When there is a shift, the vaccine effectiveness is very low. And you saw that influenza A is the most common because there is an aviary reservoir and adaptation to pig, human, horses, and other mammals. All the pandemics occurred with influenza A. Influenza B, it's almost only happens in humans and no adaptation with animal. So it's very, very unusual to expect an influenza B pandemic. Besides the benefits of vaccination and beside the lung diseases that influenza may cause, there is also some cardiovascular diseases caused by virus. And I will show more about influenza that is the most known. So you may all remember that in 1918, there was one important paper with 364 hospitalizations for acute MI, and the risk of admission during the interval risk was 6.05. They considered the zero moment of the risk interval, the positive detection of the laboratory positive detection of influenza. And then, during this period, the risk for admitting for acute MI was 6 times more. And interesting, there was no increase after day 7. We can see here that from day 1 to 3 and 4 to 7, increase in admissions, and it's amazing that after day 8, there was not. This may be related, and we all are each time more aware about how inflammation is deleterious for atherosclerosis. So inflammation may lead to rupture of the plaque and the occurrence of acute MI. And there is an inflammatory release of cytokines, a prothrombotic state, then plaque destabilization, thrombosis, immune complex deposition, and increased macrophage circulation, all that leading to acute MI, STEMI or NSTEMI. And we can also think about type 2 myocardial infarction because of the increase in the metabolism. You may all remember the IMI trial presented in the ASC Congress and then published in circulation that showed that 2,500 patients were followed and vaccinated after a myocardial infarction. And the patients were followed for 1 year. The initial recruitment was expected to be 4,400, but it happened exactly during the pandemic for COVID-19. And what they show is that vaccinating patients after a myocardial infarction, any moment of the year, was related to a relative reduction of 41% in cardiovascular death and in all-cause death in the primary outcome, and more important, 41% reduction in cardiovascular death. It was not possible to know if there was another myocardial infarction or a stent thrombosis because the patients didn't come to the emergency department. Many patients died at home, as in this and many other diseases. This makes us think that maybe that Netter painting that showed that after a meal, carrying weight, doing effort, and in smoking, and the cold was a trigger to myocardial infarction or angina. And I would say maybe the cold is not the case. Maybe influenza must be the case. What we know about heart failure and influenza vaccination? Many evidences appeared after the year of 2000, and this is from 2019, for communities in the United States. Here we can see the influenza seasons, and we can see in blue the visits for influenza, and we can see in black hospitalizations for heart failure. It was almost 5,000 adults, and this led to further investigations. And this was one of them. It was retrospective. It's the influenza vaccine, the effect in heart failure, in a Danish nationwide cohort study, with the objective was to investigate if flu vaccination was association to reducing cardiovascular deaths and all-cause deaths in patients with heart failure. And they show that in 134,000 patients, all-cause deaths was reduced with any number of vaccinations, but more than 3 vaccinations in the period study that was from 2003 and 2015, more than 3 was related to a reduction in 28% of all-cause death and the same amount in cardiovascular death. This was retrospective, but we have prospective studies like this one that was published more recently. Patients with 5,000 patients with any kind of heart failure were randomly assigned 1-to-1 to influenza vaccine or placebo. And what was found? Patients, the study was divided between the number of events during peak influenza and outside the peak influenza. All-cause deaths were in patients with heart failure was very, about 20% lower than patients with placebo, but only during the peak influenza circulation period. In the outside peak influenza, there was no relation. But pneumonia was not also was less occurring, about 50% during the influenza period, but also outside. If we compare drugs with vaccination, the benefit is very similar. But not only influenza. We saw that also in COVID. This was published about 90,000 patients with COVID and 350 matched control. What saw that including day zero, that was the day of the exposure, the odd risk for acute MI was 6.61. Interesting, it was very similar to that study, to that previous study. Vaccination for herpes. This is a meta-analysis showing a reduction in 30% in cardiovascular event and 34% in vaccination after herpes zoster. Even the rate of acute myocardial infarction after herpes zoster was 1.68 more than patients without it. But of course, the time after the diseases lowered the benefit. We are doing right now a study about the prevalence of influenza in ED facilities and the impact in cardiovascular morbidity. But we aimed the wrong target because we planned to see from 2019 to 2020. So we couldn't start because if we take a look at flu in general population, although 617 patients with flu syndrome, we had a positive flu A or flu B in only 11 patients. There are many other viruses circulating right now, like beside COVID, Epstein-Barr, rhinovirus, and also pertussis. And we also couldn't relate flu with cardiac or lung worsening because we had no patients until now with flu, with positive flu. I'd like to finish with this study that is made from a database from 2008 to 2019. That means 11 years, almost 2,000 patients with a cardiovascular event and vaccination within 12 months versus non-vaccinated. So they studied 120-day post-flu vaccine and after that and before that. And the acute cardiovascular event was acute MI, unstable angina, acute heart failure, stroke, ischemic transitory stroke or limb ischemia, the population was divided between high risk and low risk, and the patients with high risk had the higher protection. In general, cardiovascular protection on day 15 to 28 was related to almost 30% less events, and the greater protective effect was higher in patients above 65 years. We can see that any cardiovascular event less 28, myocardial infarction less 40%, unstable angina less 21%, acute left ventricular heart failure less 24, stroke less 30, transient ischemic attack less 18. So in summary, viruses are a trigger for acute myocardial infarction and death for acute myocardial infarction. Decompensation and death in heart failure patients, increase in cerebrovascular events. Influenza vaccination protects against the risk of these complications, mainly during the influenza seasons. So all patients with heart failure at least and other cardiovascular disease should be vaccinated. Thank you for your attention.
Dr. De Soma has one short question.
Very short. Fantastic, Musho. Really enjoyed a lot. My question is, okay, for tomorrow patients coming with the influenza in the emergency room, how can you detect between many patients we send at home, the patients that are going to have myocardial infarction? Did you have any suggestion to detect this one?
Well, I think the most important is to ask if the patient was vaccinated or not. This make the patient go in two different ways. But I think we need to be closer and look closer at patients with cardiovascular risk. Not all the patients with influenza, but the ones with many risk factors.
I just one final question, if I may. So the evidence looks quite clear that if you have cardiovascular disease, then vaccination is good for you, and it's part of our guideline now to do that for influenza. We've just been through the COVID pandemic, and there's a lot of research suggesting that you're more likely to have had a myocardial infarct if you had COVID than if you had been vaccinated. There's also a kind of drive, after all the industry investment in vaccination here, to continue to give COVID vaccines in the future. And so my question is whether you think there will be a role for ongoing vaccination for COVID in vulnerable high-risk patients who may be at risk of cardiovascular events or not.
Well, I'm not infectious disease specialist, but what was discussed is that COVID-19 or SARS-CoV-2 will behave in the next years of the next decades as a common flu. We see each time patients with less severe diseases and dying with a much less rate than before. I think that vaccination makes all the sense.
Excellent. Well, thank you very much for that fascinating presentation. Okay, we're going to pivot from Brazil to Singapore, and looking forward to hear Sui Han Lim tell us his experience over the last 20 years about the use of cardiac troponin.
forward pointer. Forward. Backward. Backward. Thank you for the kind invitation. It's my privilege and honor to be here. This is my academic affiliation. I'm a simple emergency physician. So at the end of my residency, and my government sent me to Royal Infirmary of Edinburgh, and we learned excellent clinical emergency medicine. And my supervisor, Corey Robertson, told me that to make a diagnosis, it's 80% good history and 10% physical examination, and the rest will add on to another 5 or 10%. And 3 years later, for my advanced training, I was sent to University of Cincinnati, working with Dr. Brian Gibler. And at the time, CKMB was the gold standard for the diagnosis of MI. And he was doing a clinical trial with troponin T point of care, under Boehringer Mannheim before they were brought over by Roche. And in 1997, my lab chief sent me to this Bali meeting funded by Boehringer Mannheim, and Dr. Carter's, inventor of troponin T, and then Dr. Alan Wu and Elliot Edmund, and also the Reklik, I think from Sweden, and this Japanese cardiologist, I can't remember his name. And I was standing right behind, hiding right behind, and I was converted. So we got some money to do a randomized study, and with Dr. Jacob is the late Dr. lab chief, and also we have this is my mentor Ananta, and then Terence Chua is the chief of nuclear cardiology, and we study patient present to ED with chest pain, suggestive angina, and non-diagnostic ECG, and also we exclude patient which is suggestive of typically, and that means they have a history of coronary artery disease, came back with the same presentation, and those definitely not cardiac chest pain. Again, is a clinical diagnosis and require admission for other concomitant medical problems. And so all the patients have 036 hours CKMB troponin, and then 2/3 will go to stress nuclear scan mandatory, and then 1/3 will go, the senior emergency physician will decide whether to admit or discharge. And for admission, we need to go through the cardiac fellow. And we follow up the patient for 30 days and 1 year. And this is an endpoint adjudicated myocardiac sort of adverse cardiac event, and also CAB, critical coronary artery disease. And this is the results of our biochemical biomarker, and you can see the ROC curve of troponin is quite impressive. However, the statistician give us the 95% confident ROC and all that. There's a lot of overlap, between troponin T and CKMB. So we look at the result. We look at those with adverse cardiac events and the old sort of fourth generation troponin T, and 50% concordance and 30% both miss, all right? And for those in between, troponin won most of the time, and so because of this, we swap overnight, all right, to troponin. And we never publish our result for various reasons, which long story we haven't mentioned. So this is the stress echo. The second row is stress image, and then the top row is the rest image. And you can sorry, the other way around. The stress image is the top, and then the lower row are the rest image, and you can see the sort of defect. This patient had a critical coronary artery disease, randomized to the stress nucleus. In fact, he was a garbage collector. Every time he pushed the truck, he got this neck pain and arm pain, and then we randomized normal troponin conventional troponin. We randomized to this study. And however, it doesn't show any difference in outcome, all right? But it cut down admission rate, cut down the rate for coronary angiogram. And we are thinking of whether we should use clinical score to replace stress myocardial perfusion because it's quite expensive, you know, and also limited sort of availability. And then for those who can't do there's about 20% of the patient which cannot do enough exercise stress, you know, and these are the group of patients that will have a higher 30 days MACE, you know, and so we don't think that exercise stress test, although it's cheaper, is a solution. And here comes the high sensitive troponin troponin. This is a landmark paper, and my chief of lab clinical chemistry summoned Terence and me to his office, you know, and he said that we have to switch to high sensitive troponin because they are not going to produce conventional troponin anymore. So are we going to change the cutoff value because the old value was 30, you know, now we use 13. So we say no, you know, because in 30 we already see some false positives, so we cut down to 13, it will be a crying wolf, you know. So we say we kept to 30, but without knowing it, actually we already shifted our cutoff from 54 to 30, right? Because the two, you know, that's how, you know, the correlation between a fourth generation troponin and high sensitive troponin. So without knowing it, and this is a very important paper by Christian, you know, one of my heroes. This is the first paper to show that we need two cutoff points, one for rule in and one for rule out. And so we no choice, we have to collect some data, and we finally published our data on patient, you know, a same cohort of patient, and we found that, you know, it's almost a straight line. So when the level of high sensitive troponin go up, the PPV went up, you know, go up. So actually, you know, to define the cutoff point is quite difficult. You know, the choice is I don't know, it's yours. And we also found that for the delta, you know, it's +7, not for our population, it's +7. And you can see we choose 16 as our cutoff point because of a Y index, and even very low 5, the negative predictive value is still quite not that high, you know, it's 96%. And if we use so cutoff point of 30, it gives a PPV of around 50%, which is nice. And if we use 52, it's about 66.7 PPV. So this is our, we published, so this suggested, and the statisticians say maybe you should use 0 and 2 hours, 26, you know. We give you a rule in about around 50%, 60% at that time. And if you use 0 and 2 hours, 16, it will, you know, it is 97 negative predictive value. So how to cut down further? And then we talk about HUD score, and this is the HUD score, and I met Barbara Beckers 1 month ago in Amsterdam, so we took a picture. And according from our data, we found that, in fact, you want to have a MPV of 99.5, I think we should use cutoff 2 rather than 3. Okay, so we're comfortable with 2. And so we started our chest pain protocol. This is the exclusion-inclusion criteria. So all cases must be vetted by ED attending, and we excluded those with you know, renal failure, as well as those have a raised baseline troponin. And you can see this is extremely complicated, you know. So definitely we need some artificial intelligence. and this is the those with this. Yeah, so just to show, and also we say that patient with persistent chest pain or dynamic ECG changes, we have to admit, okay? Yeah, so we need artificial intelligence. And then we went back to the previous study, the randomized study, because we collected very good history because we have a template, for collecting history, and it entered in our electromedical record. And the history are collected by the residents or medical officer equivalents. And we found that, and also every patient had a random LDL and HDL, and also sugar, all right? So this is our sort of coronary risk as well as the history. And it shows that, pain radiate to the jaw and neck, but not the arms, okay, associated with diaphoresis, aggravated exertion, relieved by GT. And these are our typical feature in our population. And then if the associated population is negative. And so we derive a score, and then we also found that, so please ignore on population, it shouldn't be there. About 13% of the patient with MACE has none of the typical symptoms. And about 73% of non-MACE has one of the typical symptoms. So this is live. So this history. And if you combine this score with troponin, we can sort of excluded about 20% of the patient, but those low-risk group where you don't need any stress test, no need any further cardiac follow-up. And we can in fact, there's a very low-risk group, about 63% if the score is less than 13, and this group don't even need to come to emergency department. So we also dissect of the previous data. These are the hard score, right? So the ECG score of them are 0. And we found that troponin, in fact, is the most important, highest positive predictive value. So if the troponin score is 1, this is conventional troponin, the PPV already 70.8%, so we don't have to talk about history or coronary risk factor. And there's one group of patients with very low risk, small group of patients. That means this group of patients don't have coronary risk. They have a normal LDL, normal HDL, as well as a normal random sugar. So it's almost 0. So again, they don't have to come to the hospital. Yes, and history is, the positive predictive value is not very high. It's about 10 to 20%. Right, so going forward, I think we need artificial intelligence, and Nick, as the anchor author of this paper, and this M13 show that if you put in the sex and the age plus the change in the troponin, you can get a better predictive value than the ERC guideline or the sex age specific cutoff. And of course, this is very, very, Christian and Nick around, the latest paper, using the this dots, and it shows that the multiple variable, in fact, you can even more accurately predict. Unfortunately, there's not many paper on this model on troponin T, So I think maybe it's time to explore that. So in conclusion, separate population-specific rule in and rule out cutoff values for high-sensitive troponin are required. Like in the United States, Frank paper showed that it's 19. And then I also want to mention decrease in 2 hours high-sensitive troponin to 16 does not predict MACE. So for us, if we see a decrease in 2 hours troponin T, it doesn't predict MACE, right? So it's different from other data, right? Different from the other the recommendation by AHA, ACC, ESC. And high troponin T have to be used in conjunction with age clinical presentation, coronary risk factor ECG diagnostic, so we need an AI. And for heart score, we use rule out is 2 and rule in is 6. Okay, and beware, patient may have more than one pathology that can cause elevation of high sensitive level, you know, and we have a patient present with urticaria and also have some chest pain, and then in fact he have urticaria with MI, so do beware. And a rule out MACE doesn't mean that the patient is okay. Aortic dissection and PE, very difficult to exclude. I think that's all. Thank you for your attention. And
Thank you for that lovely talk. I'm a student of the history of medicine, and it's wonderful going back to see the old Royal Infirmary. I remember Colin Robertson calling me down to that emergency department as a young SHO to come and see patients with abnormal CK and B results. And I was determined to prove that it was a false positive every time. And probably it was. But, you know, it's interesting. And it's also good for the young trainees to see those pictures of the heart. You know, the tiny hearts there. That's all we had back then, the tiny hearts. But we all have the same challenges, I guess, in how to incorporate symptoms, risk factors, and biomarkers into a pathway that works for our healthcare system. In Singapore, do you have a high prevalence of myocardial infarction? Do you think there are regional differences that mean that your pathway needs to differ from, say, a European pathway in Basel or a pathway in Scotland?
Yeah, I think, you know, this the cutoff point is based on the prevalence, you know, and also how you define the 99th percentile of, you know, how stringent, you know. You want to subject everybody to MRI, to, you know, stress echo, and and the age as well. You know, usually in the 99% cohort, usually they choose younger patient, very few elderly, and that's why I think we need to have a different cutoff point. And again, it's a straight line, so you have to make a decision somewhere. You know, and to find the most efficacious cutoff point.
I also liked your photograph of the troponin T expert consensus group in 1997, and I think it's fascinating that we're still debating how to use this test 25 years later. But thank you very much for that excellent talk.
Thank you.
And next we have David Brenner, live from San Diego.
Still there from San Diego.
All right, changing paradigm in research.
And this is the pointer.
Okay. Thank you. Thank you, everyone, for hanging out with us. So this is an area that I've become very interested in, and hopefully that'll be obvious very quickly. But I'm thinking about how we organize clinical and translational research and whether we can do it differently. But first, I'm going to orient you to San Diego. And those of you who golf will know that this is the most famous public golf course in the United States, Torrey Pines. And it's directly across from my office. And the only problem is I never learned to golf. But if you look at this Torrey Pines Mesa, there's a major university, UC San Diego, and there are 6 not-for-profit private research institutes: Salk, Stanford Brennan Previs, Scripps Research, La Jolla Institute of Immunology, Venter Institute, and they're all within walking distance. And right behind it are 600 biotech and big pharma laboratories, not manufacturing laboratories. So when I moved, for many years I was the vice chancellor at UC San Diego, and I moved to Stanford Brennan Previs. I went through this thought process: are we doing research correctly? Is there some way we should organize ourselves to be more effective? I mean, we're in Germany, and most should probably know this, but US medical schools and US universities are completely based upon 19th century German universities. So maybe that's not the best approach for 21st century research. Okay, so this is my current institution, Sanford Brennan Previs. It has several scientific centers. It has, we call them technology cores, or they're cores, you know, for support the research. It has its own graduate school, it gives a PhD in biomedical research, and it has the Previs Center, which is the largest academic high-throughput screening facility in the United States. The whole idea is that we should be developing at least the beginning compounds for drug discovery. Okay, so I don't know if you're familiar with this, but what people do in the United States when they go to a new institution or look at a new program, they do a SWOT analysis, which stands for strengths, opportunities, weaknesses, and threats. The strengths are kind of unique to Sanford Brennan Previs, but the weaknesses, threats, and the difficulty, the opportunities, I think are generalizable. And that led to thinking about why is it so difficult to do research despite having, you know, an amazing environment, great resources, great colleagues. And someone tried to explain this, and this was Kuhn. So the way most of us were taught, the conventional wisdom, is that you have regular, we call it the normal science, and you incrementally increase it. So you get some new ideas, and slowly but surely you make it better. He said that's completely wrong. That is not the way science works. The way science works is that you have your normal science, and then the model, you get some problems, it doesn't quite fit anymore, and then there's a crisis. And then that leads to a revolution and a paradigm shift. The best example I know is, you know, Darwin's Origin of Species. It changed everything. After 2 days in this audience, I think people here probably think troponin was a paradigm shift. And that might be right. It changed. I learned with MBCPK, so I don't know. But I think in the current practice, you would say troponin changed everything in a certain type of medical care. So I think we are now in a crisis that we can change the way we do biomedical research. So this is the steps I took. This is just for me to make people own this. So and you're going to be the first person to see this, so be very critical when I show this to you. I did the outline for this, what I'm going to show you. I then brought it to the principal investigators at the institution. I then have an external scientific advisory board who are very tough and stress tested this, and I actually report to a board of trustees. And at the end, I want to be able to explain why I want to do research different at this institute than I had been previously trained to do. Okay, so this is sort of the mission. So the mission is to conduct biomedical research, but it's not just to do biomedical research. It's to do biomedical research that translates into discovering cures for devastating diseases. And this is different than my colleagues at Salk that study earthworms and plants, and different than my colleagues at Scripps Research that does primarily chemistry. So this is a unique role that I think fits in well with physician scientists. Okay, so now people are not going to like this. So this is going to go from what our current way we're set up to what I'm proposing. So in academia, we always have independent faculty members. They get promoted. They have to show their own stuff. And what I'm proposing is that we have disease-focused centers of highly interactive people. Self-contained labs go to team science. I don't know if you're familiar with this. R01s are the unit for getting funding at the NIH. This is everyone's goal. But instead of aiming for R01s, we're going to aim for multi-principal investigator grants, center grants, program projects that involve teams. A big change is that we're all trained to do hypothesis-driven research, and this is more what we call discovery-driven research, where you use, instead of using small data and hypothesis, you use big data. It's going to emphasize translational research, which up until recently was a dirty word because it was not driven by hypotheses. And it'll have a different group of people. Most of us consider ourselves biologists now, you know, as physician scientists, but it'll involve people, more chemists and more data scientists. And I know there are a couple of department chairs in the audience, so I apologize. I don't think you have any future. I think the future is going to be in disease team leaders. Okay? So this is a change, and I'm going to show you a cartoon that will hopefully put this all together. But the change would be that there will be disease-focused, highly collaborative, multidisciplinary, multi-institutional research, which will advance. We use the term assets. It's like, for example, like a compound that looks like it might be a drug, or a knockout mouse that might give you insights into pathophysiology. It emphasizes translational research, which is relatively new, especially in the US. And it emphasized the idea of, can you push this into commercialization? Can another source of support for research be commercialization? It emphasizes data science, which is something that we never did until very recently with next generation sequencing. And integrating clinical research and translational research, setting up so that you can go everything from very basic spatial transcriptomics all the way to clinical trials. I think one of the things people should like is that it reemphasizes physician scientists who actually understand the clinical problems and know how to approach them. And it emphasizes, as I said, entrepreneurship in addition to traditional funding to be able to actually commercialize and advance your assets. Okay. If you're going to do this, the faculty you recruit is going to be slightly different. I mean, this is the obvious answer to every faculty. Everyone we want to get is to recruit the best postdocs and the best labs and the best institutions. That's still true. But in addition, we need people who are highly collaborative, who are not going to be siloed, who want to interact in multidisciplinary projects and really hard projects. And we have to change the way we do academic advancement. If you're going to be a computational biologist and be a middle author on your papers, we're going to have to protect those people and make sure they can advance in the current academic environment. And we also have to say that we're going to recruit people besides our traditional biologists and biochemists, but people who know enabling technologies, who like computational biology and artificial intelligence and drug discovery, and we're going to have to treat them as colleagues and advance their careers in an equal way. Okay. I also wanted to say that the way we do graduate school should probably also evolve in step with what I said, that many people go into biomedical research and go into academia, but also even more, at least in the United States, go into biotech. And we should appreciate that and train people to do that and let them have a big experience that will allow them to do this in addition to those people who want to go on and reproduce what you and I do. Okay, so this is the key slide. So the first thing you notice is that there are no departments. Instead of departments, there are disease-specific teams. So it's independent of the way you're trained. You could be trained as a cardiologist or as a cell biologist or as a radiologist, but you'd all be working together on cardiac diseases in a cardiac center. So this happens to be the 4 diseases I think that our institute can do the best. But this is not relevant probably to other places. But obviously cancer is one, cardiovascular is another, neurodegeneration, and because of my training, metabolic and liver disease. But then going across this are enabling technologies like high throughput screening, artificial intelligence, multi-omics, being able to generate these large data sets. These are agnostic. These people can work on any problem. So we have to be able to have them look at our diseases and bring them into them and embed them with us, but then be available for other types of approaches. It also obviously involves clinical partners as well as technology partners. Okay, so the one that I'm starting to work on now, because I am a hepatologist and interested in metabolic disease, is this Metabolic and Liver Institute, which will allow everyone from spatial transcriptomics, basic biologists, all the way through clinical trialists to be able to maximize their understanding of patient material, to be able to enroll people in trials, to be able to do ancillary studies, and to separate the clinical and translational research from the hospital working. Because if you compete with the hospital for resources like MRIs or DEXA scans or others, it won't work. We won't be able to do the efficiency of scale that we need to do to be able to do this. Okay, so this is our high-throughput screening facility. If you have a high-throughput screening facility, you have to show a robot, because it's just, everyone has their favorite robot, and the robot always has to be yellow. I'm not sure why. But this is our robot. It's happily screening up to 300,000 compounds in a week. The idea is to make this available to academics. This is a concept. This is what I think we should be doing as academics. Genetic screens, mouse models, high throughput screening with the right facilities, and then computational medicinal chemistry. And then we need to partner with industry to make this successful. And the partnership is based upon, do we have a good molecule? Is there scientific strength to support the therapeutic hypothesis? And is this competitive? And with that, I think we in academics should leave and move it on into industrial partnerships. Okay. So the last very short point I want to make is in artificial intelligence, where does this fit in? And one of my colleagues gave me this slide. He said, David, you would not believe how much venture capital is going into artificial intelligence, and that we should be leading this and not following this. And this is just a list that the Prebys Center for Drug Discovery made of the types of things artificial intelligence should be doing in drug discovery, and includes target identification, molecular simulations, prediction of drug properties, de novo drug design, candidate drug prioritization, and synthesis pathway generations. And this is my last slide. The very first person that we hired as a faculty member was not a cardiologist like Salvador, it was not a hepatologist like me, but was actually an artificial intelligence engineer. And what he said is that the way to approach this is his slide, is that you can use artificial intelligence to identify targets, which he's already doing. You can use artificial intelligence to identify toxicities. And then the grand finale is you could use this generative artificial intelligence model to actually predict and generate new drugs. And that would be, of course, the best possible result. So this is where I am now. I am trying to socialize this. You're the first group I tried to socialize this to, and I very much appreciate the opportunity to do this. So thank you. Questions?
Okay, we're good for questions. And I got the first one.
Sure.
How are you going to monetize that? I understand all the idea, and I understand how to get money from the government, but that's because they give you the money today and then you spend it. You're having to spend it before you have a product.
Yeah, no, that's right. Just very quickly. So the current institute is 80% NIH grants or other types of grants, 10% philanthropy, and 10% business development, intellectual property. So there's enough money to invest if there's return. For example, if an asset is developed by this drug screening, we can make decision, do we want to push it without using our own funds, push it forward to make it more valuable, or try to get out of it more quickly. And so by having, roughly $10 to $20 million a year philanthropy, that gives me the opportunity to do that. But hopefully the philanthropy won't be so dependent on philanthropy, and the return of the investment will continue to kick in as we develop new assets. If not.
Okay, anybody else? All right, well, I know where at the table he's going to be sitting at having a glass of wine shortly.
Yes,
so
I will.
We can get you then.
Thank you.
And our last one, we say the best for last. It's how this always works. It's Tatiana Kaseleva, Genetic and Epigenetic Approaches to Heart Disease. So after this, there's a glass of wine waiting out there. So, you ready?
Yes. I want to thank the organizers for inviting me. It's a very, very exciting meeting, and I have learned really a lot. Oops. Got it. Yeah, I got it. Okay, thank you. So I will switch the topic, and I will talk today about myocardial infarction, which is characterized by immediate inflammatory response, extensive cardiomyocyte death, and replacement fibrosis to prevent cardiac rupture. And replacement fibrosis occurs in response to cardiomyocyte apoptosis, necrosis, inflammation, and is characterized by activation of fibroblasts, which produce collagen type 1 and produce fibrous scar. And this is the representative images of the mouse model of myocardial infarction, and serious red, and also here staining for alpha smooth muscle actin, demonstrates development of fibrous scar in mice. Development of fibrous scar is very positive because it prevents the rupture. And it is mediated by the crosstalk of endothelial cells, cardiomyocytes, mast cells, lymphocyte, and of course myofibroblasts. Myofibroblasts develop from fibroblasts from the liver resident fibroblasts, but they produce collagen. So in response to injury, cell death, production of reactive oxygen species, angiotensin II, high glucose, altered pH, activation of TGF-beta, which is produced by monocytes and inflammatory cells, leads to activation of fibroblasts into myofibroblasts, production extracellular matrix fibrous scar. But then there is a next phase when these myofibroblasts have to inactivate. They have to stop producing collagen. And one of the mechanisms by which they inactivate is they undergo senescence and clearance by immune cells. So there are several predispositions to myocardial infarction. And one, of course, is genetics. And out of many, many genes which are critical for development, atherosclerosis is linked to two genetic locuses, and this is this locus, and these mutations actually have been linked to these 4 genes. And out of these 4 genes, ApoE, ApoB, and LDL receptor are critical in the pathogenesis of atherosclerosis. These genetic factors are critical, but they are predispositions. So there should be other environmental factors which allow these factors to be causing the disease. So what are the other factors? And the other factors are epigenetic factors and gene expression profile. And several new technologies have been evolving in the recent years, which allow us to look at the more specific factors which are not involve genetic mutations. So one of these techniques is ATAC-seq, and allows us to look at the unraveling of the genomic DNA and opening chromatin, and usually it's linked to transcription. However, RNA-seq is the technique which allows us to understand if these genes are either transcribed or suppressed. Finally, proteomics allows us to actually understand if the levels of RNA are translated into the proteins and how these proteins are upregulated or downregulated or stable. And this is one example that combined analysis of RNA-seq and ATAC-seq gives us identification of all the cells that I already mentioned to you, and we see that fibroblast population plays an important role in development of healing during the myocardial infarction. And so we can actually analyze combined data on cardiomyocytes. The big changes in gene expression profile, in epigenetic profile, are shown in cardiomyocytes, but again, so fibroblasts play an important role in development of this transient fibrous scar. So we are going to focus on fibroblasts, and this is the data from mouse models of myocardial infarction. In normal heart, there are fibroblasts, but they do not produce alpha smooth muscle actin or collagen and do not proliferate. But in response to injury and release of TGF-beta, there is an activation and proliferation of fibroblasts, and by day 4 or 7, they start produce collagen and regulate alpha smooth muscle actin. But then after day 10, formation of scar is accomplished. And so these fibroblasts, they have to persist in the cardiac wall for a certain period of time to make sure that there is no rupture. But then they have to be eliminated. And one of the ways to be inactive, so they stop producing collagen and they stop proliferation. So what happens next? In the phase of proliferation or healing, so and here we're looking for epigenetic profile of this fibroblasts. No really big changes in the uninjured, But if we look at the day 3 and day 7 during the healing process, formation of fibrous scar, fibroblasts change the epigenetic profile, unravel the genomic DNA sites for transcription very strongly. And after 2 weeks during resolution phase or recovery from fibrosis, we see that the epigenetic profile changes dramatically, and there is a upregulation of genes that we haven't seen in the normal fibroblast. So this is translated to the gene expression profile, and again, so healing phase is associated with proliferation, formation of the stress fibers, migration, and deposition of extracellular matrix proteins. And this ends by day 7. With week 2 and week 4, we see that there is a resolution phase, and production of extracellular matrix and proliferation is accomplished, and there is an upregulation of very interesting group of genes which are linked to the cartilage production. And why is it important? Because those myofibroblasts or fibroblasts which exhibit an impaired phenotype, they potentially can contribute to heart fibrosis and lead to heart failure. This is another example of looking at the spatial transcriptomics. These techniques allows us to look at the specific populations, its specific part of the heart. So the heart is sectioned, hybridized with different transcripts, and finally released, so we can identify in the scar of the heart different population of myofibroblasts or fibroblasts, and different colors reflect their different position in the cardiac wall. But also they have different emergence of production of collagen during different days. Like for example, the first is the early intracardiac scar is 3 days after the myocardial infarction, then 4 days intermediate, and 7 days is the final fibrous scar formation. So what happens during the resolution? After 2 weeks of myocardial infarction, myofibroblasts either apoptose, so they have this programmed death and they're cleared by immune cells, or they senesce, so they have this cycle arrest and they just hibernate in this cardiac wall. 65% of the cells are just waiting for their cell fate. And what happens to them afterwards? So some of these senescent cells are called helper cells. They actually have a very positive role. They promote cardiomyocyte maturation, maintain tissue homeostasis. They're resistant to TGF-beta, and they're susceptible to apoptosis. Approximately 3 weeks after the myocardial infarction, these cells are cleared by NK cells. But there is another group of senescent cells which are detrimental, and they persist in the heart after 6 weeks. They induce senescence of cardiomyocytes. So cardiomyocytes cannot populate this area, they cannot proliferate. They promote inflammation and cardiac fibrosis. They respond to TGF-beta and actually can proliferate and again, produce fibrous scar. And they're resistant to apoptosis. So these cells are critical for development of heart failure. Why is it happening in some patients and it doesn't happen in other patients? So development of senescent, detrimental senescent phenotype is linked to the telomere shortening, specific epigenetic changes which are linked to upregulation of this methyltransferase, accumulation of DNA damage, oxidative stress, mitochondrial dysfunction, and very important, the upregulation of p53, p16, p21, the genes which are critical for inhibition of cell cycle, while the survival genes are actually upregulated. Senescent, detrimental senescent cells, they also secrete senescent-associated secretory phenotype, a bunch of cytokines which affect nearest cells. They can be recognized by expression of beta-gal. They prevent their own removal through protective senescent cell anti-apoptotic pathway, SCAP. They promote senescence of surrounding cells, I already said. They promote aging and cancer. So what is the function of senescent-associated phenotype? So senescent cells secrete IL-6, IL-8, ataxin, different chemokines, CCL5, so IL-6, which are known as very highly inflammatory cytokines. Very important that CCL2, which is secreted by senescent fibroblasts, can prevent immune clearance. It's a sort of like suppresses activation of T cell and K cells. A recently identified pathway, activation of GATA4 in senescent fibroblasts, leads to mitochondrial damage. Another pathway has been suggested that serine proteinase activates TGF-beta IGFBP7 pathway in cardiomyocytes. And the authors of this paper also suggest that IGBP7 can be a marker of dying and failing cardiomyocytes. So what can we do with this? How can we get rid of this detrimental senescent cells? And senolytics are the biologically active compounds that specifically can remove senescent cells. They can target one or more of these pro-survival proteins, can preventively induce apoptosis in senescent cells. Targeted removal of senescent cells through agents called senolytics was shown to enhance lifespan, alleviate systemic inflammation, improve organ function, and also mitigate characteristic age-related disorders. So it's the future, the drug of the future. And this is one of the examples when in the post-myocardial recovery phase, senescent fibroblasts release SASP, and these cytokines induce senescence of cardiomyocytes and also stimulate production of fibrous scar. But if these mice are treated with senolytics, then senescent cells are eliminated. There are no production of SASP and inflammatory cytokines, and no formation of fibrous scar. And the drug that has been tested in this particular study was navitoclax. Several generations of senolytics have been generated. As David said, that original drugs were designed by, driven by hypothesis. And so what was the hypothesis? That first of all, we need to remove or the block, the genes that prevent apoptosis, and also the kinases which are associated with the senescent phenotype. Several lysosomal proteins. We need to neutralize P53, induce block cardiac glycosides, and also like heat shock proteins which prevent apoptosis and provide survival signals also should be blocked. But the recent generation of senolytic treatments is based on the high throughput compound library screening, vaccines, and one of the potential ways to eliminate senescent cells is generate the CAR-T vaccines. Recently, 2 papers were published, one in Science, one in Nature, suggesting that there is a way to target senescent detrimental fibroblasts using a fibroblast-associated protein. There are 2 other examples which I would like to mention. Cellular therapies, cell stem therapies can be potentially useful for treatment of myocardial infarction by injection of the stem cells into the injured area. But the question is that if we have senescent senolytic cells, do we need to treat these hearts with senolytics first before we anticipate that the stem cells will give rise to cardiomyocytes? The second potential and very interesting pathway, or the therapy, potential therapy, is to introduce either transcription factors that can be beneficial for cardiomyocytes for their proliferation and differentiation, or block certain mRNAs like in fibroblasts, which prevent the fibrogenic responses. And that will be the reprogramming factors. And usually it can be used either by adenoviruses, like in this case, the authors used adenovirus 8, and that will be the cellular therapy that potentially can be very interesting in the future. In conclusion, cardiac fibrosis fibroblasts are the major source of fibrous scar in cardiac fibrosis. Cardiac fibroblasts originate from endogenous fibroblasts derived from epicardium. Cardiac fibroblasts transiently activate to 7 days. They lose SMA expression during recovery stage. And cardiac fibroblasts that persist in fibrous scum for more than 28 days after myocardial infarction exhibit a senescent phenotype. Senescent fibroblasts do not proliferate but maintain local inflammation and promote senescence of surrounding cells. Senolytics are a new class of drugs that cause apoptosis of senescent cells. Thank you.
Fabulous talk, and it's absolutely remarkable what these discovery science methods can do in terms of giving us insights. We need to work out how we're going to use these. I'm fairly sure that red wine is senolytic, isn't it? I read
Yes.
that somewhere.
I agree with you.
I'm sure we're going to be in need of some senolytics after today.
This is a tough one to be the last lecture.
It is.
Yeah.
I have a question for you. This is coming from a cardiologist's background, not an expert in discovery science, sorry. I'm sure you're right that the fibroblast plays a really important role in the recovery of the myocardium after myocardial infarction, but we completely ignore it. And one of the questions I always ask myself when a patient comes in with an acute coronary occlusion and a completed infarct days ago, late presentation, is whether I should open the artery or not. And I guess my question really relates to whether you think that having an active vascular supply to the myocardium during that period of remodeling would be useful for the clearance of these senescent fibroblasts or not, and if you've got any insights from your experimental models that might help us answer that question.
That's a great question. I don't think I can answer this question, but of course, you know, the environment also predicts why this fibroblast becomes senescent, detrimentally senescent, and that is associated with age, with obesity, with many other factors. But what I also want to say that fibroblasts is the only population that I mentioned. So we also talk about immune system, which get tired and get senescence. So of course, you know, like the more oxygen, you know, you can bring to the site, the better the outcome is.
Okay.
So if I give one of these anti-senolytic drugs too early, like in the ER, is there a negative effect, like we're going to blow out the heart?
So at this point, all senolytics are in clinical trials in the phase 1, phase 2, and I don't think that any of these drugs went to phase 3 yet. And nobody really knows how to use them. But I think that the future would be to find the optimal combination of different drugs. Like, for example, one is the antioxidant, and another is targeting a specific cellular population that in combination would be harmless. And probably that would be the solution. But so the person that I also mentioned, Kirkland, from Mayo Clinic, so in one of his lectures he said that so when we think about going to Mars, so that would be not possible without senolytics.
Nicholas?
Because, so when you do myocardial infarction in mice, it's very stereotypical. So it's always the same zone that is infarcted, etc. In human, it's very different because, and so do you think that depending if the fibroblasts come from a zone that is hypoxic versus less hypoxic, it may affect the way they will differentiate into senescence versus the other one?
That's a great question, but I actually think that it's probably more related to like telomere shortening, the RAS production, and again, factors that are more general factors related to this patient. Of course, you know how the zone of infarction affects the fibroblasts and their migration into the zone is important, but I think that the general inflammation in the body would be probably also very important.
And with that, I'm going to invite Dr. De Soma to come up and make the final comments.
Wow, the room is full now.
But we promise to be quick. So of course I want to start by thanking you for attending the meeting and making it such a wonderful scientific exchange. We heard about the future, possible future in the last talk, but I think, and I'd like to highlight to you that the future that is much so nicely presented by the young people among us, and you are the future in our field. So therefore, again, this meeting is committed to you and helping you advancing your career within our teams, within our network, because it is up to you to develop the science in the way that in your field, how you think it is best. And I think your excellent presentations throughout the 2 days has wonderfully shown us how well equipped you are to drive the future. You have been wonderful. You have done outstanding presentations. You have kept the time much better than the masters. You have done great preparations for your talk, and I really can only congratulate you. Having said that, of course, I also want to thank our sponsors, those who have stayed with us over many years and hopefully continue to stay with us. I hope also for them this has been a great opportunity for exchange, and particularly in the field where academics and industry are able to develop research jointly and in a very collaborative manner. Now, likely the most challenging task, I'm not sure whether it is completed, it's again for the committee, those experts that have followed all of the presentation of the junior scientists and the senior scientists who had the enormous task of making a ranking among them, and of course later on during the reception, the committee will present their rankings and award the young and senior prizes. So that was I had in mind to say, and now about the future, I hand over to Sal.
Thank you, Christian. Let me tell you that I would like to start congratulating with you for the fantastic program you made. It's been really the best one. Putting together many different angles of the science, and really I have to congratulate because you have done a really terrific job for many months. And really, I would like to thank you for the fantastic program you set up. Now is my time to show some, let's say, transparency data, but I just want to show the slides, if it's possible. Okay. Okay. Okay, now that's, I know I am a treasurer, vice president, but also I have the role to tell you that, of course, as Great Network, we are doing since 16 years now a lot of effort to make you happy, right? And that's our first goal beside the science. And, you know, this has been a really expensive meeting, but it makes sense because there is a lot of quality. And I would like to congratulate Valeria and Stephanie for the great job. They have, you know, it's always difficult from Italy to organize a meeting in Germany, especially in Berlin. So Thank you, Valeria. Thank you, Stephanie. So, okay, now we survive as a great network to make you happy for the science, the accommodation. Thanks to the sponsors. Again, I would like to echo what Christian said. Thank you to the sponsor, and I hope that in the future there will be more opportunity to have a sponsor, because this year we are starting with a little bit less balance in our account. But the good news that in the future, like Christian asked me to tell you, we have the meeting in probably a city a little bit less expensive than Berlin, that is Rome. I'm happy that you enjoy. I know at the end of the day, we decided in Rome, that have been done many times, to have some kind of a, let's say, situation that make everything going better in terms of cost. We hope Valeria is open to be, because she's very good in making some kind of contract with people, so she will do definitely a good job. And then this will be October. So we have decided to have more time for our sponsors supporting us to have in October. That is a beautiful month in Rome. So let me say that I really let you know that we are waiting, all of you and other people in Rome next year. I hope you enjoyed the great network meeting, and I hope you enjoyed the quarter side. And now let's enjoy the dinner, but most importantly, enjoy the football match tomorrow. Okay? Thank you again to everyone.